So everyone, very good evening to all of you. Yes, so now I think we are live. Yes, everyone, very good evening to all of you. I hope all of you are doing great. And I hope, yes, you are on the right track of exam preparation. Yes, very good evening, all of you. Okay, yes. Yes, all of you. So we are going to start with first of all, we are going to learn about the general surgery first of all. So how much we are going to score? See, first of all, I will be teaching it I will be teaching you today, first of all, basic managements in surgery. Basic managements in surgery, we are going to learn IV fluids, we are going to learn all surgical instruments, suturing, knotting, all the materials we are using for suture, okay? OT techniques, OT ethics, OT etiquettes, right? OT etiquettes we are going to learn. We are going to learn about nutrition today, nutrition also. So when we will be learning about nutrition, yes, shock topic will also be there. Shock we are going to learn. And yes, we are going to learn all road traffic accidents. So basically we will be learning about all accidents, all the traumas we are going to learn. Yes, and after that, yes, we are going to learn burns also today, burns. And then we will be learning about hernia today, hernia. And we have to learn about a surgical aspect of the thyroid. Yes, so like all these we are going to learn today. So next class will be on this will be on the 28th of January. So where we will be learning about GIT, urosurgery and breast. GIT, urosurgery and breast, and remaining small topics we are going to learn on 28th. So let's start the session with the general aspect of surgery. See, first of all, we should understand how they are going to frame the question. Overall, minimum number of questions in surgery we should be expecting. Minimum number of questions will be 30. But approximately 15 to 20 questions will be related to patient management only. What is the see how they are going to frame the question. What is the next line of management? What is the next line of, they are going to give a scenario of the patient. Patient got admitted after accident, low BP, after that high heart rate. What is the next line of management, like that? So basically patient management question will be related to approximately 15 to 20 questions we should be expecting, like patient management. You have to take a decision what is best for the patient, that we are going to learn. So we should have that kind of clinical approach. And minimum number of questions, like I expect approximately 10 questions will be related to fact-based questions, where you have to diagnose these surgical diseases. This my point is clear to everyone. So first of all, 28th January, 28th December, okay, 28th December, not January, I'm sorry. Okay, fine, 20th December only, right? Our exam is on 17th Jan, right? Chalo, fine. All right. Okay, fine. See here, how much I'm going to teach you. Minimum I can give you guarantee of 18 to 20 marks. Minimum I'm saying 18 to 20 marks, but you can score more than 20 as well. Okay, let's start with the basics of general surgery. First of all, first point, I'm starting with a question. All of you, please, first of all, when we are going to start with this question, first of all, please understand that student life is almost over. Now, when we are going to learn surgery, we have to think each and everything in a clinical manner, like a clinician only, like a surgeon only. Let's start with this question. All of you, read this question and what is the best answer as per your clinical approach. Read this question and can you answer me now? A 45-year-old man was brought to casualty after road traffic accident, and his clinical presentation included bleeding from lacerations around the legs and suspected femur fracture. 45-year-old man, suspected femur fracture. Femur fracture will be the emergency, obviously. He was screaming during admission. On examination, BP was low, 94/62, and the pulse rate was high, 110 and per minute, right? Junior doctor has applied pressure bandage over the lacerating wounds. Which of the following is the next line of management? Basically, you are working in emergency department. See this question and try to answer here. I can see that most of you are answering B only. B, can you answer me? Some of you are saying C also. Yes. There will be confusion for sure, but no problem at all. Now we are going to learn how to approach a patient. How to approach a patient. This much point is clear to everyone? Right. Chalo. So some of you are saying, okay, yes, first of all, what is the next line of management? You are saying what? Airway fixation. Some of you are writing. Some, yeah, and most of you are saying C. Most of you are saying C. Now, let's learn this topic. This question is related to the management of any trauma. Management of any trauma. Let's learn this in detail. We will get back to question again. First of all, yes. First of all, meaning of the emergency surgery and the elective surgery. Where we can plan, where we can schedule a surgery. Like when I talk about the plastic surgeries, or even if I talk about the gallstone surgeries, even if I talk about the tonsillectomy and all. So many surgeries are there where we can plan that after 5 days I can operate. After 7 days I can operate. After 1 month I can operate. Where I have enough time, that is called the elective surgery, right? Okay, where I have enough time, right? That is called the elective surgery. Here I can correlate with one BNS forensic. Batao, in emergency, suppose if there was a destitute patient, can you answer me? If there was a destitute patient means lawaris patient, means who does not have any family member. Basically, suppose if I give the example that the police has brought a patient from roadside after road traffic accident. Okay, so basically he will be called as a case of destitute patient who does not have any attendant, who does not have any family member. Okay, lawaris patient. Okay, in a case of like in a case of the emergency, do you think I need to take the consent? Right? Means suppose if there is no any family member, suppose if the patient is not in that condition to give the consent. So my question to you is that in a case of the emergency, see, even without consent, doctor can operate as per which BNS number? As per BNS number 30. As per BNS number 30, doctor can operate a patient without consent in emergency. Chalo, this much point is clear to everyone. Now, whenever there will be any road traffic accident case, any trauma, any emergency, remember here, what is the sequence now? Sequence, see, sequence we have learned, no, A, B, C, D, E. A, B, C, D, E. Whenever there will be patient in the emergency after accident, yes, first of all, we have to fix airway, breathing, circulation, disability assessment, and exposure, right? This is what we have learned. But now, as per one recent update in ATLS, before airway, we have to give priority to the bleeding here. We have to give the priority to the bleeding here. Basically, remember here, if there will be massive bleeding, if there will be exsanguinating hemorrhage, massive bleeding, suppose after accident, if there was rupture of like rupture of femoral artery, major blood vessel, if there'll be massive bleeding, no, remember here at that time, before airway, our first priority is that we have to stop bleeding. We have to stop bleeding. Please remember, this is update. This is update before airway. In this situation, you can understand that bleeding kills faster than hypoxia. Remember this. Okay, fine. So now, first step in a case of road traffic accident case or in a case of the trauma management, remember here, before A, B, C, D, E, like a small x is added. Now, a small x means what? Stop bleeding first. Stop bleeding first. This one point is clear to everyone. Stop bleeding first. After that, airway fixation, then you have to see for the breathing. Now, the question is that if I ask you one question, suppose after accident, if a patient is brought to emergency department and patient is shouting, patient is screaming, my question to you is that, is his airway clear or not? Please write down in chat box. When patient is shouting, when patient is screaming, his airway is clear or not? Answer me. See, all of you, please keep on interacting. Bolo. When patient is shouting, it means what? His airway is clear. His airway is clear. This much point is clear to everyone. His airway is clear. Remember here, in this question, I have mentioned here, no? Remember here, patient was screaming. It means what? His airway was clear. His airway was clear. After that, there was the pressure bandage also. It was already kept here. So here, out of these four, now can you answer me? What is the best answer here? What is the next line of management here? Yes, we have to look for what? Maintaining circulation. For that, I am going to fix 2 IV cannulas. And yes, like in the beginning, no, like if there is an emergency condition where we are planning to operate the case, we have to send blood sample. At the same time, whenever we are going to fix a cannula, no, we are going to take blood sample out so that we can send for basic blood investigation like CBC, LFT, KFT. Can you answer me? What are the routine investigations we are sending for? Can you answer me? All of you, can you write down? See, all of you, please write down in chat box. What are the routine investigations? What are the routine blood investigations we are sending in emergency or before any surgery? Can you answer me, all of you? Please write down in chat box. Blood investigations are very, very important, no? We have to send blood samples, no? Can you answer me? Which blood tests are mandatory? Which blood test? Bolo. Yes, please keep in mind. Number 1 is always CBC. We have to do, yes, CBC, the complete blood count, where especially we have to look for hemoglobin. And hemoglobin, after looking the status of hemoglobin, we can take a decision to do blood transfusion or not. Yes, no, blood transfusion or not. Hemoglobin, basically CBC means what? You have to do the complete blood count, where WBC, RBC, platelet count, hemoglobin count, everything we are going to see. And yes, LFT, liver function test, KFT, right? See, either you can say KFT or what? RFT, renal function test you can say, or kidney function test. Serum electrolyte like sodium and potassium, mandatory here. Okay, now sugar level, right? No, sugar level, right? Sugar, very easy to understand, sugar level. Okay, right? After that, yes. See, with this CBC, yes, you have to send for what? Blood grouping and blood matching also. Blood grouping and blood matching also, right? Now, so that if there will be need of the blood transfusion, yes, very, very easy to understand. All these points are clear to everyone. After that, we have to send for, at the same time, we have to send this sample for viral markers also. Can you answer me which viral marker I'm talking about? Very, very commonly used, yes, right? Yes, HIV, right? Hepatitis B virus and hepatitis C virus. We have to do viral marker testing also, because we don't know whether patient is positive for HIV, hepatitis B or C. Yes, we have to do all these, yes. So all these are what? See, all these are what? Yes, basic blood routine test, right? No, routine test, blood investigation. After that, if we have to plan the patient for surgery, yes, then ECG will be must, right? No, ECG, and after that we have to do the X-ray for the chest also. Very easy to understand. Like at the same time, send the sample for urine test also, right? All these points are clear to everyone. So in this question now, I feel you have the basic idea that why I have marked here option number C. This much point is clear to everyone. I hope you are able to understand this. Yes, yes, you are able to understand this. Yes, with this, yes, one more test we should add here. Okay, blood clotting profile also, yes. Okay, blood clotting profile like PT, like the bleeding time, PT INR, APTT, all these very easy to understand, right? Yes, yes, I can see that most of you are able to answer the question. Very easy to understand. Yes. Now, so like remember here ki A, B, C, D, E, but what is the update here? Remember here we have to prioritize, right, to stop bleeding, to stop massive bleeding. Now, this is here, see, airway, breathing, circulation, disability, exposure. If you can understand this, you can solve so many cases. You can solve so many cases here. You can handle so many patients. So first of all, we have to look for airway. We have to look for airway. My question is that suppose if you were walking on the roadside, you could see that after a road traffic accident, a patient was lying on the roadside like this, right? No, like this. Okay, fine. Even in the movies also you would have seen, no, like the doctor or the person who was actually walking from there, no. So like if the patient looks very, very unconscious, so first of all, he's asking the patient, hey, what is your name? Hey, what is your name? If patient is saying, my name, okay, if he can speak air basically, but if he's not able to speak out, no, airway obstruction is there. Airway obstruction is there. So whenever there will be airway obstruction, yes, head tilt and you have to lift the chin, right? No, head tilt and you have to lift the chin. Easy to understand. Head tilt and chin lift. And after that, one more is there that is called as jaw thrust. Basically, see, what I'm saying here, no, see, with the head tilt and chin lift, we are securing the airway passage. I'm making clear. Even after that, if there is obstruction, patient is not able to speak, or if you can see if there is some kind of foreign particle inside, no, yes, you have to remove that out, right? No, even after that, if there is no clearance, no, like even patient is not able to speak out, you have to stand at the back side of the patient. After that, from the back side, you are going to apply a pressure over the jaw at the angle of jaw here. You are going to apply a pressure here. This is called as jaw thrust. This is called as the jaw thrust. You can overall, whenever you are going to apply a pressure here, there will be severe pain. Even patient had a laryngospasm, the patient will shout, something like that. After that, there will be airway clearance. So head tilt and chin lift and then jaw thrust. These are the methods to secure airway. This much point is clear. And if you are going to shift the patient to hospital, yes, finally you are going to fix what? Definitive airway only. You are going to intubate the patient. Airway clearance. Now, sometimes you might be having confusion in this cervical spine protection. My one question to you, first of all, suppose if there is a case of history of fall from 5th floor and patient is lying on the roadside, patient neck is like this, right? So like at the time of management, are you going to do like this? First of all, are you going to do like this? Answer me yes or no. Head aise tha pehle, are you going to do like this? Answer me yes or no. Obviously no. Obviously no. You want to kya karna aise karke. See, like in this position, a patient is like this. No, it could be possible that there can be the cervical bone fracture. If you are going to turn like this, no. See, it can damage a spinal cord and your patient can become fully paralyzed also. Basically, ये मोहल्ला बचाने चले थे, शहर जला दिया. Very easy to understand. Remember here, so cervical spine fixation is very, very important here. Remember here, cervical spine protection. You would have seen, no, like there is a, like even in the movies also, even in the hospital, you would have seen there is a pink color. There will be a Philadelphia collar, right? Philadelphia collar. Very easy to understand. Right? Very easy to understand? Yes. Remember here. So basically, cervical spine fixation is very, very important. And this is also the component of airway only. Next, breathing movement. How you are going to see if there is some problem in the breathing now. Like suppose if a patient is lying on the roadside and you have to stand at the back, like you have to stand at the back of the shoulder here. So you also have to sit and you have to look for the movement of the chest, My question to you is that, see, remember, overall, whenever you are going to breathe in, like at that time there will be expansion of chest. Whenever you are going to breathe out, like at that time there will be relaxation. ये normal है. This is normal breathing only, no? But suppose after a building collapse, if you have recovered a body from inside, right now after that, when he is breathing in, there is indrawing of chest. When he is breathing out, there is expansion of chest. This is opposite respiration. No? Can you answer me? Where do you see this kind of opposite respiration, which is also called as paradoxical respiration? Can you answer me? Where do you see paradoxical respiration? Can you answer me? Where do you see the paradoxical respiration? Yes, I'm sure you are able to recall that. Yes, this we see when there will be, yes, this is seen in flail chest. This is seen in flail chest. Overall, whenever there will be fracture of minimum 2 ribs, minimum at 2 points, this is an emergency. So abnormal breathing, abnormal ventilation you can see in flail chest. Even if there will be tension, pneumothorax, yes, there can be abnormal breathing. Yes, so after seeing the movement of the chest, you can understand here breathing problem. Now circulation problem means what? Blood circulation. I am talking about blood circulation only. So can you answer me? How do you understand that? Like overall, can you understand? Yes, I can see your charts. All of you, I can see your charts. So can you answer me here? How do you understand that patient is having some difficulty in circulation, or there are some problems in circulation? Can you answer me? How do you understand that circulation problem is going inside the body? Basically, circulation means blood circulation only. Okay. So now see here, whenever any patient will be coming to the hospital, why doctor is saying like, why doctor is asking the nurse, sister ji, BP and pulse rate check karo, BP and pulse rate. Remember here, blood pressure. First of all, you have to check blood pressure. Blood pressure means what? The pressure exerted by blood over arterial wall. Blood pressure, and you have to see the pulse rate also. Pulse rate means what? Heart rate. With circulation, you are going to understand whether heart is functioning normally or not, or there is normal supply of blood to the each and every tissues of the body or not. This one point is clear to everyone? Okay, fine. So remember, so circulation we can check with the help of BP and pulse rate. BP and pulse rate. Can you answer me now? Suppose if I have got a patient after road traffic accident, patient BP was 90/60. This is normal or abnormal? Normal or abnormal? Can you answer me? Bolo. Normal or abnormal? Obviously, this is what? Hypotension only. No, this is only what? Hypotension only. When a low BP after road traffic accident, if there will be massive blood loss, now okay, yes, there will be low BP now, low blood pressure, right? After that, you can say what? There will be low cardiac output, and to counter that, heart has to pump more, so heart rate will be increasing. So I can say here, when there is a low BP, to counter this, heart rate will be increasing, low BP and tachycardia. It means what? My patient is going into shock. Shock means what? Inadequate perfusion. Shock means what? Inadequate perfusion to body tissues. Inadequate perfusion means lack of blood supply to the tissues. Okay, fine. So it means I can understand here that patient is going into shock. Patient is having lack of blood supply, and this is an emergency. Remember here how to manage shock. Yes, as soon as possible, you have to start giving what? IV fluid, no, intravenous fluid, 1 liter of normal saline, whatever you have. This much point is clear to everyone. So I can understand here that with the help of airway, breathing and circulation, I am managing circulation with what? With fluid management. Very easy to understand. This much point is clear to everyone. Yes. All right. I will be teaching you shock in detail. First of all, we are learning ABCD only. D for disability assessment. D for disability assessment means what? First of all, I am going to assess, I am going to examine the consciousness. I am going to examine the consciousness. Basically, we are going to perform neurological examination. So how should I check the consciousness in my patient? Is there any scoring system? Is there any scale? Yes, you would have learned in forensic also, or somewhere you would have learned about GCS score. Can you answer me? What is GCS score? Glasgow Coma Scale. Glasgow Coma Scale. Remember here, Glasgow Coma Scale. This is going to check. This is going to check the consciousness in your patient. So remember here, GCS is being performed. GCS is being performed during disability assessment. Disability assessment. E for exposure and what? Maintain hygiene around the environment here. So exposure means what? You are going to remove all the clothes of the patient. Okay, you are going to undress the patient, but at the same time you should also be careful why you are removing all the cloth, so that you can check if there will be more damages around the body. But at the same time, you have to take care of hypothermia as soon as possible. You have to finish the examination. After that, you are going to cover with the blanket. You have to maintain, remember, you have to prevent hypothermia. All these points are clear to everyone. So now, with the help of A, B, C, D, E, we can easily understand. First of all, maintain airway, breathing, circulation, disability assessment. Then you have to expose the body of the patient. But can you answer me, what is the most primary thing now as per ATLS protocol? As per ATLS protocol, can you answer me, what is the first thing to do now? Like a small X, you have to prevent massive bleeding, exsanguinating hemorrhage. This much point is clear to everyone. Yes, yes, we have learned this much part. Can you answer me what is being performed here now? All of you, after seeing the photo, can you answer me what is being performed? What is being performed? Yes, I can see that most of you are able to answer the question here. Can you answer me? Bolo, what is being performed? Yes, this is called as this is called as jaw thrust. This is called as jaw thrust. Very good. And what about this one? Yes, after seeing the photo, you can easily understand here, this is called as what? Head tilt and lifting up the chin, and this is called as jaw thrust to secure airway, to secure airway. Okay, now, right, see here. Now, very, very important topic. We are going to learn a very, very important topic. Yes, whenever there will be trauma, whenever there will be trauma, yes, you have to fix 2 wide bore cannula. 2 wide bore cannula. Wide bore cannula. Basically, इसी को हम लोग बोलते हैं wind farm, right? No, so this is what IV line. I have to secure IV line means what? Like intravenous line. I am going to fix one intravenous line in the blood vessel so that I can infuse fluid, so that I can perform fluid resuscitation. I can take blood sampling also. I can take blood sample also. Even if I have to give antibiotics or the drugs, yes, like intravenous, I can give with the help of these IV cannula. So, how to memorize size of these cannulas? Size, okay? Repeatedly asked question. Remember here, like in hospital practice, I used to memorize only with the help of one color, green color. 18 gauge, 18 gauge, 18 gauge. I used to remember only green color, like 18 gauge. After that, you have to add or you have to reduce size 2 actually, size 2. Like this, please remember here. This is 18 gauge. And see the pink color, this is actually, okay, 20 gauge. And the blue color, size will be 22. Yellow, size will be 24. And see the purple color, size will be 26 gauge. Okay, 26 gauge. What about gray color? Gray color, remember here, you have to minus 2. Okay, 16 gauge. 16 gauge. And what about orange color? 14 gauge. 14 gauge. Remember here, when I talk about this gauge, actually, remember here, this gauge is inversely proportional to the diameter of the cannula. This is inversely proportional to the flow rate of the cannula. Lower the gauge, bigger the diameter, and more flow rate will be there. More flow rate will be there. So maximum flow rate you can see from orange color. Maximum flow rate. If you have to do massive blood transfusion, if you have to do massive blood transfusion or massive fluid resuscitation, remember here, if you have to do massive or very, very fast, if you have to do fluid resuscitation, or if you have to do fast blood transfusion, number one, remember here, number one, you should be choosing orange color. After that, you have to choose gray color. But very frequently, if you ask me, like in the general ward, in emergency department, most commonly used cannula, maybe after any accident, if a patient is coming to your hospital, at that time, very frequently available and most commonly used is what? Green color cannula only, green color. So remember here, if there is an adult, for the general purpose also, for the fluid resuscitation also, for the blood transfusion, or if patient is admitted in hospital for 1 day, for 2 days, or only for a few days, okay, see, the green cannula will be enough. Green cannula will be enough, okay? But for the massive, orange or gray color. Suppose if I see any old patient, where if you see the blood vessel, no, there will be the tortuosity of the blood vessel. After green, a smaller size will be pink color. So for the old patient, or if patient is admitted only for 1 day, or if patient had, like severe dehydration due to vomiting, or, loose motions and all, okay, that time also we can use the pink color. But what about blue color? Blue color we are using for adolescent age. Suppose if there is 11-year-old boy, 11, 12, 13, like younger boys, there's 7, 8, 9, 10. 7, 8, 9, 10, 11, 12. Like for that case, we can use blue color. But yellow is for pediatric age group. And smallest size for neonate, we are using purple color. So remember here, central point, how I used to memorize. I used to memorize only with the green color. After that, when I have to decrease the size here. So first green, and then pink, then blue, then yellow, then last will be purple color. But bigger size here, see, after green, there will be a gray color and orange color. I'm telling you, this you have to memorize. Remember here, see, the color coding is very, very important. But now there is a new cannula. Please highlight, please write down. Okay, like easily it is not available everywhere, but in ICU, especially in like intensive care unit, you can see one new cannula, white color cannula also. There is a new cannula, white color cannula, white color. Okay, white we are see here, size is 17 gauge. Please highlight this white color. Please highlight this, right? White 17 gauge. Okay, like everywhere it is not available, but since like it is important, please write down here. Yellow. Now flow rate you have to memorize, like especially for green color, gray and see orange, gray and green. Maximum flow rate is of orange color 240 per minute. But remember here, this can vary up to the company also, like the manufacturing company here. Like see, some company will be having up to 270, like see per minute also. Like even for the gray, you can go up to 236 also. Right now. So remember here, but what I have mentioned here, this is the standard flow rate. All these points are clear to everyone. Remember it, very, very important topic we have learned. Size of the cannula, and see different color we can learn here. All these points are clear to everyone, right? So can you answer me here? See, out of ATLS protocol, can you answer me? GCS will be performed during. All of you, please answer me in chat box. GCS, Glasgow Coma Scale, right? A scoring system will be performed during airway, breathing, circulation, disability, or during exposure. Answer me, all of you. Yes, okay, during disability assessment. During disability assessment. Can you answer me what is the first priority should be given now? As per new ATLS protocol, can you answer me what is the first priority? To stop massive bleeding or to fix airway? At this point, you have to keep in mind bleeding kills faster than hypoxia. So first of all, we have to stop massive bleeding. Okay, chalo. All right. Now, one more is there, very, very important topic here. This blood sample collection tube. Blood sample collection tube. I'm sure you would have seen this kind of blood sample collection tube. I think this photo is not given in your notes, so please write down. All of you, please write down here, where do we use, for what purpose we are using, for what purpose we are using these blood sample collection tube. Remember here, red color, purple color, gray color. Okay, all of you, please write down. All of you, please write down here. I would say, first of all, I would say red color tube. All of you, please write down red color blood sample collection tube. This is called as the plain tube. This is called as, so basically I'm talking about this one, red color, okay. Remember here, red color is called the plain tube, where there will be no ingredient, and we are using this for very commonly used LFT, KFT, liver function test, and the kidney function test. All these you have to do during your internship. Your internship work will become your question. Okay, after that we can do serology test also. Serology test also. Remember here, serology test, very, very important. Like you can use for what? Like hepatitis B, surface antigen also, HIV also, right? Surface antigen. After that, next most important will be the purple color. Next most important will be the purple color, where EDTA is there. EDTA is there, purple color. Every time being an intern, no, most of the time you will be having in your hand either red color or purple color. Most of the time red and purple every day on daily basis. Like suppose if you will be posted in the ward, right now, so all admitted patient, most of the patients, so like in morning time you have to repeat blood counts and all, right? So see, the purple color especially we are using for what? Remember, a purple we are using for CBC, right? Basically for the complete blood count, CBC, with ESR also, yes, you can see, okay, with ESR. Very easy to understand, right? Okay, fine. Like at the same time, remember here, even for HbA1c also, HbA1c, we are using purple color. This much point is clear to everyone. Next important will be, see, remember here, next important will be, and next important color, please remember here, next important color will be, remember, gray color. Next important will be gray color, right? So especially we are using for sugar. So what are the components of the gray color here? See, remember, like in the gray color, one is a sodium fluoride. Which is anti-glycolytic agent, and there will be sodium citrate or potassium oxalate also. Okay, so that will be having what? Anti-clotting agent, right? Now, so that will be having what? Anti-clotting property. So this we are using especially for sugar. Even for lactate also, lactate will be increased. So can you answer me, like in which condition lactate will be increased? Yes, like if there will be sepsis and a septicemia will be there, if there will be hypoperfusion, lactate will be elevated, lactate will be there. This one point is clear to everyone, lactate will be there. So we have learned about gray color. See, sodium fluoride, the question is that, like, even in the biochemistry you would have learned this case here. No, you would have learned why sodium fluoride is added. Remember, yes, sodium fluoride will be blocking which enzyme? Can you answer me? This will be blocking which enzyme? Biochemistry knowledge, enolase enzyme. This will be blocking enolase enzyme. Why? Okay, fine. I will give you example. Suppose if this is my clinic here, I have a patient of diabetes mellitus here, I have to check his sugar level. I have called a lab technician here to take the blood sample here, but his lab is half an hour far from here. Right now, so like suppose if he is going to take a red color tube, now if he is going to collect blood sample in the red color tube, no, when after half an hour when he will be reaching his lab, no, by that time there can be glycolysis. Right now, see, glucose will be converted into pyruvate and further oxidation will be there, right? So after half an hour after reaching his lab, no, see, exact sugar you will not be able to calculate over there. So that's why I don't want glycolysis to happen here. So second last enzyme of the glycolysis cycle, that is enolase. Sodium fluoride is going to block this enzyme so that there should be no complete glycolysis. Simple, very easy to understand, so that there should be no oxidation, and whatever sugar level was here, same thing will be there even after reaching the lab. So remember, sodium fluoride, very, very important component here, anti-glycolytic agent, anti-glycolytic agent. All these points are clear to everyone? Very easy to understand, right? Now, see here, and now what about a sky blue color? What about a sky blue color? What about a sky blue color? Sky blue, right? A sky blue, please remember here, like here also there will be sodium citrate, potassium oxalate, anti-clotting agent. This we are using for blood clotting profile. This we are using for blood clotting profile. Like if I have to check PT, like if I have to check the prothrombin time, if I have to check fibrinogen, right? No, fibrinogen, right? Even if I have to check for INR, right? INR, if I have to check for INR, right? No, INR we are using, remember here. I hope all these points are clear to everyone. Yes, I can see that most of you are able to answer it. Yes, most of you are able to answer it. INR, suppose if the patient was already on the warfarin, right? Now, warfarin patient was, so yes, INR. And even if I have to check a D-dimer, even if I have to check a D-dimer, yes, I will be using what? Yes, D-dimer ke liye bhi kya karoge aap? Sky blue color. I think this was the question in last FMGE exam only. I hope all these points are clear to everyone. All these points are clear? Sky blue color we have learned. Now, what about yellow color? What about yellow color? What about yellow color tube? Yellow color tube, please remember here, this we are using especially for electrolytes. This we are using especially for electrolytes, like electrolytes, and even for, yes, remember here, like electrolytes, like especially for sodium, potassium, sodium, potassium. Even if I have to check urea, and even if I have to see specifically creatinine, right? No, creatinine. And especially, see, remember, this can be used for okay, for the liver profile also, right? Now, for the liver profile also, for lipid profile also, for lipid, even for thyroid also, if I have to see the thyroid function test, yes. Okay, even for C-reactive protein also, if I have to see only magnesium, yes, I can use yellow color, okay, yellow color, very easy to understand. And if I have to see even, even if I have to check bone profile, bone profile, right? All these points are clear to everyone. Even for the cardiac enzymes, even for the cardiac enzyme, if I have to check the troponin T, actually, if I have to see the level of the troponin T, I hope. See, remember here, I have mentioned here red color, purple color, gray color, sky blue color, and what? Yellow color. Yes. So basically, see, actually, okay, and what about the green color? What about green color? You might be asking, what about green color? Remember here, when I talk about green color, no, all of you please write down here, when I talk about green color, no, green color will be having like heparin also. Like this will be having heparin. So heparin will be present here. So yes, this we are using especially for if I have to see the level of ammonia. Right now, right? Very easy to understand. Even if I have to see the level of the electrolytes, I can use green color. And one more color, please remember here, what about the pink color? Especially if I have to use only pink color, then I can use for blood grouping, blood matching. Remember here, for blood grouping, for blood matching, we can use the purple color also, purple, okay, same purple color. See, there are so many tubes, but most commonly used in hospital, red, purple, gray and sky blue. These four are frequently used almost in every hospital. You can see all these tubes. I hope these points are clear to everyone. So can you answer me, all of you, can you write down in chat box how much is the size of green cannula? Can you answer me how much is the size of green cannula, all of you? I have mentioned here, what about the, like, see, for sugar, yes, देखो इसमें मैंने मेंशन किया था ना, for sugar gray color, for sugar gray color, for sugar, okay, 18 gauge is green color. So can you answer me which one is the like the smallest one, smallest size? How much was the smallest size we have learned? See, all sizes I have taught you from 14 gauge to 26 gauge, right? The smallest was 26, purple color for newborn, yellow was for the pediatric age group, like size was 24. What is the new color? Can you answer me which cannula is having 17 gauge? All of you, can you answer me 17 gauge? Bolo 17 gauge kaun sa tha? New aa gaya, everywhere you cannot find, but especially in the ICU you can get white color. Yes, white color. All these points are clear to everyone, very easy to understand. We have learned basic things only. Now, what can be the complication of IV cannulation? See, remember here, like when I remember when I inserted IV cannula for the first time, as per my experience. Okay, so when I inserted it, no, first of all, yes, like you are going to apply tight tourniquet here so that you can make a visible vein over here. So wherever there is the straight vein, you have to insert the cannula like this. If there will be the bifurcation, please don't, and see the, like if there will be the bifurcation, right, see here over the veins, if you can see any bifurcation, please don't use that vein. Wherever there is a straight vein, use that vein. That will be best, actually, that will be best. So when I remember for the first time, when I inserted the cannula, see inside there will be a needle type, no, metallic, jo usko bolte stellate. So when you are going to inject, now when I inject, so when I inserted, no, after that, see, after that I could see swelling over there. Can you answer me what was that? See, actually that was my mistake. When I inserted, first time when I inserted the cannula, no, after that I could see like 1 centimeter or 2 centimeter there was swelling over there, swelling over that area. Yeah, that was actually what? Hematoma collection, blood collection there. Basically what I did here, no, because see, out of, you know, like out of zero experience, when I inserted, no, I ruptured blood vessel over there. So because of that, yes, there can be blood collection over the hematoma collection, right? After that, you should not be worried. Okay, that will go away by itself, no problem at all. Okay, fine. No. So what kind of question they are asking? Okay, what is the most common complication of IV cannulation? IV cannulation. Remember here, whenever you are going to insert a cannula, no, yes, this can damage the wall of the blood vessel. After that, there can be inflammation, there can be blood clotting also. Yes, remember here. So this is called as superficial thrombophlebitis. Superficial thrombophlebitis, inflammation of blood vessel over, you can see here. But after that, you don't have to worry, actually. See, remember here, like I did for the first time, and after that I could see that kind of swelling over there. So I was very nervous. Oh my god, what I did. After that, my senior told me, don't worry, ye hota hai, normal hai. But after that, you can use one ointment is there in hospital. If there will be bruises, it will be contusion, like bluish color, no. So you can use one ointment in the market that is called that is known as the thrombophobe. Okay, that will go away. Okay, that will go away. So remember here, most common complication of IV cannulation, one-liner question, that is superficial thrombophlebitis. Now, remember, whenever you are getting a serious case of the trauma, yes, for the adults, first of all, fix it, two green cannulas. But suppose if there will be massive blood loss, patient can go into shock, and see, all blood vessels will be fully collapsed. And so when blood vessels will be fully collapsed, no, you will not be able to insert a cannula there. So you will not be able to get, you know, like actually a perfect vein over there. Like at that time, in emergency, we can fix a central line also. So like central line means what? When I talk about these blood vessels, no, these blood vessels here, these are called the Yeah, all these are called the peripheral lines. But central line is central blood vessel, like if I'm going to like insert a catheter in what internal jugular vein here, subclavian vein, and like the femoral vein, central line, major blood vessel made directly here. So remember, in a case of the trauma, first of all, you fix either a 2 green color cannula, wide bore cannula. This is called as here a wide bore cannula, like especially orange, gray, and green, wide bore cannula. If you are not able to do that, and if patient is in the need of massive fluid resuscitation, please fix one central line as soon as possible. And very easy to insert is what? Jugular vein. Actually, jugular vein means like in between the heads of the sternocleidomastoid muscle. If you are going to insert, you will be exactly into the what? Internal jugular vein here. But suppose if there is a 4-year-old boy 5-year-old boy, 5-year-old boy, right now, where you cannot detect, where you cannot identify the blood vessels. So normally all blood vessels are fully collapsed. So what to do in that situation when a 4-year-old boy, 5-year-old boy is in the dire need of fluid resuscitation? What will you do then? What is the next option you have? At last, you can inject the fluid directly inside the tibial bone, directly inside the vein. Remember here. So then you can do what? Okay, at that time you can choose interosseous route in tibial bone. Interosseous route in tibial bone. All these points are clear to everyone? Yes, I can see that you are able to understand all these points. Now, suppose my patient was going into shock. Basically, my patient had some problem in blood circulation, or lack of blood supply was there. There was insufficient perfusion to the organs and tissues. After that, I have given bolus of 1 liter of normal saline. 1 liter of normal saline. But can you answer me, what is the best parameter to check fluid resuscitation? What is the best parameter to check whether my patient is receiving adequate amount of fluid from outside? Yes or no? Can you answer me? What is the best parameter to check fluid resuscitation? All of you, please write down in chat box. See, I'm teaching the basic things only. Slowly we are going to learn. Slowly we are going to dive into the depth of the surgery. But first of all, understand basic management. Then only you can understand the big part of surgery, right? Yes. Best parameter to check fluid resuscitation is urine output. So how will you understand how much urine output is there? Are you going to ask the patient to pass the urine every minute? Pass the urine, and you are going to collect in a jug? You are going to collect in a like in a vial or in a glass? Obviously no. So what will you do then? To check urine output, what will you do? Yes, we are going to fix Foley's catheter. We are going to fix Foley's catheter in the urethra. Foley's catheter. Remember here, Foley's catheter we are going to fix here. Remember, a different color Foley's are here. Now they are asking this question also. Like which Foley's we are going to use, which Foley's catheter we are going to use for females, for babies, for adult male, right? So remember here, you can see this is green color, this is green color, this is black color, and this is, I would say this is orange color, and this is last one is a red color. So remember here, green color is for girls. Green is for girls. Black is for babies. Black is for babies. Orange is for males. For males, orange color. Remember, you can see here that in all these three, how many lumens are there? There are only, see here, overall how many lumens are there? There are only 2 lumens. Right now there are only 2 lumens. Remember here, there are only 2 lumens, but you can see red one is different. Red one is different. How many entry points are there? How many lumens are there? In red one, there are 3 lumens. There are 3 lumens. So red color, remember here, this we are using especially for blood irrigation. for blood irrigation. Red color, blood. Remember here, for blood irrigation, after any surgery, are you able to recall about BPH, benign prostatic hyperplasia? What is the surgery we perform over there? TURP. TURP is what? Which I will be teaching you in urology part here. TURP, this is the transurethral resection of prostate. So for the blood irrigation, you can use red color. This was last time, or I think last time FMG question only. I think, see, from Foley's catheter, no, repeatedly asked question in INICT also, even NEET PG also, FMG also. Okay, all these points are clear to everyone. Remember here, all these are double lumens only, but red color will be having one extra lumen for blood irrigation. Blood irrigation. Now the question is that, see, remember here, size, yes, you have to remember here, size you have to memorize here. See this one, black babies, like size up to 10 French. Okay, after that, for female, 14 French. For male, 16 French, right? 16 French. Red will be bigger, so 18 French. So what is a French here? French means actually what? Actually, French denotes outer diameter here. So remember, 1 millimeter is equal to 3 French. Okay, fine. All these points are clear to everyone. Now, the question is that which fluid we are using to inflate the balloon. When you look at here, you can see here at the tip, there is a balloon also. There is a balloon also. You have to inflate the balloon. Basically, this is bladder. And this is urethra. This is bladder and this is urethra. Here only you are going to see, like here only you are going to see, there will be the prostate part here, right? So, like, see how to fix Foley's catheter. First of all, you have to wear the gloves. And with betadine, you are going to clean urethral orifice. Urethral opening, you have to clean with betadine so that you are not going to insert infection. You are not going to carry infection along with Foley's catheter. Foley's you are going to insert directly inside the urethra. Okay, directly inside into the urethra. Okay, fine. So remember here, first of all, this will be actually normal. This will be deflated only. This will be normal only. So when we are going to insert Foley's here, no, after reaching inside bladder, remember here, now we have to fix it inside. Every time you are not going to hold it. No, you cannot ask the patient to hold it like this. Obviously, no. Obviously, no. And obviously, no. So how to fix it inside the bladder? Then I have to inject a fluid here. I have to inject a fluid here. Normally in hospital, very commonly we are injecting normal saline. Very commonly we are injecting normal saline to inflate the balloon. But please remember, this is wrong. This is wrong. It is not the fluid of choice. We should not be using normal saline, because if patient will be admitted only for 1 day or 2 days, no problem at all. But if patient will be admitted for longer duration, now there, remember here, normal saline will be having sodium chloride. This can form crystals. Right now, this can forms the crystals, and after formation of the crystals, no, even if you want to take out the fluid, no, very after that there will be difficulty in deflation. There can be clotting, there can be obstruction. So you can say now Foley's catheter, now like see here, even you cannot detach it like this. No, you can rupture urethra, you can rupture urethra, no, you can damage it, right? So remember here, that's why fluid of choice is distilled water. Fluid of choice is distilled water for Foley's catheterization, because if there will be retained Foley's, no, then you will have to do what? Ultrasound guided, you have to puncture the balloon. Now this can become a surgical procedure then. For simple thing, you are not going to hurt the patient, right? So remember here, normal saline should not be used for Foley's catheterization for inflammation, for inflation of the balloon. What is the fluid of choice? Distilled water. Distilled water. This much point is clear to everyone right here. This much point is clear to everyone. So when I learned Foley's catheterization for the first time, no, I learned from a ward boy. First time I joined a hospital in New Delhi. First time, so I joined in emergency department here. So like actually like the department was overcrowded. Okay, like so many patients were there. So one patient came there, he was having severe abdominal pain because he was not able to pass urine. He was not able to pass urine normally. So he was having lower abdominal pain. So my senior asked me, Nadeem, go and fix the Foley's catheter. So I was somewhat nervous. I asked him, sir, can you show me once? After that, अरे यार, should I handle MI case or your police कहते हैं, hey रामू भाई सर को सिखा दे जा करके. I know Ramu bhai was the ward boy. So like he asked me, sir, please take police catheter bag. First of all, you take it. And a police catheter bag, वो होगा छोटा सा वो, in a packet it will be there. Okay, sir, you take this, you wear gloves, right? After that, you have to clean the urethral orifice with betadine, and you have to apply lignocaine jelly also. Lignocaine jelly, 2% jelly. So there will be a lubricant jelly with lignocaine, local anesthesia, so that there should be no pain during insertion. Okay, fine. Now you are going to keep a lignocaine jelly here. After that, you are going to insert it. So I was inserting very, very slowly. Actually, I was here only. I was here only. So actually, I was doing very, very slow, very, very slowly. Actually, I was doing it. No. So I asked Ramu bhai, everything is fine? So he told me, sir, I think you have reached to the right position. I think you can inflate now. Here only I inflated. Blunder. After that, patient started screaming. He started shouting, oh my God. So I thought, oh my God, what has happened to the patient? I know. So after that, I asked Ramu bhai, ab aage. After that, he told me, sir, I don't know further. मुझे इसके आगे नहीं पता. मैं बोला तुम पागल है क्या रामू भाई? बीच में लाके फंसा दिया. So nurse was watching her. She started laughing. So when she came, so after that she asked, sir, anatomy, huh? Sir, whenever you are going inside here, no, like there will be a urine bag also. When urine will start coming, when urine will start coming out, it means you are exactly into the bladder. When urine is not coming out, you are not into the bladder. Very easy to understand, right? Fine. I remember here, see a Foley's catheter you can insert only when the penis is in relaxed state. Only when the penis is in relaxed state. Okay, when penis will be erected, like at that time you cannot insert Foley's catheter inside. All these points are clear to everyone, है ना? So how to remove Foley's catheter? First of all, you have injected minimum up to 10 ml, right now, of distilled water here, right? After that, same thing with the syringe, you can take it out. After that, there will be deflation and slowly you can remove it out. All these points are clear to everyone? Yes. So can you answer me which color Foley's catheter we are using for babies? All of you, please write down in chat box. Bolo. For babies, black color. For girls, green color, right? For males, for boys, for males, orange color. All these will be having how many lumens? Only 2 lumens. But where will you see one extra lumen? Red color. So where do we use a red color? So that will be the triple lumen for blood irrigation, like after surgery, urethral surgery. All these points are clear to everyone? Yes. So can you answer me what is the fluid of choice for Foley's catheterization? Right? Fluid of choice is distilled water and not the normal saline. So we are using like see here one Foley's catheter. You can see here this is made up of rubber. So like this can be there, you have to change within 1 month. But these days we are using what? Silicon Foley's also. This you can keep up to 3 months. Up to 3 months. Remember here, rubber Foley's and what? Silicon also. Yes. Now CVP catheter. CVP is what? Central venous pressure. Remember here, this is 18 gauge IV cannula, green color. This you can say this is actually a peripheral line. This is actually a peripheral cannula. But if you have to insert the cannula, if you have to insert directly into the central vein, for that you have to use central line. This is called as central line. And a central line catheter. Here you can say one big catheter is there, and you can say how many lumens, how many entry points are there? First, second, and third. Okay, so there are 3 lumens here, central line. The question is that what are the uses of this? See, the question is that, see, what is the difference between a peripheral line and the central line? If I have a patient admitted in my hospital only for 1 day, only for 2 days, only for a few days, no problem at all. We can use, single ear peripheral, I can use, no problem at all. But suppose after severe burns, if a patient got admitted, like after severe burns, like overall, so total body surface area, 40%, 50% or 60% here. Now I can expect patient can be admitted in my hospital for more than 2-3 weeks also. So inner burns, hypovolemic shock will be there, no? Fluid management is the most important line of management in burns. So do you think, see here, so like when patient will be in shock, no, you will not be able to identify, you will not be able to get a normal blood vein. Right now, you will not be able to get a normal blood vessel. So do you think on daily basis, you are going to insert a green cannula, green on daily basis? It is very painful. It is very painful, I'm telling you, very painful. Ideally, we have to use anesthesia also, but it is very painful, remember here. But we are not using, we are inserting directly. Okay, fine. Very easy to understand. Right. So remember here, so where I suspect that my patient will be admitted for longer duration in hospital. At that time, we do not use peripheral. We use a central line only. Central line you can change, after 1 week also, after 2 weeks also. Like this can be there for a month also. For a month also. But negative point, yes. So I'm sure you are able to recall about microbiology knowledge, catheter-induced infection. Yes, there can be, it can lead to, if a central line is there for the longer duration, yes, it can lead to infection also. It can lead to, yes. Okay. So central line, can you answer me? Like in which blood vessel you can insert central line? All of you, can you write down in chat box which blood vessels you are choosing? Which blood vessels, right? Now see here, which, right? So can you answer me? Which veins you are choosing for central line? One is like internal jugular vein, subclavian vein, and a femoral vein. Very commonly, yes, no? Femoral vein, very easy to understand. Now, remember here, what are the uses of first lumen, second lumen, and third lumen? With the one lumen, like every time I can check CVP, like central venous pressure. We see central venous pressure, which is going to check the pressure inside superior vena cava, right atrium. Basically, this is going to tell you like efficiency of, or the blood filling pressure of, or like how much your right part of heart is functioning, right? CVP measurement. Less than 5 mg is normal. Second, I can use for IV fluid administration, even if I have to give antibiotics, even if I have to give TPN. What is TPN? Total parenteral nutrition. Total parenteral nutrition. When patient is not able to take it normally from the GIT, from the mouth, after that I can use what? TPN. From outside I have to give the nutrition, total parenteral nutrition. And one I can use for blood sampling, because if I have a patient admitted in ICU or maybe after severe burns, on daily basis I have to check his CBC, LFT, KFT, serum electrolytes and all. Yes, blood sampling. Remember here. Now, see, this is the catheter here. Right now, this is the catheter part, which you can see here. This is the catheter part. Right now, like, okay, central. So remember, see, what about the tip? Where you are going to keep the tip? Remember here, the tip should be maximum into superior vena cava. It should not entering into the right atrium. Remember here, it should not be entering into the right atrium, because it can cause what? Yes, like it can cause what? Atrial thrombus. Now, so to check whether central line is placed normally or not, or if there is abnormal placement, like if I'm going to do subclavian vein central line insertion, yes, it can it can damage the nearby structure also. This can damage lungs also. So yeah, for that we have to check X-ray. We have to do what? X-ray of chest. Okay, but remember here, overall most common complication during the cannulation is what? Arterial puncture also, and pneumothorax also. Remember, and pneumothorax also, right? Pneumothorax also. Chalo. All these points are clear to everyone. So can you answer me? Chalo, one-liner question if I ask you. I have mentioned here that yes, I can use internal jugular vein, subclavian vein, femoral vein. So can you answer me some question for TPN? Can you answer me for total parenteral nutrition? Which vein is best for TPN? which central vein is best? Okay, so for TPN, best is subclavian vein. But if I ask you, what about the like in a case of emergency, after their trauma, what is the most common vein we are using for central line? Like internal jugular vein. Okay, after their trauma. Now the question is that, see, what is the negative point about IJV, like internal jugular vein? See, easy to insert, but suppose the patient had to walk, patient cannot move like this easily, no? Right, and there will be higher risk of infection here also. So remember, subclavian is safe, because for TPN, no, for many days central line we have to fix here, no? So patient can sit also, a patient can move his neck also here and there, patient can move his neck, no problem at all, right? But if a patient is bedridden for many days, so there we can do what? Like femoral vein catheterization also. Now patient is bedridden, yes, we can do what? Femoral also. So one liner question, always keep in mind, for TPN, subclavian vein is best. After trauma, internal jugular vein. But which central line insertion will be having maximum risk of pneumothorax? Subclavian vein. When I compare these two, risk of infection is more with internal jugular vein here, right? No, but overall maximum risk of infection is via femoral vein. All these are, remember here, all these are one liner question which you should be knowing. After reading this question, can you answer me? Bolo. After reading this question, can you answer me? All of you? Very simple question, no? Very easy to understand, right? Central, see here, see this kind of question we may anticipate. Central catheterization in subclavian vein. Yes, next line of management, you have to do X-ray of chest. Yes, X-ray of chest. Remember here, so how to understand whether this is like, whether there was a normal placement or abnormal? If you can see normal X-ray, you can see here, right? You can see here, very easy to understand. And after that, you can see lungs are completely normal. You can see all bronchial markings and all, everything you can see here in picture A. I can say this is 100% normal. But what about picture number B? Can you answer me? You can see here more dark color. What does it mean? More air accumulation. Oh my God, this has created what? This has created pneumothorax. So I can say that this is a faulty. Remember, see, please remember here, this is 100% normal and this is faulty, where you can see more black color means what? More and more accumulation of your pneumothorax it has created, right? So remember, this can be the complication of, central line insertion. After that, what about this one? I anticipate this in image-based question. Suppose I had a patient of breast cancer. If I had a patient of breast cancer and if I have performed modified radical mastectomy, most of the area, most of the portions of the breast I have removed. Maximum, I 100%, like almost 100% I have removed. Almost, like I will teach you in the breast how many structures we are going to remove, how many structures we are going to preserve. But remember here, like since that patient was already a known case of the breast cancer where I had to remove the breast, but after surgery, my patient is in the need of chemotherapy. So there also same like central line insertion, we are using a chemo port for what? This is also central line insertion only, same like central line insertion only. Here you can see this is actually chemo port. Here. No, so this we are going to fix inside, and with the help of this, yes, we are going to give the chemo. So remember here, this is called as a chemo port for chemotherapy. Very easy to understand. All these points are clear to everyone. Remember, during surgery only we can fix here. We can fix it. itself, chemo port. Now Hickman line insertion, remember here, Hickman line insertion, this also we are using for chemo. This also we are using for chemo. Okay, this is also a type of central line insertion only. Central line insertion only. This also, this is called, especially here you can see only only 2 lumens are there. Like it is called as Hickman line insertion. Hickman line insertion. This also we are using for the chemotherapy. Sometimes you can see that like there can be image based question, like see examiner can mention here one line, one catheter was inserted in the median cubital vein here. This was started from here, this was started from here, and after that this went into the central line. You can say this is called as, this is known as peripheral inserted central line insertion. This is known as peripherally inserted central line insertion. Okay, central line insertion. This one point is clear to everyone, right? Now we are going to learn about different suture material. First of all, we may anticipate one question from suture material. See, like overall how they are going to frame the question from general surgery only. No, 6 to 8 questions will be there. 6 to 8 questions you can expect from only from general surgery, road traffic accident, shock, nutrition, all these small things, suture material, surgical instruments and all. Yeah, from GIT you should be expecting minimum 10 to 12 question. From Euro you should be expecting minimum 6 to 7 question from urology, right? From urology. Remaining from the topic of the breast, 1 or 2 question. Related to thyroid, you can expect 1 or 2 questions. 1 or 2 questions. After that, whatever questions will be there, those questions will be from the miscellaneous topics, like from the organ transplantation, oral cancer, you know, salivary glands, right? Now, see radical neck dissection and all, right? Now, very easy to understand, like a small thing like lipoma, like sebaceous cyst, like varicose vein, right? All these points are clear to everyone. So in this manner, they are going to divide number of questions in surgery. Okay, so suture materials, remember here, yes, there are 2 types of suture material. One is absorbable, another is non-absorbable. What does it mean? Absorbable means what? This will be absorbed inside the body. Basically, this will be digested. Basically, this will be digested by body enzymes only. This will be digested by body enzymes only. Okay, so that's why these are called as what? Absorbable. Once you are going to fix the suture, after that you don't have to remove it separately. I'm sure you would have visited hospital, and I'm sure during your internship or maybe during your hospital training part, at least you would have seen some external suture. Sometimes you would have seen doctor will be removing the suture separately. I know, means after healing of the wound, doctor is removing the suture. So removal of suture is needed in non-absorbable. Non-absorbable. Can you answer me? What is the size of the blade you are using to remove the suture? Size of the blade. Size of the blade to remove suture is, size will be 12. I will be teaching you surgical blades only, but here only you can mention, yes, size of the blade is actually 12. Okay, size of the blade will be 12 for suture removal. Absorbable sutures, suppose if I have to do suturing inside the body, or if there was severe laceration, or if there was a glass cut injury over here, right? Now, suppose if there was the depth of wound was 1 centimeter. So here, like if there was the depth of a wound was 1 centimeter, you cannot do only skin to skin suture. Inside there can be gap and there can be accumulation of fluid there. So because of that, healing will be very, very bad. You are giving, you are giving so much chance of doing what? Like accumulation of, like accumulation of the pus. After that, severe infection can be there. So whenever, like suppose if depth of a wound was like this, right now, so we have to start suturing from here to here to here. After that here, and so subcuticular suture, subcutaneous layer. No, subcutaneous layer. First of all, I have to approximate. I have to approximate what? Subcuticular suture. At last skin, right? Now See here, very easy to understand. All these points are clear to everyone. So for subcuticular, for inside the body, yes, we are using absorbable suture. So natural suture which is available, that is, one is called the, right, this is known as cat gut, which we have made from sheep gut, submucous of sheep gut. Synthetic, what we have made, one is called the, see, one is known as the polyglycolic acid. And most importantly, you should be knowing about polyglycolic acid. Very frequently, you would have heard in hospital, you would have seen in hospital, almost in every hospital, Vicryl. Vicryl is actually the, see, Vicryl is the company name type, right? No, see here, so main, actually the chemical is polyglycolic acid only, polyglycolic acid. And the longest, that is the polydioxanone, longest. This will be digested after 180 days. Okay? Vicryl we have learned, polyglycolic acid. Monocryl, remember here, Vicryl will be violet color. Vicryl will be violet color. Violet means like the purple color. But monocryl, this is white Vicryl, white color. This is called as polyglycapron. You have to memorize. You have to memorize it. I'm telling you, you have to memorize it. Name of the suture. Remember here, what are the sutures we have learned? First of all, polyglycolic acid. After that, polyglycolic acid. After that, we have learned about what? Polydioxanone. Polydioxanone. What about monocryl? Monocryl, batao, white color actually. Yes, that is called what? Polyglycapron. Polyglycapron. All these points are clear to everyone. Remember, one important point you can mention here only. Monocryl, Vicryl, actually these we are using for what? Subcuticular. Monocryl, very, very important. Most importantly, most commonly, and the best is actually for subcuticular suture. See, what is the meaning of the word subcuticular? Like subcutaneous tissue, if I'm going to stitch, if I'm going to approximate. So more frequently we have to use what? Monocryl, monocryl, monocryl. Remember, Vicryl is multifilament, but monocryl is monofilament, which I will teach you. Don't worry about this. Okay. Now, non-absorbable silk, sari material, silk, non-absorbable silk, linen. Like even we can use steel also for the bone, right? But synthetic, no, synthetic. Remember, one is called the polyester, polybutyster. See the polypropylene, which is actually the proline, right? You know, proline, very commonly you would have heard nylon. And suppose after road traffic accident, if there was a rupture of major blood vessel, if there was damage of major blood vessel here, so yes, I can be in the need of a graft material, which I can take from suture material also. Na? So remember here, for blood vessel, which graft material we are using? Polytetrafluoroethylene. Polytetrafluoroethylene. If there will be damage of the aorta, major blood vessel, for that graft material which we are using is Dacron. You have to memorize all these. These are fact-based questions only. You have to learn all these. Now the question is, monofilament means what? When there will be only one thread. Monofilament. If there will be multiple threads, it will be called as multifilament suture material. I will show you photo, you will have more clarity. You can see here only one thread is there, so it is monofilament suture material, monofilament. But look at the second one here. You can see here, when I'm going to increase the size of my screen, now you can see here, see there is only one thread. You cannot see here, multiple threads are here, no, right? Multiple threads are here. That's why it is called as what? Multifilament, or you can say these are actually what? Braided, right? Now these are also called a what? Braided suture material, multifilament. So there can be some good points about monofilament. There can be some bad points also about monofilament. There can be some good points about a multifilament and bad points also. So can you answer me? If there will be single thread monofilament, and if I am going to apply a knot, right? If I'm going to apply a knot, one knot will not be sufficient. One knot, so like it will be having more slippery structure, you know, like, so this will be slipping very easily. So monofilament pe, no, minimum you have to give 4 to 6 knots. So I can say poor knotting. With multifilament, good knottings. But when I show you this, no, So many, see, so many threads are here, so many threads. So many threads, no. Small gap also, minute, no. Higher risk of infection also. Monofilament, less infection. Let's see here. So what are the good points? Remember here, when I talk about monofilament, please remember here, monofilament example like one is the proline, ethylone, even nylon, even see monocryl actually, but multifilament, silk and a vicryl. Silk and a vicryl. So what are the negative points about, remember here, negative points about monofilament, there will be poor knotting, but good point, less risk of infection. Negative point about multifilament, high infection rate, but good point is good knotting will be there. Remember here, you have to learn the examples. Can you answer me? What is the chemical name of vicryl suture? What is the actual chemical over there? Yes, okay, polygalactic acid. Monocryl was polyglycapron. What was the graft material we have used for major blood vessels? Right? Which graft material we have used? Polytetrafluoroethylene. But which graft material we have used for aorta? Dacron. Okay, Dacron. Please remember it. Very, very easy to understand. Repeatedly asked question. Now, what about the catgut? First of all, remember here, this suture material we are not going to make from the gut of a cat. Remember this. We are making this from the gut of sheep. Sheep gut. So which layer we are using actually? We are using submucosa. We are using submucosa of sheep gut. Remember here. So since we are using one, since we are using the body part itself, so there is higher risk of reaction also. That's why like in some countries it is banned now, especially in UK, this is banned. But here in India, still we are using this. Okay. Remember here, there are two types of the catgut. One is called as plain catgut, which will get digested in up to 10 days only. But if there will be shining or if there will be chroming catgut, this will get absorbed in 60 to 90 days. Where do we store this suture material? Remember, animal material basically, like meat with alcohol. Remember here, catgut we are storing in alcohol. Where do we use catgut? Obviously this is absorbable, so we can use for subcuticular suture closure even after circumcision. Yes, remember here. So this kind of shining color you have to remember. Okay, now see, remember here, so many times, even if we have not exposed, even if we have not seen all the suture material, most of the time examiner will show you this kind of suture material. So here over the suture material, over the packet of the suture material, each and everything will be mentioned over here. Right now, okay, this is actually, see, the name and the length, right? Everything will be mentioned here, name and the length. Okay, now vicryl, remember here, vicryl is a violet color. Or you can remember here, purple color. And like at most of the places in operation theater, most of the places we are using vicryl. Almost everywhere we are using vicryl. That's why it is called as what? Yes, it is called as workhorse suture material, where we can use it for the maximum places. But remember here, and this will be digested within 90 days. And this will be digested by what? This will be absorbed by hydrolysis. And multifilament, but remember here, monocryl, right? Monocryl was that was actually monofilament. So vicryl for subcutaneous fat also, even for the bile duct also, for intestine bowel also, for muscles also. See, what about this one? Can you answer me what is 4O, what is actually 3O? Can you answer me here? Like over the suture packet you can see here, it is mentioned here 4O. What does it mean? See here, suture material, this can be 1O, this can be 2O, this can be 3, and this can go up to 7, 8, 9, 10. Remember here, so basically this is the size, this is the diameter of, this is actually the thickness of suture material here. Lower the number here, bigger size will be there. Lower the number, bigger size will be there. If I have to do plastic surgery, in plastic surgery, I should be using actually very, very thin suture material, actually very, very thin. So for, you know, like even for the even for the bile duct, we are using 4O, like even for the bowel, we are using actually 3O, like even for the minor surgery, no, we can use 4O, 5O, 6O, 7O, right? No, so the more the number, less the thickness. This is actually the diameter. This is actually the thickness of the suture material. Be careful about this. Okay, length is also mentioned here. What is the importance of learning about length? Can you answer me? What is the significance of learning about length of the suture material? I hope you are able to recall there is something called as Jenkins rule. There is something called as Jenkins rule. What is Jenkins rule? 4 into length of the wound. 4 into length of the wound. The question is that suppose if I have got one patient in my emergency department after glass cut injury, suppose if size of a wound is 4 centimeter. Size of wound, size of incision, size of laceration, size of incision is 4 centimeter. How you should be asking the nurse, Sister G, how much length of suture material you want? Remember here, so how much should be the length of your suture material which you should be choosing? So you have to multiply by 4. So like 4 into 4. So you can say what? 16 centimeter of suture material will be enough. 16 centimeter of suture material will be enough to close the wound. This much point is clear to everyone. Very easy to understand. This is called as what? See, length of suture material to be chosen. No, this rule is called as Jenkins rule. This rule is called as Jenkins rule. This much point is clear to everyone. You should know. See, remember here, you should know how much a length of suture material will be enough to close the wound. I know, so that you should have complete idea, because if you are going to take one suture material one time, no, after that you cannot reuse it anywhere else. Okay, so you have to be wise in that. Okay, fine, because suture material will be expensive only. Wherever you will be working, no, you have to look for you know, like financial aspect also. Yes. Chalo, fine. So Vicryl is called as what? Vicryl is called as workhorse material. Can you answer me? What was the chemical name of Vicryl? Bolo. What was the chemical name of Vicryl? Polygalactic acid. Polygalactic acid. Which graft material we have used for aorta? All of you, please write down fast in chat box. Which graft material we have used for aorta? All of you, write down. Yes, we are using Dacron. For other blood vessels like vascular structure, polytetrafluoroethylene. Polytetrafluoroethylene. Yes. Chalo. I can see that most of you are able to understand it also, and most of you are able to answer the question also. Very good. All of you are doing great job. But before I teach you one more suture material, read this question carefully and try to answer. Read this question carefully and try to answer, all of you. Read this question. A 17-year-old girl is brought to emergency department with the case of slashing of a wrist. She is not able to move her index and middle finger. Which suture material is used to anastomose the affected anatomical structure? Answer me. So first of all, can you answer me? Like when, okay, so can you answer me when she is not able to move her like index finger and the middle finger, actually index finger and the middle finger? Can you answer me? There is actually the damage of, there is the cutting of nerve, blood vessel, or tendon, or ligament. What is there? Bolo, what is there? See, when she is not able to move her fingers, when she is not able to move, see, after slashing of wrist, yes, there can be damage of so many structures over here, no? हो सकता है नहीं, so many structures over here, right? There can be a blood vessel here, there can be nerves also, like radial nerve, medial nerve, ulnar nerve. Can you answer me then? Bolo. When she is not able to move her fingers, like there is the damage of, hey, when she is not able to move the finger, there is the damage of the tendon only, no. There is the damage of the tendon only, no. Nerve is responsible for sensation. Sensation only, no. Remember here, muscles will be interconnecting with the bones, no. Are you able to feel the tendons here? Hold your forearm like this. After that, make a fist and close it. See here, like open and close, open and close. Are you feeling any fibrous bands over here? No. Fibrous bands are actually what? These are the tendons only, no. These are the tendons. So if you are not able to move your fingers, it means there is a cutting over. There was damage of tendon. Tendon only. Tendon only. So can you answer me which suture material you are going to use for this? Which suture material you are going to use to ligate or to anastomose the tendon? Bolo. Which suture material you are going to use to anastomose the tendon? Bolo. Out of these 4 options, can you answer me? All of you? Yes. See, so many of you might be thinking, okay, this is actually internal structure only. No, this is internal structure only. No, right? This is internal structure. So I can use absorbable. So many of you might be thinking either I can use A or B. A or B. You might be thinking, no? Okay. But remember here, whenever I have to ligate, when I have to anastomose the tendon, no, when I have to anastomose the tendon, remember here, like, see, like actually that, see, that tendon will be actually what? Like this will be having so much of the stretchability. After dissection of the tendon, no, see the tendon will be stretched like this. So you have to, like, you have to give one more opening. You have to give incision. Like, see, first of all, slashing of wrist was here, no, slashing of wrist. After that, one incision you have to give here. After that, here. Same, like this is called as like somewhat like Z incision. This is like a Z incision. And after the same like handkerchief, you are going to open the skin like this. You are going to open the skin like this so that you can have big exposed area, so that you will be able to explore it further. After that, you can identify where is the tendon, no? Where is the tendon? And then you have to re-anastomose, you have to reconnect it. So remember, see, that tendon will be actually, see, tendon will be a powerful structure, right? No, like it is having so much of a strength also, right? No, strength is there, no? So if you use absorbable suture, no, all absorbable sutures will not be able to hold the tendon for longer duration. So remember here, for tendon repair, we are using non-absorbable suture material. For tendon, we are using, remember, for tendon, we are using the proline. We are using the proline. Remember, silk we are using only for the external part of the body, only for skin. Remember here, only for the external, not internal. Okay, so what about the proline here? Remember here, what about the proline? We are using to anastomose blood vessels also. See, the tendons also. Even I will be teaching you, mesh, how to use mesh in hernia repair. So mesh of the hernia, this is also made up of the proline. Old question, proline. Remember, even if I have to repair a diaphragm, yes, I have to use a strong suture material like proline. Okay, now my question to you is that if you have to ligate the pancreatic duct, can you answer me? If you have to ligate pancreatic duct, which suture material you should be using? Can you answer me? Which suture material you should be using for the pancreatic duct? You might be remembering bile duct, bowel, we have used Vicryl. So pancreatic duct also. Yes, can you answer me here? For pancreatic duct, okay, you can use absorbable suture. You can use, but remember here, so many digestive enzymes will be releasing from the pancreatic duct, no? From the pancreas. So many digestive enzymes will be coming out of that can easily absorb your Vicryl. So even for the pancreatic duct also, we can use the proline. This much point is clear to everyone. Easy to understand. I hope all these points are clear to everyone. Now, if you have understood all these, this kind of question I anticipate in upcoming exam, please read the question carefully and solve the answer. Bolo, all of you. Read the question carefully. After completion of modified radical mastectomy for a breast cancer patient, head surgeon is asking you to suture the wound using a subcuticular suture material. Which of these suture materials will you choose? Out of these four, which suture material you are going to choose? Can you answer me? Which suture material out of these four? Best one. Now, I hope you can easily answer here. Yes, we can use Vicryl, we can use actually, we can use catgut also, we can use the catgut also, but out of these four, can you answer me which one will be the best here? Best you can use here what? Monocryl only. Monocryl will be better option. Monocryl will be better option. Out of these four, monocryl is the better option. All these points are clear to everyone? Remember, yeah, see, yes, subcuticular, no, subcutaneous after, after radical mastectomy. So better option is what? Monocryl. Now, suture needles. Let's learn about suture needles. So one suture needle, you can remember, like this can be round and this can be cutting needles. So round suture needle, no. So that will be separating the soft tissues. Right? Okay, separating soft tissues, bowels, blood vessels, okay, fine. But when I talk about the cutting needle, so this will be having shape like a triangle, like edges will be like a triangle, especially to penetrate in the body parts, like especially to penetrate the tough tissues like skin, fascia, and the tendons. So if I have to, like, suppose if I have to separate soft tissues and all, okay, round is better here. But if I have to penetrate, if I have to cut, see, the cutting needles will be better. Remember here, so round needles, that is, round needles will be preventing leaks. But what about the cutting? This will be minimizing damage. Now, see here, round body, you can easily understand here, round body. See, round body, you can easily understand here, round body. But what about the cutting needle? Shape will be like somewhat like a triangle here, So this triangle I'm talking about, like there will be cross section, right? No, there will be cross section. If this triangle will be like this, like in this direction, then it will be called as what? Reverse cutting needle, reverse, opposite. Okay, so remember here, round and cutting needles, I'm talking about suture needle. Now, these days, suture needle, whatever we are getting, these suture needles are eyeless. I'm sure you would have seen stitching material like at the shop of a tailor, right? So they are using a needle where there will be eye, where you can insert a thread. And like you have to insert a thread. That hole is called as the eye of a needle. Earlier, 15-20 years back, when we used to get the needles, no, we used to have eyes, like actually eye in the suture needle. But now, eyeless. Ready-made aata directly. Now it will be getting actually what? Ready-made. And this point is called a what? Swage point. Okay, swage point here. This is actually what? See, eyeless needles you are getting now. The question is that with the needle holder, where you are going to hold? Are you going to keep your needle holder? Are you going to keep your needle holder here, or here? What is the better point here? Can you answer me? Like, see the point number. See this point I'm mentioning here. 1, 2, or 3. Can you answer me? What is the right position of holding a needle, suture needle? Can you answer me here? 1, 2, 3. Which one is the right position of holding a needle? Bolo. With the needle holder, where are you going to hold? 1, 2, 3. Yes, exactly. See, this is actually the right way. This is actually a right way of holding the needle. This is actually a right way of holding the needle here. This is actually right way of holding the needle here. Like the proximal 2/3, you are not going to remember. Like in between a 1/3 and 2/3 proximal, you have to hold the needle so that easily you can penetrate inside the tissues. Easily you can penetrate inside the skin. Very easy to understand. This is right method. of holding a needle. Okay. Now, suture needles here. Suture needles of different shapes here. Remember here, one is called as half circle like this, and you can say the quarter circle here, J-shaped also. This is the compound curve. Where do we use these needles? Half circle we are using for if I have to do incision, like suppose if I have to do what, like suturing in bowel, bile duct or the blood vessels, I will be using half circle. Eye surgery के लिए, for eye surgery, small ones here, this is called the quarter circle. For the vaginal surgery, J-shaped. For the laparoscopic surgery, J-shaped. Remember here, for like inside oral cavity, this will be actually compound. This will be like, actually this will be curved, so that you should not be damaging inside, no? So that is called the compound one. Remember here, old pattern, old type, straight and all, straight, right? So these are no more in the use. These are the different shapes of the needles now. Now the question is that how much should be, remember here, where you should insert the needle, where you have to take the bite. Suppose if this is, suppose if this is the laceration part. Suppose if this is the laceration part here, this is, or maybe you have received a patient, after glass cut injury. After glass cut injury, you can see here there is a gap of this much gap here, right? This much gap here. Like even you can analyze depth of a wound also. So yes, I can insert my needle here to apply a suture. I can remove from here, like here. Okay, fine. So after that I can do stitching. I have to approximate the wound. Easy to understand. But the question is that at which length from the incisional point you have to take a bite. You have to insert the needle. Remember here, rule of X to X. Rule of X to X. What does it mean? If depth of a wound is X centimeter, depth of a wound is X centimeter, right? So the point of insertion from the incision should be 1 centimeter, should be X centimeter like this, X centimeter like this. So what does it mean? Let's understand this part here. So what I'm saying here, that remember here, see that depth of wound, so the point, so the point of insertion of needle, like it should be X centimeter from the point of incision. Like suppose depth of a wound was 1 centimeter. Depth of a wound was 1 centimeter. So from the point of incision, from here, no, like length of first, like insertion point should be 1 centimeter. Okay. So like insertion point and the exiting point, like 1 centimeter, 1 centimeter. Now, how much should be the distance between two alternate sutures? Distance between these two sutures should be equal to 2 centimeters. This much point is clear to everyone. Very easy to understand. I hope this is clear to everyone. Depth of a wound, like as per the depth of wound, first bite, first insertion should be there from the same distance. And like how much gap should be there in between two alternate sutures? Like see here, double of the wound depth. X to X rule, X to X rule. This much point is clear to everyone. Remember here, all these points are clear to everyone. X, double X. Remember it. I have mentioned everything in your note, right? Now the question, like suppose if I ask you one question here, suppose if I am going to give incision, suppose if I am going to insert the needle, can you answer me here? Ye batao, so can you answer me here? How much should be the angle of entry point? How much should be the angle of entry point? 45 degree, 90 degree, 180 degree. At which angle I have to insert the needle? See here, like at which point I have to insert the needle. Remember here, I have to insert a needle at 90 degree. I have to insert the needle at 90 degree. Okay, this much point is clear to everyone. So like entry point and exit point, entry and exit point, that should be at 90 degree angle. 90 degree angle. Can you answer me? See here, what is the size of green cannula? All of you, can you answer me? What is the size of green cannula? All of you, can you write down in the chat box fast? Green cannula, 18 gauge. What about gray cannula? 16 gauge. What about orange cannula? 14 gauge. है ना? 14 gauge. What is the smallest size like for a newborn baby? Okay, 26 gauge, right? 26 very good, very good. Now, what are the knottings here? Remember here, safe, or you can say safe knot, square knot, which is also called as reef knot, which is also called as reef knot. Square knot, reef knot, repeatedly asked question. Square knot is 100% safe, 100% safe. But like see here, like there can be mistake during suturing. There can be mistake during suturing, and that is called as, see here, and that is called as which type of knot? That is called a, yeah, this is called as this is known as the granny knot. Let's learn how to identify these two. When you see here a normal healthy knotting is when two up and two down underneath, like same ratio are there both sides. This is a square knot, reef knot, 100% safe knot, very good. But if a one knot is going up, one is going down, slip, this is called a granny knot. This is called a granny knot. Remember here, being a junior doctor, if you are going to apply a granny knot in operation theater, no, senior will scold you because any time it can slip. Anytime it can slip, okay? So that can be dangerous for your patient. This one point is clear. So A4 knot, remember here, when I talk about square knot, safe. How to recognize, how to identify these two, how to identify, remember here, both down, both up. Means both are in their normal position, but one is going up, one is going down. So that is called the, yeah, it is known as a granny knot. But what about a surgeon's knot? I'm sure even for a few times, if you have given suture, no. So many times your senior will teach, no, okay, first of all, insert the needle with forceps, you are going to hold it. And after that, you are going to move like this. Whenever there will be the double throw, same A4 knot, but if you are doing the double throw, this becomes surgeon's knot. This becomes surgeon's knot. Knot matlab gaanth bandhna, right? Knotting. This much point is clear to everyone. So a square knot, simple ho gaya yahan pe. But if there will be the double throw, it will be giving rise to surgeon's knot. Surgeon's knot, right? Chalo. Now, different types of suturing. One is called a simple, intermittent, simple, intermittent, and continuous. What is the meaning of what simple, like interrupted suture? Like what is called a what? Like interrupted suture. Simple and interrupted. Suppose this was the laceration. Like suppose if this was the, like after laceration, this was the size of the wound. First of all, I have inserted my suture needle here. After that, I'm going to take out here. And then I'm going to give a suture here. And then I'm going to cut. Second, I'm going to do here. Right? After every suturing, no, after every, see, after tying the knot, every time I'm going to cut. So this is called simple and interrupted. Simple and interrupted. Simple suture, one insertion, second, so one time entry, second point exit, right? Simple, but same, like after every knotting, if I'm not going to cut, like same continuously ho gaya, that is called a simple and continuous. Now, there is a type of suturing technique that is called as a mattress. Mattress means like, you know, same thing, like, you know, like I'm going to keep one another at the same position, mattress. Suppose if I have to do what? Suppose if I have to like close the wound tightly, I have to close the wound tightly. Okay, no. So I can give the, so remember here, see the mattress suture will give more strength here, right? What does it mean? Let's learn here. See, there will be no confusion in simple, intermittent or simple continuous. No problem at all. Like this is called the continuous, like subcuticular suture continuous hai ye. है ना, simple interrupted, no problem at all, but there will be difficulty in understanding mattress suture. How we are going to use, let's learn this first. Let's learn this first. Let's learn this first. Like suppose if this is the wound here, like this is the laceration wound here. First needle I am going to like insert here. This is the entry point, first entry point of needle. Suture needle I am talking about. I am going to take out from here. I am going to take out from here. But I want to double it. Same suture material, no? Like same line mein, one more time. First of all, like suppose if this was the wound here, like first of all, I have inserted the needle. I have taken out the needle like this. Now at this same position, now one more time I'm going to insert it. I want to take out the needle from here. So now same needle I'm going to insert here again, and I'm going to take out from here, and then I'm going to ligate. Same line to double ho gaya. This is called as vertical mattress. Vertical mattress. Vertical mattress. Same line, but you can say कि double suturing at the same line, vertical mattress. Vertical mattress. But I have first entry point was this, second was this. But same needle I'm going to insert here, I'm going to take out from here now. Right now, so this will be called as what? This will be called as what? Horizontal mattress. Double needling here, so double insertion. Right? For the same, this is called a horizontal here. You can look at the photo, you will have more clarity here. Same line, vertical, double. See, now like a horizontal part, this is horizontal mattress. I will show you some more photo, you will be having more clarity. Can you look at the photo and answer me? Ye bolo, this is which type of suturing technique? Can you answer me? This is simple, intermittent, simple, continuous, or this is a mattress? Bolo kya hai ye? All of you, can you answer me? Yes, easily you can understand this is what? Simple and interrupted. Simple and interrupted. See, first one, see, after first suture, this was first. But after looking at this photo, you can say what? Simple and interrupted. Simple and only for one time entry, one time exit. Simple interrupted. But look at the photo. Okay, this is called as what? This is the continuous actually. This is what? Easily you can understand here. This is what? This is the continuous. Ye continuous hai. Now, look at the photo here. Same line, vertical mattress. Horizontal line में double अगर है तो remember here for weak skin we can use horizontal. We can use horizontal. For depth of wound अगर है तो vertical mattress है. I will show you one more photo. You will have more clarity. See here. So this is actually horizontal. But I will show you one more photo, and after looking at this photo, can you answer me? Now, I will not tell you what is the answer here. You have to tell me, look at the photo, and then you tell me which type of suturing technique I am showing you here in this photo. Can you answer me? In this photo. Bolo. I think you can easily understand here. Dekho, see, there are the double points here. Na? There are the double points. You can see here double points. 1 point, second point, double point, 4 points are here, right? And easily you can understand this one. Easily you can understand here, right? Now there should be no confusion. There should be no confusion. This is a case of vertical mattress. Vertical mattress. I hope these points are clear to everyone. Kafi hai? Are you able to understand that technique of suturing? Suturing, easy to understand. Samajh mein aa gayi baat? Right? No, all these things what we are learning here, no, all these things you are going to practice in hospital. Whenever you will be doing internship, for sure you will have to do suturing. Yes, you can perform all these, you can practice over there. And I'm sure most of you know about all these things. Yes? Chalo, very good. Now, where we can do suturing like this, like a purse string, whenever there will be circular wound, like even after removal of appendix, even after removal of the appendix also, right? No, even after removal of the appendix also. Yes, so where you have to, like, you have to give suturing like a same like the purse string. Remember here, this is called as purse string suture. purse string suture, right? Purse string suture. Now, remember, see, I already have taught you that whenever you are going to insert, like needle entry should be at 90 degree, and there should be exit at 90 degree, 90 degree, 90 degree. Remember it. Can you answer me what was the rule I have taught you, that if I have to choose how much length of suture material I have to ask from the nurse? Can you answer me which rule I have taught you? 4 multiplied by length of the wound. Can you answer me which rule I have taught you? Which rule? Jenkins rule I have taught you, right? Jenkins rule. Yes, very good, very good. Now, do you think during needle prick injury, see here, do you think during suturing there can be needle prick injury? Suppose if your senior is suturing and you are actually assisting him, you are keeping your fingers over there. So do you think there can be needle prick injury? Or even like if you are doing suturing yourself to a patient, so yes, sometimes there can be needle prick injury. So do you think there can be a risk of the transmission of any virus here? Do you think there can be needle prick injury? Yes, there can be. Do you think there can be the transmission of some virus? Yes. Needle prick injury. Remember here, risk of. How much is the risk of? Can you answer me? Out of these three, maximum risk of spread of which infection is there? Maximum spread. Bolo maximum spread. Hepatitis B, hepatitis C, or HIV? Can you answer me? Maximum. Okay, yes, remember hepatitis B virus. Hepatitis B virus. Risk of spread of infection will be 30%. Hepatitis C virus. Risk of infection will be only 3%. HIV. Risk of infection will be 0.3%. 0.3%. I remember like when I was in hospital, like I had needle prick injury at least for 9 or 10 times. 9 or 10 times I also had. Okay, fine. The question is that if you get needle prick injury, okay, suppose if there is a non-elective case, if there was the emergency case, or there was a local case where, like, suppose if there was a small case of lipoma, but there was like actually no, like for a small cases, no. Every time, suppose if the patient is poor, every time we are not asking, okay, you have to go for the screening of the viral markers. You have to test for, like hepatitis B, hepatitis C, or HIV. And but like in the small procedure in emergency, if there was needle prick injury, after that, are you going to send blood sample of the patient? Are you going to do like that? Yes, you have to send blood sample of patient for lab testing. So my question is that, yes, you have to send the sample of the patient, but do you think your blood sample will also be going, or should also be going to the lab? Yes, you have to send the blood sample of doctor also. What if patient was safe and a doctor was infected? I knew few of my colleagues, right? They were HIV positive. They were actually. Okay, fine. So might be, so there can be the reason, there can be needle prick injury or whatever. So yes, it can spread. No, it can spread. So remember here, you have to send the sample of patient also and doctor also. Remember here, whenever you are getting needle prick injury, first of all, there should be first aid. You have to clean it, you have to apply antiseptic dressing. After that, you have to report the nodal center. In every hospital, there will be a nodal center to report that. After that, they will give you first dose, right? Or they will give you the prophylactic dose of HIV and all, right? Okay. Now, removal of sutures. After how many days we have to remove the suture? Suppose see, mostly over the face, now we are using what? Subcuticular suture. Mostly. But suppose if there was a suture over the face, right now, after how many days you should remove it? After, like within 3 to 5 days, you should remove. After that, you come down around the neck, 5 to 7 days. Over the abdominal part, this area, you can remove within 10 to 14 days. Over the palm, soles, back, after 14 days. Can you answer me which size of blade you are going to use here? Which size of blade? Size of blade to remove the suture will be, blade size will be 12 number. Okay, 12. But देखो, for the suture removal, no. These days of the last many years, actually, we have been doing so much of suturing. Suturing will be taking so much of time. If the length of wound will be very big, no, suturing will take so much of time. So much of time it will take, right? So that's why now we are having some new techniques, some time-saving techniques. Remember here, this is a new stapler for the bowel anastomosis. Right now, this is called a thoracoabdominal stapler. Very fast you can staple, right? Right, and after that, this is called a what? Surgical. So remember, surgical linear cutting stapler here, right? For the laparoscopic surgery and all, yes, to cut and staple the tissues very fast, end to end, right? Very fast you can do it, right? Very fast, right? See, even remember here, this is actually for what? Like this material which you see here, the apparatus what you see here, this is actually what? Stapled, what? Like especially for the hemorrhoid we are using here, no? Remember here, so here we are using a circular stapling device here, especially to do what? Especially to reposition the hemorrhoids, right? And after that we can, right now. So remember here, all these are new instruments for stapling, for suturing. Now, suppose during this surgery, if there will be bleeding, suppose I had to operate over the forearm, I had to operate around the neck, I had to operate around the abdominal cavity or over the legs, over the thighs. If I'm going to give incision during surgery, do you think there can be like incision of some other blood vessels also? Some of the non-required blood vessels also? Yes, there can be damage, no, there can be incision. So during surgery, there can be bleeding, no. If there will be pooling of blood, no. See here, suppose if there will be pooling of blood, you cannot operate peacefully. You cannot operate peacefully. So there will be one intern, there will be one junior doctor who will be actually what? Who will be using gauze to soak it, right? Or to remove the blood there, right? Or there will be, you know, like there will be a suction tube also, suction pump will also be there to remove the blood. Okay, fine. This much point is clear to everyone. So, but remember here, like every time gauze and all, no, like suppose if I have to operate for the longer duration, I can use some kind of the cauteries. One is called here, you can see single, this is called a monopolar cautery. This is called as monopolar cautery, but here you can see double poles. This is called as bipolar cautery or dithermy. Bipolar cautery. In monopolar cautery, you can see there are two buttons, there are two switch. One is a yellow, another is blue. Yellow to cut the muscles or the nearby structures, and blue to clot, and blue to coagulate the bleeding vessels. Yellow to cut, blue to coagulate bleeding vessels. This much point is clear to everyone. So basically, with this monopolar cautery, remember here, I'm sure you know about the basic OT etiquette, OT etiquettes, that like doctor and patient, when they are entering the operation theater, no, there should be no jewelries, there should be no any metallic things on the body of the doctor also, patient also. Obviously, no, we are using so many things over there. So like in monopolar cautery, no, we are using electric energy. We are using electric energy to produce heat, right? We are using electric energy. We are using electric energy to produce heat so that it can cut the nearby structure also, and it can coagulate bleeding vessels also. But here there is only one pole. So to complete the circuit, there should be something, no? There should be something. So for that, we are keeping one earthing plate will be there. Earthing plate. I will show you photo. You will have more clarity. Remember, earthing plate will be like this. Earthing plate, right now. So there will be what? Yeah, this is what actually earthing plate. So from the monopolar cautery, now electric current that will be passing, right? With the help of the electric, see, with the help of this plate, actually earthing plate, there will be completion of circuit. Mostly we keep under the, like under the body, actually beneath, right? Okay, fine. But the question is that, see here, in monopolar cautery, no, earth plate is a mandatory. Earth plate is a mandatory. Remember, yellow to cut, blue to coagulate. but this will be releasing heat also na. So nearby structure, if there are nerves and arteries, it can damage nearby structure. So remember here, so there will be risk of lateral damage will be there. So whenever you are going to operate at the position and the body where there will be end arteries, like if you are operating at the fingertips, if you are operating at the fingertips or over the penis, please don't use monopolar cautery. End arteries area, please don't use monopolar cautery. If you are operating, like if there will be nearby nerves, and see, even if you have to operate in the neck, if there will be, see, the parotid gland and the thyroid gland, it can damage it. So don't use monopolar cautery here. But suppose if the patient was already, like overall, suppose if the patient already had a pacemaker before, ideally you should not be using monopolar cautery. But if there will be need, then you have to keep a pacemaker away from the actually you have to keep the earth plate away from the pacemaker. This is the rule here. But when I talk about a bipolar cautery, remember here there is no need of earth plating there. So these two will be completing this circuit itself. These two will be completing this circuit itself, and this is not used to cut. This is used like only to clot, only to coagulate blood vessels, and there will be no risk of lateral heat production. There will be no risk of lateral like any kind of the damage, right? So remember here, only coagulation property will be there, only clotting. Here at this point only, can you answer me? At this point only, I want to ask you one question. Suppose if I had a patient of lipoma, small swelling was here, which I can operate under local anesthesia. Yes. So with the local anesthesia, we are also using adrenaline. Can you answer me why? We are also, with the local anesthesia, we are also using adrenaline. Can you answer me why? With the local anesthesia, we are also using adrenaline. Yes. Like first of all, this is going to increase the efficacy of local anesthesia. First of all, this is going to increase efficacy of local anesthesia. Second, this will be causing vasoconstriction. Because see, remember here, no, like suppose if I'm giving one incision over here, after the, if there will be pooling of blood, I cannot operate peacefully here. That's why we are using adrenaline, which is having actually what? Vasoconstriction, and there'll be a lack of blood flow here, so that I can operate peacefully. This much point is clear to everyone. My second question to you is that if I have to operate near the fingertips or over penis, do you think I can use adrenaline over there? No monopolar cautery, no adrenaline, because there are end arteries. We should not be using adrenaline over there. All these points are clear to everyone? Yes, very good. Now, see, remember here, we have learned all these points now. Now, what are the suction drain? Can you answer me? See, suppose if I had to operate over the shoulder area, like inside the axilla, around the neck, or if I had to remove the breast, or if I had to operate over the abdominal area, after any surgery, when I'm going to close the wound, do you think even after the complete closure of wound, even after antiseptic dressing, even if I have shifted my patient from operation theater to recovery room to ward, after 1 or 2 hours of surgery, after 1 or 2 hours of the completion of surgery, even inside the closed wound, do you think there can be leakage of blood? Do you think there can be accumulation of blood even after complete, suturing and all? Yes, no, even after that, yes, no, because you would have damaged so many bleeding vessels over there, no. You would have damaged, actually, see, you would have cut so many blood vessels over there, no. So even if you are going to close it completely, even if you are going to shift the patient to ward, yes, there will be risk that some blood will be leaked over there. There can be accumulation of blood over there. This much point is clear to everyone, right? Now, for that, right? To prevent that, there should be no accumulation of blood. There should be no accumulation of external blood there, no, because that can lead to severe infection. That can lead to, and see, hematoma collection will be dangerous for the patient. This one point is clear to everyone. That's why we are inserting a drainage tube. These are called, see here, see, negative pressure. Negative pressure, remember these are called what? Negative pressure suction drain. One very commonly used in hospital, like this one. This is called as a Romovac. When I show you the photo here, you can see here shape is like this, no, shape is like this here. Shape is like this here. Hai? So first of all, I am going to insert, suppose if I operated over here, around here, yeah, here, axilla mein, I am going to insert a tube here. I am going to insert a tube, the drainage tube here. Okay, and after complete suturing, no, I'm going to see the same vac, no, same bottle you see here. No, this is actually a closed drainage system. So first of all, I'm going to apply a pressure. It like see here, I'm going to apply a compression over here like this. I'm going to compress it like this. So this will become size will be like this. See, after slowly when it will be opening, no, slowly when it will be opening, no, this will be applying what? Negative pressure, and whatever fluid collection is there, no, it will suck it. This is called as Romovac. Remember here, these are the examples of closed suction drain. So this shape, remember here, this is a Romovac, and where you see like a bulb, like a cylinder, this is called as a Jackson drain. This is called as Jackson drain. Jackson drain, right? Jackson drain. All these points are clear to everyone. Remember here, these two are repeatedly asked question, image-based question in your exam. Romovac and Jackson drain. These are the examples of negative pressure. You can say what? These are the closed only, no? Closed suction drain. Closed suction drain. Next. Remember here? Yes. This is also an old image-based question only. After abdominal surgery, yes, you can see abdominal drainage tube here. Because of the gravitational force, there will be suction of the accumulated fluid over there. So this is what? Abdominal drainage tube. Abdominal drainage tube. This is repeatedly asked question in INICT, NEET PG, FMGE also repeatedly asked question. If there is a case of burst abdomen, diabetic foot, where you can expect so much of accumulation of the pus over there, so much of accumulation of the pus, you are going to fix it like this. There will be negative pressure of -20 pressure will be there. This is called as a vac therapy. Vacuum assisted closure therapy. Vacuum assisted. Okay, now vacuum pressure will be -20 only. So remember here, this will be your image based question. Over the diabetic foot, old, you know, like old abscess, old, you know, wound is there, where there will be what? Severe accumulation of the pus over there, right? So you can use vac therapy. Vac is what? Vacuum assisted closure. Vacuum assisted closure. I hope you will be able to recall these images and these things, like suppose if you get a chance to visit plastic surgery department, okay? So like there you can see all these very frequently. You can see, like even in a case of the burst abdomen, yes, very frequently you can see. All these points are clear to everyone, right? Now, after that, different positions during the surgery in operation theater. Most commonly used for the, you know, like abdominal surgery, or if you have to operate over the, you know, like for the breast surgery, supine position. Supine, normal position hai. Now, the opposite will be prone position. If you have to operate over the back, over the spinal part, this is called the prone position. Okay, now these are two very frequently asked positions in your exam. When you see legs are up, head is down, head is down. Legs are up, head is down. This position is called the Trendelenburg position. Right now, very easy to understand. So now the question is that, what is the significance of this position? Remember only one point. If I have to operate in operation theater, no, if I have to operate in operation theater, you know, first of all, there should be no accumulation of blood, or there should be less blood supply to that area. That's why I'm sure you are able to recall about something which is called as are you able to recall about the tourniquet? Are you able to recall about the tourniquet? if I have to do knee replacement surgery, or if I have to operate here, if I have to operate over the lower limbs, yes, for time being, I am applying a tight tourniquet. I am applying a tight tourniquet so that there should be less arterial blood flow over there, so that we can operate it peacefully. But you cannot keep the tourniquet. You cannot keep the tourniquet for many, many hours. No, for a few minutes, like, for a few minutes. This depends upon the timing actually. So very frequently you have to remove it also, so that there should be normal blood supply. This much point is clear to everyone. So you can easily understand why do I need to apply a tourniquet. Means like if I'm going to apply a tight something with a tourniquet, like you will see in hospital, right? If I'm going to apply a tight tourniquet over here, suppose if I'm like applying a tight tourniquet over here, so less blood flow here, so that I can operate peacefully. If there'll be bloodless area, I can operate peacefully over here. This one point is clear to everyone. One question, one mistake of a junior doctor. Please answer me. Like there was a case, like there was a surgery of knee replacement surgery was going on. Knee replacement surgery, okay? Or around the knee surgery was going on in orthopedics department. And senior doctor applied a applied a tight tourniquet around, just at the higher position over the thigh, near the inguinal part. Like, okay, fine. Easy to understand. After surgery, senior doctor asked junior doctor, you have to close the wound, you have to apply the tight dressing, and after that ship the patient to ward. Basically, this is the duty of a junior doctor, to remove the tourniquet. You have to remove the tourniquet. But that junior doctor forgot to remove the tourniquet, and he shifted the patient to ward. By the evening time, what happened? After 6 hours of surgery, patient started complaining of severe pain in that limb. So nurse started searching. So nurse thought, I have given the injection of analgesic, was also given. Everything was given, right? So why he's complaining of severe pain? After that, nurse found there was a tight tourniquet. She removed it. Actually, there only she removed it. After that, after a few minutes only, patient went into coma. Why? Patient went into coma, like there was severe breathlessness and all. I know. So there was a worsening of the symptoms. My question is, why? Bolo, why? All of you, why? This is called the tourniquet syndrome. Mistake of junior doctor can kill a patient also. Remember here, see, when you have applied the tight tourniquet here, you wanted to stop, you wanted to stop arterial blood flow for some time only, only for time being, but you have stopped venous blood also, Venous blood will be having what? Deoxygenated blood or contaminated blood, right? So when you have stopped, stopped blood supply for 6 hours, so yes, so do you think there'll be a lack of blood supply to that affected limb, lack of nutrition, lack of oxygen? There can be rhabdomyolysis. Yes, so do you think there can be what, like, there can be the contaminated blood, there can be what, like even there can be myonecrosis also. So suddenly if you are going to remove the tourniquet, now the contaminated blood that will be going inside the systemic circulation, and because of the emboli, because of the thrombus also, yes, there can be embolism and all. Very easy to understand. This is called as tourniquet syndrome. So by mistake, if there was suppose if there was a tight tourniquet for last 6 hours, what is the last management here? If you want to save the life of the patient, amputation only. You have to remove that affected limb 100%, so that you can save the patient. Okay, so remember, yes, simple mistake can be disastrous. It can be disastrous, right? I hope you are able to recall. Yes, you are able to understand all this. So the tourniquet syndrome, you are not going to forget in life. Okay, fine. In this manner, now in this position, can you answer me? In this position now, blood flow will be in this direction here. So here in this area, there will be actually what? Remember here, in this area, there will be less blood flow here. So I can operate, suppose if there will be a case of, like suppose if there will be a case of varicose vein over here, varicose vein, yes. Here I can operate, I can operate over the pelvic area also, right? So this position, when head is down, this is called as the Trendelenburg position. But when this will be opposite, when head is up, leg is going down. This is called as reverse Trendelenburg position here. Now the blood flow will be in this direction actually, no? So less blood supply over here, less blood. So see here, now around the neck, I can operate in this position. Even I can do lap collie also, and a lap collie also, right? No, but remember here there will be risk of air embolism. Risk of air embolism will be there. And when I do lap cholecystectomy, laparoscopic, no, right, laparoscopy, so under the diaphragm there can be accumulation of CO2 gas, which we are using in laparoscopy, no, there can be accumulation of CO2 under the diaphragm that can give rise to radiating pain towards the right scapula. Okay, no, side effects. So remember here, like in a reverse Trendelenburg position, yes, air embolism can be seen, air embolism. Okay, fine. Now this is a lateral this position is called as lateral kidney position. After seeing this position, you can easily answer, no, can you answer me which surgeries I can perform in this position? Can you answer me which surgeries I can perform in this position? Yes, over the back only, no, over the back. So there will be good access to the thoracic place. There will be good access to the renal part here. So if I have to do what? Like suppose if I have to, you know, operate over the renal part, over the kidneys, this is the good position. Right? Very easy to understand. Very easy to understand, right? No? So over the like, so for the surgeries over the kidneys, over the thoracic part, easily I can go inside here. And one more important point in lateral kidney position. Remember here, kidney position for kidney surgery. Remember like that. Okay, fine. If suppose if an obese patient is then obese patient, so this is also good actually, you know, like see here, abdominal content will be coming to one side, no? Abdominal content will be coming to one side so that you can operate peacefully. Remember here, this is lateral kidney position, lateral kidney position. Now, for a neurosurgery, or you can say what, sitting position, or for Fowler position. Fowler position. Remember here, air embolism is more common. When there will be 50 to 100, when there will be 50 to 100 cc of air accumulation, or suppose if examiner is mentioning that surgery was being performed in the sitting position, surgery was performed like over the head, over the skull part, right? Now, basically neurosurgery, after that patient started having what, like desaturation, breathing problem and all, right? Now, breathlessness and all. Yes, so remember here, Fowler position will have higher risk of, more risk of air embolism. So now when you suspect this, after that you have to keep the patient in which position? You have to place the position, you have to place the patient in which position? This position is called the durance recovery position here. Remember here, foot up position and head down, right? No, head down. So like in this position, you are going to keep the patient here, and after that from the central line you can take out the air. Remember here, this recovery position is called a durance recovery position. Durance recovery position. Durance recovery position. Now, easy to understand, this is called as the lithotomy position for the vaginal surgery, anal surgery. Lithotomy position, you understand it, right? Obs and gynae, right? But when we are going to keep, remember, when we are going to keep the legs like this, okay, no, see here over, so do you think there can be the compression of, common peroneal nerve? Yes, there can be compression of common peroneal nerve, and this position can lead to foot drop, right? No, foot drop due to compression of common peroneal nerve. Okay, now in this position, if I have to operate over here for the pilonidal sinus surgery, like even for the hemorrhoid surgery also, so this position is called the jackknife position. This position is called the jackknife position. Due to position, there will be risk of asphyxia. So there will be risk of positional asphyxia. These are the side effects of different position of surgery in operation theater. Now, Lloyd Davies position. So surgeon will be standing here. Like surgeon will be standing over here. Surgeon will be standing over here, and if you have to operate over the pelvic region, lap surgery here, this position is called a Lloyd Davies position. Remember here, head down with split leg, Now, in ENT, I'm sure you would have learned this position is called as rose position here, rose position here. So if I have to operate around the neck, if I have to operate for the thyroid, if I have to operate for the tonsil, right now, right? Easy to understand. Or here, basically in the neck area. So like in this position, I'm going to keep my patient in this position. This position is called as rose position. But what can be the side effect? Do you think there can be temporary, or there can be, like somewhat subluxation of some vertebra? Right now, there can be, yes, remember here, there can be subluxation of C1, C2 joints, C1, C2 joints. And this can give rise to, remember here, this is called as Grissel syndrome. This is called as Grissel syndrome. This is the side effect. This is the side effect here. Okay, fine. Chalo. All right. So now we can take, I think we can take a small break now. After that, we are going to continue, right? Chalo, we can take very small break now. Very small break we are going to take. After that, we are going to learn about different abdominal incisions and surgeries we are going to learn. Okay, you can take a small break only for 5 to 10 minutes. That's it. Yeah, okay, fine, everyone. So we can continue from here. Now we are going to learn about different shapes of the incision. Different shapes of the incision. Like suppose if I'm making this one, you remember, like this is the abdominal part here. This is the abdominal part, right? This is the abdominal part. This is umbilicus here, right? So now where to give incision? Remember here, the same photo, like the same photo what is given over here, we can understand here at the subcostal part. If I'm giving incision like this, right? Incision like this incision is called as Suture incision. So the question is that, see here, as per the location of the incision, no namings are there. Remember here, this incision is called a Suture incision. So if I give incision over here, I can have easy access to gallbladder. So for like even for the cholecystectomy, I have to do what? Suture incision. But suppose if I have a patient of the appendicitis, I have to give incision over this part only, right now, over this part only, right now. Okay, fine. So here only like in between or like near the McBurney's point. I hope you are able to understand. I hope you are able to understand meaning of the McBurney's point, right? Okay. So now the question is that, so which type of incision I can give it here? Like one incision is called as a gridiron incision. Gridiron incision. Second incision just at the lower part of the grid incision, that is called as lance incision. Lance incision. And if I have to give a muscle cutting incision, then like at the same point, like see like over the right side, this will be called as Rutherford-Morrison incision. Related to appendicitis, we have to keep in mind most important, see, names of incision: Rutherford-Morrison, gridiron incision, lance incision. What are the significances of all these? I will teach you. Don't worry about this. Remember here, like see, suppose if I'm giving these incision, Rutherford-Morrison incision and gridiron incision. Over the McBurney's point only, no, I have to give gridiron and Rutherford. So like remember, see when I talk about the gridiron incision, muscle splitting. Okay, this is actually muscle splitting where I have to split. But if I have to cut, the muscle, no, that is actually what the muscle cutting is Rutherford-Morrison. Rutherford-Morrison, this is the muscle cutting incision. Muscle cutting incision. Basically, if I'm giving incision, like first of all, I have to give incision over the skin only. After that, this depends upon me. I can split the muscles. I can split like this, so that I should not be damaging. So remember, a muscle splitting is gridiron, but suppose even after that, if I cannot reach inside, then I have to give a cut. Muscle cutting incision is, what? Rutherford-Morrison incision. Only skin crease, lance incision. Remember here, lance incision, I can say this will be cosmetically, this will be better. This is also called as Bikini incision. Bikini incision, because this is given over here only. This is given over at the lower part here. So for the, like even for the cosmetic purpose, no, this is better. For a C-section, for cesarean section, yes, when I'm giving incision here like this, no, this is called as Pfannenstiel incision. Pfannenstiel incision. All these are very easy to understand. Now, like on the basis of the location, suppose if I have to give incision like exactly in the midline, this is called as midline incision. Midline incision, somewhat near to midline, this is called the paramedian incision. Or if I have to give incision in the horizontal manner, this is called the transverse incision. Basically on the basis of the organs where I have to operate, I have the facial part over the maxillofacial part. So like whenever, like being a surgeon, whenever I have to give incision, no, I should be very, very careful that like there should not be a big scar. Or I have to give incision where there should be least scar, or a scar should not be visible. Suppose if I have to operate for the nasal surgery here, or if I have to do what? Rhinoplasty here. So if I have to open, like suppose if I have to open this much portion of the nose here, I can give incision around here. And after that, this much portion, I can keep it up and I can take it up. And even after the closure, no, see, scar will be here, which will not be visible. over the maxillofacial. Suppose if there is a case of the maxillofacial cancer, right? Now see, maxillary cancer or hard palate cancer, I can give incision so that I can reach inside. I can operate here. Remember here, so I can give incision here just under the eye bed here. After that, around the nose, and then I'm coming down here, right? See, around the nose, and then I'm coming down here. This incision is called as Weber-Ferguson incision. This incision is called as Weber-Ferguson incision, like for maxillary cancer or over if there will be hard palate cancer. Weber-Ferguson. Now, some special incision. Remember here, like I'm making this portion. This is what? Abdominal part. This is abdominal. Okay. I have to operate for the gallstone. One incision I have given. This incision is called a Kocher incision. Now the extension of Kocher, like this is called as chevron incision. Chevron incision. Chevron incision. So the Kocher incision for gallbladder, for chevron incision, or you can say what? Rooftop. So after that, no, there will be actually very good, like after that I can have good views for what? Abdominal surgeries. Even if I have to operate near the pancreas or liver or spleen, chevron procedure. One more incision if I give here, same like Mercedes-Benz. So this is called a Mercedes-Benz incision, especially for liver, for the hepatobiliary part or renal surgery. These incision you have to memorize. Only one incision over the right subcostal here. This is called as chevron. The extension of chevron, this is called, I'm sorry, like see here, like over the subcostal area, like if I'm giving incision like this is called a Kocher. Extension of Kocher like this, like a rooftop, this is called a chevron. One more incision here, same like Mercedes-Benz. Simple, very easy to understand. I hope all these points are clear to everyone. Okay. Next, these lines are called as surgical incision. See, these lines are called as Langer's line here. What is the significance of these lines in surgery? If I have to give incision, if I have to give incision, please remember here, now I have to give incision along the Langer's line. Along the Langer's line. So I have to give incision at the parallel to the Langer's line so that there should be less scars. So that there should be actually good scar. Right now, remember here, one side effect which I will also teach you, because after the major surgeries, there can be formation of big scar. One is called as hypertrophic scar. One is called a hypertrophic scar, big size of a scar. And like if size of a scar is becoming big and big, then it will be called a keloid, which I will teach you separately. Big scar is hypertrophic scar, but if size of the scar is becoming big, okay, like around the sternum, around the earlobe, so like it will be forming what? Keloid. All this will be learning in detail, don't worry. Okay, fine. Next, now this is one more here where electric energy, remember here, a scalpel means a scalpel and blade. With that to give a cut, right? I'm going to give a cut. Now there is harmonic scalpel. This picture you can expect image based question, where remember here electric energy will be converted into ultrasonic waves. We are not using here, we are not using heat here we are using ultrasonic waves here, remember here. So this will be working same like a scalpel, with the help of, remember here, with the help of 50,000 hertz high frequency wave, we are going to give a cut. Right now, same like a scalpel blade. This is called as harmonic scalpel, right? This is called as what? Harmonic scalpel. No lateral spread of it, so safe in all cases. Remember it, very, very important. Now, for abdominal examination, can you answer me, all of you? See here, what is the sequence of doing abdominal examination? I am sure all of you know the fact that if I have to do physical examination across the body, first of all, I have to do inspection or observation. After that, I have to do palpation, and then I have to do the percussion. At last, I have to do auscultation. ये तो general है. This is general. This is for general physical examination. This is for general physical examination. Yes, I'm sure. Yes, all of you know this. So most of you are marking answer is A here. Most of you are saying answer is A here, right? No, answer is A only. You are saying no, answer is A only. Most of you. But remember, I have specifically asked you for abdominal examination. Remember here, like first of all, yes, you have to do inspection. But if you do palpation before auscultation, remember here, like if I'm going to apply soft pressure, if I'm going to touch with soft pressure, it is called a palpation. It is called a palpation, like this, right? It is called as palpation, right? I'm keeping my fingers, after that I'm going to tap, that is called a percussion. For what? Like for this one, right? No, for ascites fluid and all, you can recall all these, right? For differentiating resonating sound and dull sound. But remember here, so in a case of the abdominal examination, no, before auscultation means what? You are listening the sound with a stethoscope, no? Yeah, you know auscultation, right? So if you do auscultation, like suppose if you do palpation before auscultation, no, you can disturb bowel sounds. So after inspection, second is auscultation. Then there will be percussion. At last palpation. At last palpation, answer is D here. Remember here, very, very simple question, but yes, you can do mistake also. This was very easy question. Now there should be no more mistakes. There should be no more mistakes. All these points are clear to everyone? Right. Okay, काफी है. Now, next. Now, we are going to learn about surgical instruments here. Remember here, like when you are working in hospital, when you are working in the surgery department on daily basis, if you will be using, so many surgical instruments, like for the lifetime, you can memorize the name also. But here, since we are preparing for exam, I will be showing you some photos and we have to memorize the name and uses of these surgical instruments. Like number one, I'm showing you, this is needle holder. This is a needle holder, same like, but if you look at the photo, if you look at the photo of the apparatus here, this looks like only artery and forceps only. But how will you understand this is a needle holder? When you unlock it, when you open it, inside you can see there is a groove. Inside you can see there is a groove. बीच में गड्ढा दिख रहा है ना? Inside you can see there is a groove. So if there will be a groove, it means, remember here, this is a needle holder. In needle holder, there will be a groove. There will be a groove. Very easy to understand. For a needle holder, you should be understanding this. All these points are clear to everyone, right? Fine. This is needle holder. Needle holder means what? For suture needle I am talking about. Suturing needle. Next. Yeah, so during the surgery, when I have to hold the fascia, I'm sure this forceps, so many times you would have seen this one. So this is actually what? Alice forceps. Alice forceps, right, to hold the fascia for time being, to hold the fascia. This is called Alice forceps. Why it is important to memorize all these? Because like in operation theater, when you are a surgeon, when you are operating, when you need surgical instrument, a nurse will be there to assist you. Like at that time, you cannot say, Sister G, give me that instrument. No. You have to take the name. Sister G, give me Alice. Sister G, give me this retractor, this Zerny. I want Zerny. I want this forceps. I want mosquito, like that. Okay. So you have to memorize the name here. Now, Alice forceps we have learned here. Like this is actually what? Alice forceps only. Alice forceps only. Alice forceps to hold the fascia. Next. Suppose if I'm doing abdominal surgery to hold the bowel for time being, right? To hold the bowel, to separate it, we are using Babcock's forceps. This is called a Babcock forceps. Okay, so there will be no tooth, because if there will be a tooth, if there will be a tooth, this can damage it, So like it will be actually blunt. So here this will be actually blunt, right? No, it will be blunt. So to hold the bowel, we are using Babcock forceps. Next. Now, forceps actually tooth-head. See here, I'm sure. So one photo is here. Actually, one more photo was here. So this got removed in editing. So one forceps you can see here. Here at the tip, you can see this is completely plain. Right? This is called as plain forceps. This is called as plain forceps. Plain forceps. But one more same forceps will be there, where you can see like there will be a tooth in front of this. There will be a tooth. What is called the tooth head? Right, it is called the tooth-head forceps. Can you answer me? If I am operating over here, I'm asking my junior assistant to retract or to hold the skin, right? To hold the skin for some time. So to hold the skin, I should be using plain forceps or toothed forceps? Can you answer me? I should be using plain forceps or toothed forceps? All of you, please answer me. Please answer me. Okay, so you are saying plain. My dear friends, please understand here. If I have to hold the skin, no. If I will be using a plain forceps, no, I will have to hold it very, very tight. I have to apply a pressure, no. I can crush the skin. I can damage the skin. So remember here, to hold the skin, we should be using, remember here, to hold the skin, we have to, remember here, to hold the skin, we have to use toothed forceps. Toothed forceps. Toothed forceps. Remember here, toothed forceps, although it will be pointed, but you don't have to apply huge pressure. Okay, no. So remember here, so we are using forceps to grasp, right, to retract or to stabilize the tissue. So if I have to hold the tissue, if I have to hold the skin, I will be using toothed forceps. So where do we use non-toothed? Where do we use plain forceps? Like if I have to pass suture or if I am holding needle for time being. Okay, fine. All these points are clear to everyone? Remember here. Chalo. So especially for the bowel, can you answer me which forceps we have used? Babcock's we have used. Babcock to hold the fascia. In the beginning I have shown you one image. Alice forceps. Needle holder, what was the special point about needle holder? How will you identify whether this is exactly a needle holder? Right? How will you understand that? There will be groove. There will be groove inside, right? There will be groove. Now, so like see, so many times we have to hold the gauzes. Actually, these are same like these are actually called the gauzes, right? Now these are called the gauzes, right? No, gauzes, or you can say part of the bandage also, right? No, part of the bandage. So suppose if I have to operate a patient, I have to clean this area. So obviously I will be using, first of all, I'm going to clean with the betadine. After that, again, I will be using spirit, right? No, first of all, a spray, then betadine, then easy to understand. Basically, betadine is nothing but the povidone iodine, right? Now, povidone iodine, right? Now, antiseptic. So how to clean the surface area? Can you answer me? How to clean the surface area? Obviously, you are not going to use your hand, okay, with hand going to clean like this. Obviously, no. You are going to use a gauze, a piece of the cloth. So this gauze I am going to use. So which instrument I am going to use for this? Which instrument? This is called as sponge holding forceps. This is called as Forster. Remember, this is called a Forster sponge holding forceps. Right now, sponge holding forceps. All this you are going to see in operation theater, in minor operation theater also. And whenever you'll be visiting surgery department, obviously you are going to see. So sponge holding forceps. Right? You can say what? These are called the gauzes, or you can say sponge. Next. Now, see, I have to operate over here. I have to operate over the chest. So when I have to operate over the chest, do you think I am going to keep the patient 100% naked? I am going to remove each and every portion of the cloth there? Obviously, no. Remember here? Yes. See, remember here. So what we are going to do here? If I have to operate over here, no. So I have to close the remaining part. Only this much portion I am going to keep open. Only this much portion I am going to keep open, okay, 10 centimeter from both sides, from like up and down also. I have to keep it open. So we are using surgical towel. I'm sure you would have seen the green color towel in operation theater. All these are sterile towels. Sterile towels hote hain sab, sterile towels. Remember here, so like suppose if I have to operate over here, I have to keep a towel over here, and basically I have to close the remaining part. But how to hold the towels in the position? We are using a clip. And this clip is called as myoclips. And this is called as myoclips, right? To hold the sterile towels. Right now, this is called a myoclips. Remember it. All these points are clear to everyone. This is called a myotowel clip. Okay, fine. Very easy to understand. So, yes. After that, like see here, one more towel clip is there. But if shape is like this, this is called as what? Remember here, this is also the towel clip only. But this shape is called as Doyen's Doyen's clip, right? Now this is called as Doyen's clip, right? Doyen's clip. Next, scalpel and blade. This is called as what? Bud Parker handle. Bud Parker handle, or short form you can say what? This is called as a BP handle. This is called as BP handle. So basically a scalpel where you are going to fix the blade. So like for every scalpel also size is different. So like one size will be only 3, second size will be 4. So at the lower part you can see here size is mentioned here. No, this scalpel size is only 3. The question is that how do you hold the scalpel? Are you going to hold the scalpel like this or like this? How to hold the scalpel? Can you answer me? How to hold the scalpel? You have to hold the scalpel at ease. Hold like a pen only. Hold like a pen. Hold like a pen, right? At the easiest method. Hold like a pen. And whenever you are going to give incision, it should be very, very smooth. What is the definition of a surgeon? What is the definition of a surgeon? Your eyes should be like eagle. Heart should be like a lion. Okay? And a stamina should be like a camel. And your finger should be like lady finger, like very, very smooth. Like if you have to give incision, no, right? Like it should be very, very smooth, very, very smooth, right? Very, very smooth, so that you should not be damaging so many structures. So hold like a pen only, hold like a pen. Very easy to understand, hold like a pen. So remember here, size of a scalpel will be either 3 or 4. So with the 3, you can use a small sized blades. You can use a small blades. With the 4 scalpel, you can use big blades. I will show you all blades also. I will show you all blades also. Okay, remember here, so size number, like size of the blade like 11, 15 or more than 20, size 4, size 4. Okay, now see here, basically this is a scalpel and this is the blade. You can see here, for the blade you can see there will be a separate packet here. Here you can see the number of the blade is mentioned here. Number of the blade is actually 23. Actually remember, there are so many surgical blades. See here, all these are surgical blades which we are using in operation theater. All these like 10, 11, 12, 15 also, 20 also, 20 also, 21 also, 22, 23, 24, like that. So now you have to keep in mind only 5 or 6. You have to keep in mind only these 5. Very, very important. See, first of all, always keep in a sharp and the pointed 11 size. Sharp and the pointed, this is the 11. Number is 11 only. Number is 11. So this, where will you use it? Like this is sharp and pointed. No, if I have to puncture, right? If I have to puncture, if I have to do incision and drainage. Incision and drainage, yes. So remember here, size number 11 we have to use for arteriotomy, incision and drainage, and where I have to stab, right? Stab incision. But remember, yes, remaining all we are using for skin incision. Remaining all we are using for skin incision, but please add here size number 12 we are using for the removal of suture. So that will be actually somewhat like everted type. Okay. Fine. Now, where do we give incision here? Now, you look at the shape of the size number 10. So here, like surface area will be from here to here. Okay, for most of the skin incision, we are using size number 10. But for the micro surgery, for the plastic surgery, we are using, like see here, this is very small only, no, size 15. Size 15, but you have to give incision over the major surface area where there will be the tough tissues. You can use size number, like you can use size number 20, 22, 23, like that. So these are actually big blades. So remember here, first of all, if I have to do incision and drainage, size number 11. For normal skin incision, size number will be 10. Right? For microsurgery, size 15. Remaining all big surgeries for big incision. Remember here, for long incision, for the abdominal incision, size number will be 20, 22, 23, like that. All these points are clear to everyone? Fine. So if I ask you one question here, that I have to give skin incision for the pediatric surgery. Like suppose if there is a 5-year-old child where I have to operate, if I have to do skin incision, I will be using size number 10 or 15. Can you answer me? If I have to do a pediatric surgery, so I will be using size number 10 or 15. Obviously, I will be using size number 15. Size number 15. 15 for, remember here, for microsurgery, minor surgery, plastic surgery, for the pediatric surgery, size number 15. Because remember here, see surface area to cutting area of 15 is small, and the see surface area for the 10 is bigger, right? All right. Chalo, fine. Now, okay, fine. To cut the tough tissues and ligaments, the normal seizure, what you see in hospital, that is also called a what? Myo seizure. But for the towel clip also, there was the myo towel clip. So one was the myo towel clip, second was the Doyne's clip, right? Okay, especially for the bowel, which forceps? Babcock's. And suppose if I have to hold the gauze, hold the sponge to clean. Foster sponge holding forceps. Sponge holding. I have shown you two forceps. One was the toothed, second was the non-toothed. So like for skin holding, like for retraction of the skin, I will be using toothed. Toothed. Yes? Yes. Very good. Now, see here, now you see this seizure here. So like at a one side, this is actually blunt. Second side is the pointed here. So if I have to cut the bandage, you know, if I have to cut the bandage here, so like under the bandage, I can insert the blunt part, and over the bandage, there will be sharp. This is called as a Lister bandage cutting seizure. This is called a Lister bandage cutting seizure. Lister bandage cutting seizure. Easy to understand, right now? Lister cutting bandage seizure. If I have to cut, if I have to remove the bandage, remember here, Lister seizure. Lister. Yaad rakhna. Very, very important. You have to memorize all these. Now, mosquito forceps. So when I'm, like suppose if I have given incision over the abdominal part, over upper limb, lower limb, anywhere. So when I have given incision, when I am operating, so during surgery, do you think there can be damage of some other blood vessels also? Yes, no. Suppose if you do not have monopolar cautery, suppose if there was a big blood vessel which got ligated, which got, there was a somewhat bigger size blood vessels, which got cut. So how to stop the bleeding? How to achieve a hemostat there? At that time, I can use a forceps. I can use a forceps which can clamp the blood vessel, which can obstruct the blood flow over there. So remember here, so this is also forceps only. This is called as mosquito forceps. Halsted mosquito forceps. Mosquito forceps to clamp the blood vessel to achieve hemostat. But remember here, on the basis of the shape, this mosquito forceps can be curved, and this can be straight also. This can be straight also. This can be straight also. So as per the requirement, remember here, mosquito forceps, small forceps, mosquito forceps. Right now, this can be curved, this can be straight also. This can be straight also, right? Very easy to understand. I hope you are able to understand all these points here. Surgical instruments, you have to recognize at least one question from the image-based question you can expect. Okay? Now, okay, fine. Suppose if I am going to operate, and if I have to hold the gland or a fascia, right now, like at that time, see, remember here, like it, especially to hold the glands or the smallest structure out of fascia. So this is shape. This is called as Lane's tissue forceps. Lane's tissue forceps. Lane's tissue forceps. Okay. Next. Now, very, very important. I think last time this was the FMG question. Very, very important needle. This is called a Venous needle. Remember, a very, very important Venous needle during laparoscopic surgery. And I see before laparoscopic surgery, first of all, we have to create pneumoperitoneum, like a space we have to create, So first of all, we are inserting a needle. Remember here, you cannot take a chance to forget this needle. This is called a Venous needle. So like mostly like the entry point will be umbilicus, because of what? Because of very, like skin will be very, very, like it will be very, very thin. And there will be lack of blood vessels also. And so we most commonly the entry point will be umbilicus. We are inserting this, and see, if first of all we have to make it clear whether exactly we are into the peritoneal cavity. How we are going to infuse saline, we are going to take it out right now. So when you are exactly into the peritoneal cavity, after that you are going to infuse CO2, okay, carbon dioxide gas, right, to create pneumoperitoneum here. So this needle, remember here, this is called as Venous needle here, right, for induction of pneumoperitoneum during laparoscopic surgery. This needle is very important, okay? So which gas we are using to create pneumoperitoneum? We are using carbon dioxide. We are using CO2 gas, okay, carbon dioxide. Now, see, for a liver biopsy, this is actually what this is a cannula here. This is a cannula, and inside you can see here the needle here. This is called as Silverman biopsy needle, especially for liver biopsy needle. Remember here, this is also old question here. This is called a Silverman liver biopsy needle. Liver biopsy needle. Whenever you suspect, whenever you have to do biopsy of the liver, yes, no, so you can use this needle. You can use this needle, Silverman. So remember, Veris needle and Vim Silverman biopsy needle. Biopsy needle. Now, when I have to do what, a venous section, when I have to perform venous section, you know, so when do we perform the venous section? Actually, remember here, right? Remember here, suppose if, like, we can use here, suppose if we do not get any, like suppose if all the blood vessels are fully collapsed, we don't have any access to the peripheral blood vessels and all. So what we can do, we can give, see, under local anesthesia, we can give one incision. After that, like, we have to identify a vein. We have to identify a vein. So vein, how you are going to understand whether this is a vein or not? So like suppose if we are going to do, like if we are going to ligate around there, no? So this portion is actually blunt. It is not going to damage the blood vessel. It is not going to damage any of the structures over there. This is called as aneurysm needle. Aneurysm needle. Okay, aneurysm needle during venesection. Venesection. Now this one, please remember here, right? To hold blood vessels, we have one big artery forceps, which is called a Spencer Wells, Remember Spencer Wells artery forceps to hold blood vessels. This can also be curved. This can also be straight. Same like the Halsted mosquito forceps, right? For hemostat here to hold the blood vessel. This can also be straight and curved, but size will be bigger than mosquito, obviously. Now, the most anticipated topic, the most anticipated image-based question. This is a special knife which we are using in the plastic surgery department, where suppose if I have to harvest the skin, this, like when I have to harvest the skin from here, right? No, can you answer? Like suppose if there was a patient of burns, a severe laceration over the chest, severe burns over the chest. If I have to do skin grafting here, I have to harvest the skin, no. So mostly we are using the thigh area. To harvest the skin, right? To take out the skin, Remember here, so the knife which we are using to harvest the skin, this knife is called as Humbee's knife. I'm telling you, please make a circle here. This is most anticipated image-based question. Humbee's knife we are using for skin grafting, for skin harvesting, and then we have to do grafting. Okay, like in a case of plastic surgery, in a case of, after burns, yes. Now, see, bone cutter here. Now, suppose like if we were operating like across the body, like suppose if we have to dissect, if we have to cut a small portion of the bone, so this instrument you can easily understand here. Now, this you can easily understand here. Yes, this is a bone cutter here, small portion of bone if you have to cut. This instrument is bone cutter here. Yes, bone cutter here. But like remember, same cutting, same lab. But if you have to cut ribs, can you answer me? Like in which surgical situation I have to take out the ribs? Or if I have to cut out the ribs, like if I have to cut the ribs, in which condition? Okay, like chilo one, like suppose if I have to, suppose if there will be, like fracture of the multiple ribs and all, like if I have to operate over there, suppose if I have to do, okay, but like especially in a case of plastic surgery, ear reconstructive surgery. Suppose if there was a person who was sitting in a bus, so like he was sitting at the window side here, so his half part of the face was out of the window of the bus, right? Okay, so remember here from the opposite side, one more bus came, and after that there was huge collision, side to side collision in between the buses, and he lost his one ear. If I have to make one new ear, so ear is made up of the cartilage only, no? Cartilage. Now I have to harvest a portion of the cartilage. So can you answer me from where I harvest this much big cartilage? Can you answer me? I have to use the cartilage to make new ear. Can you answer me from where I can harvest this much big cartilage? Okay. So yes, we can harvest the cartilage from ribs. This we are using in plastic surgery department. So can you answer me, out of 1st to 12th ribs, which ribs will be having longest or biggest or maximum of the cartilage? Remember here, 6, 7, 8th, 6, 7, 8th, 6, 7, 8th. Ribs will be having the longest or the maximum cartilage. So there also, if I have to take out it, no, so remember here, yes, like we can use this kind of instrument, rib shear. Okay, fine, right? All these points are clear to everyone. See here, floating ribs will be having 100% bones, no cartilage there. Floating ribs will be only bones. Okay, fine. So rib shear. Okay. Now, see, okay, during the surgery, if you have to transfer the instrument, or suppose if the nurse has to give you some instrument, I know, so which instrument she can be using to pass the instrument here? Remember here, this is called a kettle forceps, right? Or this is called the kettle forceps. Remember here, very, very important here, simply to transfer the, like, all the instruments during surgery. This forceps is called a what? Kettle forceps, right? Now, remember here, like in a case of the gallstone surgery, we are using a forceps to remove the stone, right? So this is called a what? Desjardins forceps. This is called as Desjardins forceps. Remember here, Desjardins forceps to hold the stone, right? To pick the stone and to remove it out. Desjardins forceps. Now, especially in a case of the hemorrhoid, like if I have to visualize inside the anal canal or rectum, this is called the proctoscope. All these, see here, all images what I have shown you here, no, these are frequently used in surgery department also, and these are frequently, yeah. So this is actually a proctoscope to visualize inside the anal canal or the rectum in a case of the hemorrhoids, piles. Yes. Now this we are using, this is actually used as a, yeah, this we are using as a trocar only. So basically, like during the surgery of the gallbladder, if I have to decompress the distended gallbladder, no, I can use this instrument. This is a type of the trocar only. Okay, fine. Now, right, to suppose if I am operating for the appendix, or maybe like around, you know, like around the neck or around the abdomen, anywhere. So like for time being, I have to retract the open space. I have to retract from the both side. So there I can be using a retractor, that is called as, so if you see the shape, both side will be bended. This is called as Zerny retractor. Right now, Zerny retractor for the retraction of the tissue, Zerny retractor. Remember here, both sides are bended here. But if you can see, like in a case of, remember here, like especially if you have to like separate the hard structure, like the tissue or bone, right? So this is, so this shape of instrument, this is called a what? Beckman-Wittlaner retractor. Beckman retractor, remember it? But suppose now I'm showing you one more photo here, like this is somewhat smaller size, you can see here, somewhat like fork here, that is somewhat like fork like this, like a paw type, no? So like since this is a bigger, this is actually what? Volkmann retractor, especially to retract skin flaps or fascia. Okay, remember this is called as Volkmann retractor. Right now, so like see, in this manner we are using Volkmann retractor, right, to expose the area so that main surgeon can operate peacefully, right, to retract the tissues. Remember, first I have shown you both sides were bended, Zerny. After that big one, so that was actually what? Beckman. After that, like see here, like I have shown you this one. This is actually which one? Volkmann. Okay, Volkmann. Now, see, size is actually a smaller, same like a cat paw, right? For the micro surgery, a small, same like a cat paw, but both, I see one side it is like a paw, another side it is bended. It is called this is known as cat paw retractor. This is called a cat paw retractor for micro surgeries if we have to do micro surgeries. Now, see here, now like, yeah, actually not this one. Yeah. shape like, see here, shape is like the journey. Shape like is like the journey only, but one side is not bended here. So this is called as, so this shape is called as Morris retractor. This is called as what? Morris retractor. Only one side is bended. This is called as Morris retractor. Same like for the tissue retraction only. For the tissue retraction only. For the tissue retraction. Now, see, shape is like this, like if you can hold it, like especially in a case of what, rectal dissection, so that you can hold it like this. No, this is called the Kelly retractor, especially used in the pelvic surgeries, especially used in the pelvic surgeries. But if shape is like this, like see, this is completely blunt. If I have to retract the liver, so liver retractor, this is called a Devers. Dever is for liver. Dever is for liver. Yeah, in this manner, you have to memorize. Dever retractor for liver. For liver. After that, you can see, like if shape is like this, especially in the gynae department, we are using this, like especially for what? Especially for suprapubic retractor. This is called a what? Doyne's retractor. Doyne's retractor. Remember here, especially during C-section, during the pelvic surgeries, right? Doyne's retractor. Now, yes, like see, this instrument is very, very important here. Like when I have to separate the neck portion, when I have to retract the neck here, right? Remember here, key, like from here you can open it. So this is called as Jawl's retractor. Jawl's retractor. Remember, especially for the thyroid surgery, or if I have to operate near the neck, this is called a Jawl's retractor. Jawl's retractor. Now, this one, yeah, this we may anticipate. This is actually laparoscope. This is actually laparoscope. Like at the entry point, you can see there is a camera here. At the entry point, you can see there is a camera here, so that I can visualize inside. This is actually laparoscope. This is actually laparoscope. Remember here, visualization of the surgical field, like it can magnify the field so that you can watch it clearly. This is laparoscope. This is actually laparoscope. So there should be no confusion. And now, see, remember here, suppose during the laparoscopic surgery, like if you have to use, like suppose if you have to create, pneumoperitoneum by open technique, at that time you are using this cannula. This is called as Hassan's cannula. This is called as Hassan's cannula. Okay, Hassan's cannula. Now, where do you use this kind of tube? Suppose if I have to operate, for a bile duct stone, I have to operate for a bile duct stone here. So there was actually some retained stones here. I have removed it, but after that, I want to keep a tube inside here. No, I want to keep a tube inside here, right? I want to keep a tube inside here, like for the retained stone. This tube is called a T-tube. This is called a Kehr's T-tube. This is called a Kehr's T-tube for the bile duct surgeries and all. We have to keep a tube that is called a Kehr's T-tube. And DP, this is called the double pig. This is called the double. Same, like this will be bended here like a pigtail, no, like a pigtail, like that will be turning like this. Actually, this is called a pigtail actually. So this we are using for the ureter surgery only, like especially for the ureter surgery, especially for the bile duct. This is called a DP stent. You can say what? Double pigtail. Or surgical instruments we have completed. All surgical instruments we have completed. And now, see here, now when we are going to shift the patient to operation theater. Now, suppose if the patient is on operation table. Okay, so what are the things which we have to keep in mind? What are the precautions we are going to take before surgery? If patient is on operation table now, so before anesthesia induction, what you are going to do? Right? What are the things which you have to perform, which you have to do before anesthesia induction? That is called as sign-in. Before a skin incision, now this is called the timeout. And before patient is leaving the operation theater, that is called as sign out. So before anesthesia induction, first of all, you have to recheck whether he is the same patient or not. Name of the patient. You have to check whether there was history of any allergy to the drug. Or like suppose You also have to see whether the consent was taken or not, whether the consent was obtained or not. Marking site of the surgery, this you have to perform. Remember here, suppose if I have to operate over here, I have to operate over here with the black marker or with the marker, I have to mark the incision site. See, like I have to give incision exactly over here, like around the chest, I have to mark the area with a marker. So that is called as what? Marked site for surgery, right now. And what is the actual disease? Yes, all these you have to check before anesthesia, before skin incision. Reconfirm about the patient, about the disease, about the surgical, what is the surgical procedure, right now. Remember here. And yes, you also have to check wrong limb, wrong organ. Suppose if there was a case of small mass in left breast, by mistake surgeon has removed right breast, so this can happen, this kind of mistake can happen. So this you have to do, this you have to recheck before skin incision. After surgery means whenever you are going to close the wound, no, please count all the surgical instruments. You have to count all the surgical instruments. See, this is the duty of the nurse, to check, to count, right, all the number of instruments. Right now, because if you are not going to count, no, like this kind of mistake, like especially to prevent, especially to avoid these kind of mistakes where res ipsa loquitur, doctor, you don't need to prove anything. Yes, doctor, you will be in jail for sure. So can you answer me, which BNS defines severe medical negligence act? BNS number 106. 106. Okay, so remember, so you have to count the instruments, you have to count the instruments. And suppose if you have operated for the gallstone, so you have to send the gallbladder to the histopatho lab, no? So you have to label the specimen, basically the specimen which you want to send to histopatho lab, you have to label it. Okay, you have to count all the instruments. Okay, and after that you also have to check whether all antibiotics were given or not. Remember here, fine. All these points are clear. And how much blood loss was there? Remember here, blood loss. How much blood loss happened during the surgery? This should be informed by the anesthesia doctor, not by the surgeon. Surgeon can say not so much blood loss, but actual blood loss, anesthesia doctor can tell you. Like on the basis of that, you can take further precaution. So remember here, so this is an important surgical safety checklist as per WHO. Sign in and the timeout and sign out. Okay. Now, next we are going to learn here. Yeah, after that, now we are going to learn about nutrition. So can you answer me, what is the best method to check? Okay, so can you answer me, what is the best method to check the nutrition level of the patient before surgery? Because like suppose if patient was malnourished, or if there was like suppose if there was actually the deficiency of nutrition inside the body, wound healing will be delayed and your surgery can be hampered. Okay, fine. So the best parameter to check, to assess nutrition in the surgical cases is serum albumin. Serum albumin. Old method like we had to check BMI, body mass index, like skin fold thickness of the skin fold thing of the triceps, right, mid arm circumference and all. These are old methods, but best method to assess nutritional level in a case of surgical, right, it is serum albumin. Remember here, when serum albumin is more than 3.5 gram per deciliter, it is good, it is healthy. Now, what are the IV fluids we are going to use? See, now we have started learning about nutrition. Very, very important here. So what are the types of IV fluids? Remember here, what are the types of IV fluids? What are the types of IV fluids? First of all, we are going to learn now what are the types of IV fluid. What are the types of IV fluids? One is called as same like watery fluid. This is called as crystalloid fluid. This is called as the crystalloid fluids. Very easy to understand. This is called the crystalloid fluids. Same like water, same like the clear water, like normal saline, Hartmann solution, or you can say Ringer's lactate, dextrose or plasma light. All these are watery fluid types, so these are called the crystalloid fluids. But if the fluid will be somewhat thicker, somewhat like you can say somewhat like milky, or solute will be higher, then it is called a colloidal solution. Colloidal solution like albumin, dextran, starch, and gelatin. Remaining all these are called as blood products. So how to understand which fluid to be given when? Suppose if this is the blood vessel, suppose if this is the blood vessel, this is the blood vessel here, and this is any tissue. Okay, this is blood vessel I'm mentioning here. Suppose if this is a blood vessel and this is any tissue, any tissue. See, in between this gap is called as, this gap is called as, see, the gap in between blood vessel and the tissues will be called as third space, or this is called as interstitial space. Okay, so whenever, suppose if I'm using normal saline, basically if patient went into shock, if BP was low, I have to give IV fluid. No, I have to give IV fluid. Suppose if I'm using a normal saline, which is actually a crystalloid fluid, when I will be giving infusion of normal saline, no, normal saline are this much small, very, very small actually, you know, that they can, see here, they can easily cross the blood vessel wall. So what does it mean if I'm using, you know, like if I'm using normal saline or ringer's lactate, there can be leakage also. This much point is clear to everyone. And there can be leakage also. Okay, this much point is clear to everyone. But suppose even after infusion of normal saline, even after infusion of ringer's lactate, I have given 1 liter or 2 liter of normal saline, but after that also there was no improvement in the blood pressure. Now I have to expand the volume. See inside here now, you see this is actually what, volume only, no, volume of the blood. Actually I have to expand the volume, so I can use a volume expander, plasma expander here. Remember here, now I should be using a fluid product which should not be able to cross blood vessel wall. Remember, so whenever I'm going to infuse albumin or a dextran, so they will be having higher molecular weights. Remember here, they will not be able to cross blood vessel wall. So they will be living inside the blood vessel only. That's why dextran is called as what? Volume expander. Very easy to understand. This much point is clear to everyone right now. So the colloidal solution, what are the examples of the colloidal solution? Like albumin, dextran, starch, and gelatin. All these points are clear to everyone. Now they are asking, see, repeatedly asked question, what are the ingredients of normal saline? What are the ingredients of Hartmann solution? Remember here, in normal saline, sodium chloride 154 ml. Remember here, 154 ml, 154 milliequivalent per liter sodium and chloride. 154. See here, mostly there will be no calcium. Remember here, so no calcium. Remember here, only sodium and chloride, sodium 154. But what about Hartmann solution? You can say, sir, Hartmann solution and ringer's lactate, what is the difference? Hartmann solution and ringer's lactate, can you answer me here? Hartmann solution or ringer's lactate, what is difference here? See, both are almost same only. Almost same. But remember here, slight variation in lactate. Okay, slight variation in lactate. Hartmann will be having more lactate than ringer's lactate. Okay, remember it. So in Hartmann solution, we are having sodium also, sodium 131, and the chloride 111 milliequivalent. Potassium will be 5, but what about the calcium? See, the calcium will be 2, and bicarbonate will be 29, lactate will be 29. These ingredients they already have asked. This one point is clear to everyone. Please remember here, Hartmann solution will be having more lactate. Now the question is that, suppose if I had a patient who had severe dehydration. Can you answer me? Suppose if I had a patient who had severe dehydration. Patient is having dehydration. Can you answer me how we are going to check whether my patient is completely dehydrated? Bolo. How to check that? Yes, if I can see the face, skin texture, lips, and the tongue, right? Everything will be dry. Everything will be dry. See, everything will be dry only. No, everything will be dry. So even there'll be dry skin, dry lip, there'll be the dry mouth, there'll be dry tongue. Okay, everything will be dry. And after that, patient will be saying, what, sir, over, like internal part, like near middle epicanthus, no. So here patient will say, sir, I'm having pain here. Actually, like it seems as if my eyes are going inside, andar ki taraf ja raha hai. So this is called as what? Sunken eyes. This is called as sunken eyes. After that, look at the forehead of the patient. Look at the forehead of the patient. See, normally if you look at the forehead, no, overall forehead will be shining. If there will be normal water in your body, no, forehead will be shining, right now, forehead will be shining. But if there will be dehydration, there will be loss of luster. There will be loss of luster. There will be loss of luster. Loss of luster means what? Loss of shining from the forehead. And even if you are going to pinch the skin, right? If you are going to pinch the skin, you are going to like when you are going to leave it, no, like this will be going back. Suddenly if it is going back, it is normal. But suppose if you are going to pinch it, but slowly if it is going down, then I can say this is called as loss of rigidity. This is called the loss of the turgidity. How you will understand a newborn baby is dehydrated? Obviously, a newborn baby will not be able to speak out. So over the stomach, you are going to pinch. Over the stomach, you are going to pinch. Slowly, if it is going back, dehydrated. So in a case of the dehydration, IV fluid. So remember here, like if mild symptoms are there, mild symptoms, you can ask the person, hey, you have to drink more and more water. You have to drink. So actually, you have to drink the plenty of water. So like some more dehydration, okay, ORS can be taken. If patient is admitted in hospital, then IV fluid. Question is that, suppose if patient had a dehydration secondary to vomiting, frequent vomiting, can you answer me? What is the fluid of choice? Bolo. अगर मान लो secondary to vomiting है, secondary to vomiting, can you answer me? What is the fluid of choice? Secondary to vomiting, fluid of choice. Secondary to vomiting, can you answer me? Secondary to vomiting, when a person will be vomiting more and more. So my question is that, do you think you can use Ringer's lactate? Do you think you can use Hartmann solution? Secondary to vomiting. See, vomiting may there will be loss of hydrogen ion, hydrochloric acid. Hydrogen ion is actually what? Actually, that is the proton pump. So acid will be losing. So secondary to vomiting, there will be metabolic alkalosis. There will be metabolic alkalosis. So remember here, whenever there will be metabolic alkalosis, no, you should be using a fluid which can create some acidic environment in the stomach. Secondary to vomiting, dehydration is there. Fluid of choice is normal saline. Fluid of choice is normal saline. Okay, but suppose if a patient was having dehydration secondary to diarrhea, can you answer me? In diarrhea, so many minerals, so many things will be losing from the body. So for the diarrhea, secondary to diarrhea, Ringer's lactate, or you can say what? Hartmann solution. But one clinical question I want to ask you, suppose if there is a case of gastric outlet obstruction, and if there will be gastric outlet obstruction, there will be severe vomiting. Okay, so like if there is a patient of gastric outlet obstruction, do you think you can use Hartmann solution or Ringer's lactate? Answer me yes or no. Please write down in chat box. In a case of gastric outlet obstruction, can you use Ringer's lactate or Hartmann solution? Answer me yes or no. Think and then answer. See, in gastric outlet obstruction, severe vomiting will be there, no? Severe vomiting. Remember here how lactate will be functioning in your body. Remember here, when there will be more lactate infusion is there. More lactate. So lactate will be going inside. See here, After blood circulation, this will be entering into the liver, and after the liver, this will be forming what? So this will be forming more and more bicarbonate. This will be forming more and more bicarbonate here, more and more bicarbonate. So remember here, Hartmann solution or Ringer's lactate, this will be creating more and more alkalosis, more and more alkalosis. In gastric outlet obstruction, already there was severe alkalosis. This can be very much lethal for the patient. So in a case of gastric outlet obstruction, remember here, we cannot use Hartmann solution. Hartmann solution. So fluid of choice will be there also, normal saline. Okay, so there also it will be normal saline. So remember here, from here, frequently asked question, fluid of choice. Fluid of choice. In a case of burns, fluid of choice is Ringer's lactate. Septic shock, mostly, see, septic shock may, mostly we are using what? Normal saline. After the trauma, massive fluid loss, whatever fluid you have, you can use either NS or RL. NS or RL. Question is, what about head injury? What about head injury? After head injury, remember only one point here, you should not be using any solution which is having dextrose. You should not be using any fluid. You should not be using any fluid which is having dextrose. Why? Because this is going to aggravate edema. This is going to aggravate edema. Aggravate edema. Okay, so remember here, fluid of choice is normal saline. My question is that in head injury, why not Hartmann solution? My question is that in a case of head injury, can you answer me? In a case of head injury, why not Ringer's lactate? In a case of head injury, why not Ringer's lactate? Why not Hartmann solution? Why normal saline is the fluid of choice? The injection of mannitol you have to give. See, the drug of choice to subside edema is mannitol only. Mannitol only. That is the drug of choice. Injection you have to give. I'm asking about fluid of choice. Why normal saline? Why not Ringer's lactate? Why not Ringer's lactate? Okay. My question is, why normal saline is called as normal? Because it is isotonic to the blood. Isotonic to the blood. Now, see, this is blood. This is blood. And this side, I'm writing normal saline. And this side, I'm writing Ringer's lactate or Hartmann solution. Blood 0.9%. When I talk about normal saline, no, it is almost similar to blood, not 100%, almost similar to blood. But when I compare Ringer's lactate, than blood, this is somewhat hypotonic than blood. Hypotonic, and normal saline, this is somewhat I'm saying, not more, somewhat hypertonic than blood. So now, what is the significance of this? Basic physiology, I'm sure you are able to recall that hypertonic fluid attracts hypotonic fluid. Yeah, na basic physiology, hyper attracts hypo. Hypertonic fluid attracts hypotonic fluid towards itself. Yeah? Okay. Now, if there is a case of head injury, if there is cerebral edema from the blood vessels, now the blood has been leaked. Cerebral edema is there. If you are going to use a Ringer's lactate, now what will happen? No, like inside the cerebral part, like in the cerebral edema, blood will be attracting more Ringer's lactate, and there will be more and more edema. So this will aggravate edema. That's why Ringer's lactate should not be used, because it is hypo. We are using normal saline because it is somewhat hyper, no. So when you are infusing normal saline, no, so this is going to attract blood from the cerebral part here. So this will subside somewhat edema. Easy to understand. Remember here, that's why in head injury, normal saline is the fluid of choice, not the Ringer's lactate and not dextrose. Easy? Right. All these points are clear. I hope fluid of choice is clear to everyone. ठीक है? काफी है, right? Yes. Now, suppose if I have to give actually TPN for the nutrition, suppose if I have to give TPN is what? Can you answer me? TPN is what? Total parenteral nutrition. If I have to give TPN. So when patient is not able to take it, when patient is not able to consume any food like on his own, and he cannot have, right? At that time, suppose I have to give TPN, I have to give actually fluid from outside or any nutrition from outside. So either there can be enteral route. Enteral route means what? Enteral route means what? Route will be GIT, right? No, gastro. And there can be the parenteral route. There can be parenteral route, like means via blood vessels. So I can use nasogastric tube, nose to a stomach, which is a Ryle's tube. Nose to a stomach, Ryle's tube, nasogastric. Nose to jejunum, nasojejunal, which is called a Freka tube. But suppose if the esophageal part that is actually damaged, or if there is a case of what, like if there is a case of, like obstruction over here, any pathology in the esophagus, I cannot use here. No, I cannot use here. So directly now I have to use a surgical method. Now I have to use the PEG tube. This PEG tube is the percutaneous endoscopic gastrostomy tube. Surgically under the guidance of endoscopic, right? Endoscopy, I have to insert a tube in the gastric part. That is called a PEG tube. That is called a percutaneous endoscopic gastrostomy. CVP we have learned. Can you answer me here? Can you answer me which vein for central line, which central line is the best for TPN, for nutrition? Can you answer me? Internal jugular vein, subclavian vein, or femoral vein? All of you, can you answer me? All of you, can you answer me? Which vein is best for TPN? Which vein is best for TPN? Which central line is best for this? Subclavian vein. Subclavian vein is best. So can you answer me, what is the best vein for central line after any trauma, after any accident where I have to do massive fluid resuscitation? After trauma? Yes, internal jugular vein. Internal jugular vein. This much point is clear to everyone? Okay, fine. Now see, so can you answer me? The rate of infection, risk of infection will be maximum with which central line? Which central vein here? Subclavian vein, internal jugular vein, or femoral vein? Can you answer me? Risk of infection is maximum with femoral vein. Very good, very good. Ryle's tube, I'm sure. Can you answer me here? First of all, read this question, and what is the position for the insertion of Ryle's tube? What is the position? What is the position for? Bolo, answer karo. All of you. Ideal position for Ryle's tube insertion. Be careful, you are not focusing that patient is in coma. You are not see here, no. I'm asking you Ryle's tube insertion, not in a normal person. I'm asking you that you have to fix Ryle's tube, but patient is in coma mein. And so in coma, a patient will be in the sleeping position, lying position. Are you going to first of all, pehle utھ ke baith phir ghusao? Aise thoda na hota hai, right? So remember here, very, very important. Remember here, normal for the full conscious position. Remember, sitting with the neck flexed. Sitting with the neck flexed. Sitting with the neck flexed. But if patient is in coma, supine with the neck flexed. Supine mein hi, but neck flexion should be there. Neck flexion should be there. This much point is clear to everyone, because in this position only there will be, means easily you can see like the difference where you can insert your food pipe and windpipe here. Now the question is that how you are going to measure the length. How you are going to measure the length of the Ryle's tube. How much length of Ryle's tube should be inserted in, inside the stomach. Okay, no, so there is a rule that is called as a next rule. So first of all, you have to measure from the nose to ear, after that lower part of the sternum. Nose to ear to sternum or Schiffer's process. In this manner, we measure length of Ryle's tube to be inserted inside. This is called as a next rule. Next rule. This is called as a next rule. But what about the pediatric age group? NEMO rule means nose to ear to in between Schiffer's process and umbilicus. In between sternum and umbilicus. Please remember it. All these are old questions. Whatever I am teaching you now, all these are old questions. After that, how to understand that see here, how to understand that the Ryle's tube which you have inserted, that has gone inside, like inside the stomach or inside the thoracic cavity. It could be possible, mistake can be there, no, mistake can be there. How to confirm it? Because like suppose after that, if you want to give any, drug or any fluid, what if you have inserted inside the thoracic cavity? Patient can die on the spot, right? No, aspiration can be there, no, right? So remember here, yes, like one very common method we are using a syringe of, we are using a syringe of the 10 ml, right? So like air of the 10 ml air we are going to push, right? Now here we can hear the tuck sound, right? Air pushing, actually air pushing, that is okay. But how to confirm? How to confirm? Remember here, aspirate, and you have to test for acidic pH, right? Now hydrochloric acid, aspirate the fluid, and you have to test for acidic pH. Even we can do X-ray also, because the tip, because the tip will be having somewhat of like this will be formed somewhat of lead, so that can be appearing on the X-ray. So we can do like X-ray also. Chalo, this much point is also clear to everyone. Now remember here, what are the clinical correlation of Ryle's tube insertion? When you try to insert the tube inside, and if there was the coiling of the tube, it did not go inside, then mostly your child, the patient, is having the tracheoesophageal fistula, right? Fistula in between, fistula or bridge in between airway and esophagus, that is called the tracheoesophageal fistula. There can be coiling of the tube, okay? Or suppose if the tube is going toward the left side, so this can be seen especially in a case of the congenital diaphragmatic hernia, right? Especially in a case of what? Congenital diaphragmatic hernia. Remember here, in which condition Ryle's tube should not be inserted. Remember here, suppose if there is a varice, like suppose if there is a bleeding from the esophageal varices, suppose if there was, like acid poisoning, alkali poisoning, or if there will be the kerosene poisoning, please don't do this. Please don't insert this, because there will be a risk of aspiration. There will be a risk of aspiration, or even, that can come up. That can come up also, and there will be further damage of what? Esophagus also. Even if there will be a case of the base of a skull fracture, please don't use Ryle's tube. So now remember here, after that, Freca tube, nasojejunal tube. From the nose to the jejunum, so it will be actually very long. So like, yes, we are using if patient is completely unconscious, right? Or suppose if there is a case of what? Duodenal fistula also, duodenal fistula. Yes, if there is a case of what? Acute pancreatitis. Yes, for the feeding purpose and all. Remember here, this picture, remember here, this is nothing but the Freca tube. Ryle's tube we have seen nasogastric only, but longer tube if you want, that is Freca. Freca tube is what? Nasojejunal. You have to memorize the name of these tubes. You have to memorize. Can you answer me? Which forceps we have used to hold the bowel? Answer me. Answer me, all of you. Which forceps we have used to hold the bowel? Babcock's forceps. Babcock's. Yes. अच्छा वो क्या था? To hold the sponge. To hold the sponge. Right? To hold the sponge. Okay, sponge holding forceps, you can say, or Foster sponge holding forceps. Okay, if you want to retract skin, toothed forceps or non-toothed forceps? Toothed forceps. There was a big retractor, and shape was actually, see, okay, bended from both sides, bended from both sides. Which retractor? Zerni's retractor. Zerni's retractor. For micro surgeries, I have shown you a small one, actually, same like a paw of a cat. Yeah, that was called the cat paw retractor. Which needle I have taught you to create pneumoperitoneum before laparoscopic surgery? Name of the needle, please. Veress needle, right? Veress needle. Which needle we have learned for biopsy, liver biopsy? All of you? Silverman. Yes? Fine. All these points are clear to everyone. Nasojejunal tube. But suppose if there is the obstruction over here, suppose if there will be obstruction over the esophagus, now you have to go for what? Surgical procedure here. That is called the PEG tube. Remember here, Right, okay, this is called the peg tube. You have to give incision over the stomach part. After that, you have to insert it. But like it should be what? Endoscopic guided. Endoscopic guided here. Endoscopic guided. Suppose if there will be obstruction, then it should be radiologically guided. Radiologically guided. Feeding tube, or you can say what? Like gastrostomy tube. Gastrostomy tube. Remember, this is the peg tube said. I have seen this question. They already have asked in INICT. This set, where do we use this set? Remember, if you can recall only this, ये जो circle दिख रहा है यहाँ पे, circle you can see here, circle. You can see the 3 circle here. You can see the 3 circle here. Yes, you can see all these structure. This is a complete set for peg tube. Remember, just image if you can recall on this will be more than enough. See, remember, you have to recall about the 3 circles here and all the, this is a complete, remember, this is a complete set for peg tube, peg tube. This is important. This is important. Right now, peg tube, yes, you can see here, very easy to understand, directly inside the gastric part here, directly inside peg tube. Okay, now, remember here, this repeatedly asked question, this is actually your TPN. What is TPN? Total parenteral nutrition. Total parenteral nutrition, where patient is not able to take it orally. After that, we have to take it from outside. We have to give it from outside. You can see here there is a big compartment first of all. After that, somewhat, and this is smaller actually. Remember, this is smaller. So remember, we have to give a component of, there should be, like see here, we have to give carbohydrate in the form of the dextran. We have to give the proteins in the form of the amino acids, and fat actually lipids. So ratio will be 60:20:20, 60:20:20, 60:20:20. Okay, so maximum you are giving what? Maximum you are giving glucose. Maximum you are giving what? Carbohydrate. Carbohydrate. Remember here, one packet will be having full energy for 1 day. One packet of TPN will be having full calorie for 1 day. Means apart from the fat, apart from the fat or the protein or the carbohydrate, there will be minerals, vitamins, and electrolytes. Like it will be there, right? It will be there for 1 day. Okay, fine. So basically, one packet will be having full calorie for 2000 calorie. But remember here, sometimes, suppose if the patient is already having fatty liver, or if there will be jaundice, at that time, you should not be giving fat from outside, no? So now you have to give what? Fat-free TPN. Fat-free TPN means what? Only carbohydrate and amino acids. So now ratio will be actually what? See, the 75% of carbohydrate, only 25% of the protein. Basically, ratio of the carbohydrate and protein will be 3:1. 3:1. Now, see, one question related to clinical practice in hospital. One question. Remember, whenever we are going to get the TPN bag, whenever we are going to fix in the, like in the blood vessel, anywhere, wherever we are going to fix it, okay, every time we have to cover it. We have to cover it. We have to protect the vitamins inside. We have to cover it with a bag or with a towel. Basically, we have to cover it. We have to cover it. First thing, right? Every time we have to cover it. Now, for any reason in between, suppose if you had to detach it, for any reason, suppose if you had to detach it, after that it should be discarded. Same TPN should not be used again. It should be discarded. Once you are going to detach it from the body, once you are going to detach it from the patient, after that discard it, please. Discard it. Same, you cannot reuse it. All these points are clear. Please remember it. All these points. Remember here, but because of the TPN where you are giving so much of carbohydrate, glucose, sometimes it can cause refeeding syndrome. Refeeding syndrome, old question related to pathology part. Refeeding syndrome will be more common with the TPN, right, than the enteral, Remember here? Okay, fine. So why there will be refeeding syndrome? Because see, suddenly there will be what? Increased glucose. Because of the hyperglycemia, there will be stimulation of the insulin. What insulin will do now? Like if there will be like more insulin, what insulin will do? Now from the blood, now it is going to take away the potassium to the, it is going to shift the potassium to the cells now. And so basically this will be causing what, like electrolyte shift, like it will be causing hypokalemia. Hypokalemia. After that, you can remember here that yes, there will be hypophosphatemia, hypocalcemia, hypomagnesemia. Remember here, abnormal potassium can lead to heart pathology. It can lead to arrhythmia, or it can lead to what? Congestive heart failure. That can be dangerous for the patient. And this is also causing, remember, this is also causing lactic acidosis. So refeeding syndrome is important for your exam. Refeeding syndrome, yes, it will be, right? Refeeding syndrome, this will be important. Old question. Now, second question. Now read this question and try to answer. Read this question and try to answer. Read this question and you have to take a decision. You have to take a decision. An adult male met an accident with a car, has been in deep coma for last 15 days. The most suitable route for administration of protein and calories is by. Can you answer me? See, first of all, I am saying only in coma. I'm not saying that his GIT is not working. If GIT is working, suppose if GIT is working, why will you choose actually any vein? Why will you choose blood vessel? So yes, you should not be choosing, you should not be using, remember, you should not be using like actually any blood vessel, you should not be using. Now, if you are going to use a Ryle's tube, patient is in coma, even if you are using, like even if you are going to use the gastrostomy tube, no, there will be risk of aspiration. Risk of aspiration will be there. So safe side will be jejunostomy tube feeding. Okay, jejunostomy tube feeding. This much point is clear. Remember here, in this manner, we have to understand, we have to rule out. We have to rule out. Now, next topic, we are going to learn shock. Can you answer me? How do you define shock? How do you define shock? All of you, can you define? How do you define shock? Inadequate perfusion to body tissues, lack of blood supply to the body tissues, lack of blood supply to the body tissues, shock. Shock. Now, next topic, we are learning about shock. Shock is one of the most important topics in general surgery, I'm telling you. If you know how to manage shock on daily basis, minimum you can save, minimum 2 to 3 patients, 4 to 5 patients on daily basis you can save in like surgical department, because most of the surgical patients, you know, they can die because of, you know, shock. I know. So shock means what? If there will be lack of blood supply to the, suppose if there will be lack of blood supply to the body organs or body tissues. So it means like there can be some pathology, like suppose if there will be pathology in the heart, after that there is a lack of blood supply, I can say this will be called as which kind of shock? This will be called as the, yeah, this will be known as the cardiogenic shock. है ना? Or if there will be any difficulty in lungs also, so cardiopulmonary shock. Okay. Now, suppose after a spinal injury, if patient is going into shock, so which type of shock? You can say this will be called as neurogenic shock. This will be causing neurogenic shock. Okay. Suppose because of severe infection, because of severity of the toxins, I can say septic shock. I can say it will be septic shock. Septic shock after road traffic accident, after huge blood loss, after burns. Can you answer me? After burns. After burns, can you answer me? When there will be loss of volume from the body, after massive blood loss, you can say hypovolemic shock. This you can say what? Hypovolemic shock. Hypovolemic shock, hypovolemia after road traffic accident, after burns, after massive blood loss. Yes, you can say what? Hypovolemic shock only, no? Hypovolemia, right? Hypovolemia after anaphylaxis, after severe allergy. Can you answer me which shock now? That will be called as anaphylactic shock. Very easy to understand. Naming is very easy now. Now let's understand pathophysiology about shock. See, first of all, basic pathophysiology. When heart will be pumping. Now remember here, within 1 minute, how much is the cardiac output? How much is the cardiac output? Remember here, within 1 minute, there will be 5 liter. 5 liter. So whenever, see, the cardiac output is actually your systolic blood pressure. This is actually systolic blood pressure. And a systolic blood pressure. This much point is clear. Systolic blood pressure is your, yeah, this is actually the cardiac output. But when, see, with the help of arteries, no, with the help of arteries from the heart, this is going to the peripheral parts. Right, now peripheral parts. So when there will be the pumping of the heart, whenever there will be pulsation in the arteries, so do you think there can be resistance felt inside the arteries also? So that resistance is called as, peripheral arterial resistance, which gives you diastolic blood pressure. Simple. Systolic blood pressure is your cardiac output, systolic, and the peripheral arterial resistance, that pressure is called what? Diastolic. After that, see, from the heart, if the blood is going to the peripheral part, now see the oxygenated blood, now the tissues will be utilizing the available oxygen over there, no? Okay, fine. After that, deoxygenated blood or utilized blood would like to come back to heart also now, no? So when the blood will be coming back, that will be coming from venous only, no? Veins only, no? So there will be resistance in the blood vessel of vein also. That is called as venous resistance. And now utilized oxygen, which the periphery, which these tissues have already utilized the oxygen, right? No. So now the utilized oxygen, now the oxygen, see, now the blood which is coming back to the heart, now after utilized oxygen, that is called as mixed venous oxygen saturation. Suppose like in the blood, 90% oxygen was used. Like suppose in the blood 90% oxygen was there, and approximately I would say 30% got utilized. So I can say now the mixed venous oxygen saturation will be 60% will be remained. Easy to, this much point is clear. So first of all, see here, see the cardiac output, systolic blood pressure, arterial resistance, that is called the diastolic blood pressure. Okay, one. After that, when the blood is coming back, venous resistance will be there. One is arterial resistance, backflow will be what? Venous resistance. How much oxygenated blood, how much blood is coming back? Okay, now which is going to give you the saturation of oxygen? That is called as what? A mixed venous oxygen saturation. This one point is clear to everyone. Ye to bahut easy hai. So now, every time you are saying, no, you have to see what? 120 by 80. 120 by 80. 120 by 80. This is the, yes, 120 by 80. This is called the normal blood pressure actually, right now. This is called what? Normal BP. Okay, fine. So see the numerator is systolic, denominator is diastolic. This much point is clear to everyone. Simple logic is that how do you define shock? In easiest language, how do you define shock? Remember here, whenever there will be fluid loss, now BP will go down. So when systolic blood pressure is less than 100, when systolic, see here, in the general term, when systolic blood pressure is less than 100, see, and to counter that, heart has to pump more, right? No? And when the heart rate is more than 100 per minute, hypotension with tachycardia, this is called a shock. See, this is the general term I'm telling you. This is the general term here. Hypotension with the tachycardia. It means your patient is going into shock. Remember here, whenever examiner is mentioning BP of the patient is actually 90 by 60 or less than 100, if you can say, it means you can understand, oh my God, my patient is in dangerous condition. Now, my patient is going into shock. I have to manage my patient with the help of IV fluid as soon as possible. This much point is clear to everyone. So the general term is less than 100 BP and more than 100 heart rate. So hypotension with the tachycardia. This is the general, this is always, okay? Hypotension with the tachycardia. It means what? Shock. Okay? Fine. Now, let's learn here. One where there was a loss of blood. When there was loss of blood happened, that is called as hemorrhagic shock or hypovolemic shock. Hemorrhagic shock, but hemorrhagic or hypovolemic shock. But there is a shock where there is no loss of blood, but redistribution of blood has happened. Because of that, patient is having low BP. So in septic shock, remember here, in septic shock, blood loss is not there. Blood loss is not there. Remember, blood loss is not there. Redistribution of blood was there. That's why patient went into shock. Let's learn here. So when there will be loss of blood, yes, there will be. When I talk about the hemorrhagic shock, hypovolemic shock, remember here, when will you declare that patient had hypovolemic shock or hemorrhagic shock? When loss of blood will be, when the loss of blood will be more than 2 liter, more than 2 liter, more than 2 liter. Loss of blood will be more than 2 liter. Okay, fine. So remember here, when there will be loss of blood after that, see, physiologically you can understand here, now there will be low cardiac output. Low cardiac output. If low cardiac output is there, no, when heart is giving actually less blood, so even there will be what, vasoconstriction over the peripheral arteries. So remember here, there will be what, like increased peripheral arterial resistance. There will be increased peripheral arterial resistance because of the vasoconstriction. If you touch the body, it will be cold. It will be cold. Okay, fine. And see, because see here, because the peripheries are not getting enough oxygen, so there will be more oxygen carrying to the peripheral tissues, no? So there will be more oxygen consumption. Because of that, when I talk about, see here, so when I talk about this saturation here, no, remember here, this one, mixed venous oxygen saturation, this will be decreased less than 50%. See, like even venous resistance will also be decreased, so that there should be more blood flow that should be coming to heart as soon as possible. But when I talk about septic shock, because of the severe release of the toxins, so many toxins, so much of the toxins in the blood, remember here, so because of this, there will be peripheral vasodilatation. There will be peripheral vasodilatation. Redistribution of blood. Okay, CO will increase. There will be increased level of the cardiac output. And remember here, there will be what? There can be the tachycardia. But remember here, now there will be vasodilatation actually. And because of that, there will be decreased peripheral arterial resistance. And because of that only, in a case of the septic shock, or you can say distributive shock, remember here, there will be warm peripheries. Warm peripheries. See, oxygen consumption is actually decreased, so there will be more lactic acid formation. Oxygen consumption is decreased, so mixed venous oxygen saturation will be more than 70%. Remember here, all these are the catchy point to solve questions related to shock. When, see, this saturation of oxygen is less than 50%, so this is hemorrhagic or hypovolemic. More than 70%, it is a type of what, septic shock, or you can say distributive shock. Distributive shock. Now different types of the shock. When I talk about the distributive shock, even neurogenic, even see the anaphylactic and septic shock, all these are examples of distributive shock. So remember here, in all these types of shock, warm peripheries will be there. But when I talk about, see the when I talk about hemorrhagic, hypovolemic, or if there is any pathology in the heart related to the medicine department, see the cardiogenic shock, remember here, there will be cold peripheries. Now, what are the important aspects you should be knowing here? Everywhere, remember here, systolic blood pressure will be decreasing. Everywhere systolic blood pressure. See, everywhere, remember here, systolic blood pressure will be decreasing. Everywhere systolic blood pressure will be going down, everywhere. And remember here, like everywhere, see the pulse rate will be increasing, everywhere. Except one condition. Remember here, there is only one exception here. In neurogenic shock, there will be low BP. With low pulse rate. Remember here, this is exception, and this will become your question. In which type of shock? You will see Hypotension with bradycardia. Hypotension with bradycardia. Please make a circle over here. Please make a circle over here. Yes, please remember here, it is only in neurogenic shock. Otherwise, everywhere there will be hypotension with the tachycardia. Hypotension with the tachycardia. Everywhere it will be there. But whenever there is one exception, in neurogenic shock, even pulse rate will be decreasing because of the spinal injury. Easy to understand. All these points are clear. If you can memorize this much, you can solve the question. Basic things you have to keep in mind. Remember here, mixed venous oxygen saturation means what one doctor is asking. Remember here, when blood is coming from the heart, when it is going out to the peripheral part, how much, see here, now this blood will be oxygenated blood, no. Now the tissues will be utilizing it. Now how much remained is coming back. Okay, that is called as mixed venous oxygen saturation. Okay, chalo, fine. All these points are clear to everyone. Remember here, now what is the best parameter to check fluid resuscitation? Because remember here, whenever there will be shock, remember here, IV fluid is the management. IV fluid is the management. Whenever you get a patient of the shock, 1 liter bolus of crystalloid fluid is the, say, IV fluid, 1 liter of bolus IV fluid you have to give, right? Okay, fine. So what is the best parameter to check fluid resuscitation in a case of shock? Urine output. Can you answer me for Foley's catheter? Which color of Foley's catheter we are using for females? All of you, can you answer me in chat box? All of you, can you answer me in chat box? Which color Foley's catheter for females? For girls, green color. For babies, black color. Black color for babies, right? And for males, for adult males, it is orange color. All these will be having how many lumens? Only 2 lumens will be there. Double lumens will be there. But a red color I also have taught you, which will be having 1 extra lumen. That was for blood irrigation. Blood irrigation. Easy to understand. Blood irrigation. All these points are clear to everyone. Remember here. Now, what is the best parameter to calculate how much amount of fluid to be given? We have to see what? Central venous pressure, CVP. Okay. Best lab value to monitor the tissue perfusion, serum lactate. Remember here, serum lactate. Okay, serum lactate. Very easy to understand. Now, if there will be a case of the septic shock, or if there will be a case of the cardiogenic shock, remember here, because there can be hypo or hyperdynamic state. Remember here, no. So like there is CVP might not be accurate here, no. So there you have to see what? Pulmonary capillary wedge pressure. All these are one-liner question. Now, see here, like on the basis of how much fluid has been lost from your body, shock can be classified into mild, moderate and severe. Class 1, class 2, class 3, class 4. Which shock is known as the compensated shock? Which shock is known as the decompensated shock? This is also an important topic. Remember here, when a loss of fluid will be, less than 750 ml, almost same like if you are going to donate your blood. Right now, so same like if you are going to donate the blood, almost less than 750, like same like 450 ml. Okay, where blood loss will be like approximately 0 to 15%. It is class 1. Blood loss is more than 750 to 1500 ml, or you can say 15 to 13%. Class 2. More than 1500 to 200 ml. Right? It is class 3. If loss of blood will be more than 2 liter, no, more than 2 liter, it is called as class 4. Remember here, class 1 is like, actually this is like a normal state. This is like a normal state. Even after blood donation, no, you will be having class 1 shock. So this is, so basically class 1 is, actually it is not a shock only. Class 1 is actually not a shock. Okay, fine. Shock will start after class 2, right? Now from class 2. Remember here, now here systolic, but when there will be like, when there will be more than 750 ml loss of blood, no. So remember here, now in this situation, see in this situation also, yes, they see the pulse rate will be increasing. See the pulse rate will be increasing here, no, like more than 100, but systolic blood pressure is still normal. So I can say this is able to, yeah, this is able to compensate. So here, see class 2, mild shock is called as compensated, but systolic BP will start falling from class 3 or from moderate. So it is decompensated. It is a decompensated. Okay, fine. So when there will be blood loss in class 1, mild anxious, no problem at all. But if there will be class 2, no. Class 2, remember here, so that time patient can have anxiety. Patient can have anxiety. From class 3, patient can start appearing, you know, like same like there can be mental confusion. There can be mental confusion. Class 4, most of the parameter you will not be able to record. It will be non-recordable. When I talk about the non-recordable, okay, here the patient will be lethargic. Even urine output will be very less, or there can be anuria. There can be anuria. All these points you have to keep in mind. Remember here what kind of question they are framing. All the points which I have highlighted, only these are the important topics from where they are going to frame the question. Remember, a class 2 BP was normal, so it is called a compensated. Class 3 BP start falling down, so it is called a decompensated, and the class 4 obviously decompensated. Remember here, blood pressure and urine output will start falling from class 3 onwards. Fine. All these points are clear to everyone? No. How to manage the shock? In the beginning only I have taught you A, B, C, D, E circulation may always fix 2 cannula here, and 1 liter of normal saline or ringer selected, whatever you have, please start giving infusion. So first line of management for any shock patient is what? 1 liter bolus, fast infusion of crystalloid fluid. Okay, but the question is that how much blood pressure you have to maintain. So do you think more okay, directly you have to increase the blood pressure more than 100, more than 110? No. If patient is in shock, no. Remember here, maximum you have the permissible maintaining of blood pressure. See, the permissible hypotension, you have to maintain in between 70 to 90. Why? Like sudden increase of blood pressure can be harmful, because more than 90, no, it can cause a rebleeding. And less than, see here, less than 70 can cause hypoxia. So whenever you have to manage a shock patient, please be careful that you have to maintain blood pressure in between 70 to 90. Basically, slowly you have to improve, right? Okay, fine. And there is, yes, okay, there is something which is called the CRASH 2 trial. You remember, if still after that, if systolic blood pressure is less than 90 and pulse rate is more than 110, no, it means there is some kind of bleeding going on here. So for that, you can use injection of the injection of the tranexamic acid, right? Injection of the Trenexa. I'm sure you know about this, right? Okay, fine. Okay, but if patient is already in the like shock of the class 3 or class 4, at that time blood transfusion will be best. Blood transfusion will be best. We have learned different types of shock. Now suppose if there is an emergency, and if you have to do blood transfusion, so suppose if you don't have time for the blood grouping, blood matching and all, which blood group you are going to use? Remember here, O negative universal blood donor. Okay, so remember, in emergency, if you don't have time for blood grouping, blood matching and all, negative, O negative universal blood donor. For males especially, you can say O positive. For that, like reproductive females, O negative. For the post-reproductive females, O positive, because there can be the risk of RH incompatibility. Remember here, whenever we are going to do the blood transfusion, no, for the resuscitation, remember here, we cannot give only platelets, we cannot give only RBCs, we cannot give only whole blood cell, only fresh fluorescent plasma. No, we have to maintain the ratio of 1:1:1. 1:1:1, right? We have to give the ratio, like so that we can avoid coagulopathy, so that we can avoid DIC. So remember here, we have to give the equal amount of PRBC, equal amount of fresh frozen plasma, and equal amount of the platelets, But as per the new update, yes, we can give only these two together, like say a packed RBCs and plasma. So platelets we can keep like Hannah. So these two, with that you have to give the injection of the Trenexa, right? Now Trenexa for the normal clotting, Remember here, equal ratio is important. For the blood transfusion. Now, see, 2 guidelines for septic shock you should always be keeping in mind. One is systemic inflammatory response syndrome, And remember here, Q SOFA, quick sequential organ failure assessment score. Remember, even in pathology, I'm telling you, even in pathology, severe inflammatory response syndrome and Q SOFA, these are very, very important. These are very, very important topic for your patho exam. So what are the 4 criteria of SIRS? Remember here, like there can be, like you have to look for WBC count. You have to look for what? WBC count. Like there can be, see, there can be increase or decrease leukocyte. There can be hypo or hyperthermia. Heart rate will be more than 90 minutes. Heart rate will be more than 90 per minute, and respiratory rate will be more than 22. Respiratory rate will be more than 22 per minute. Or you can say PaCO2, it should be less than 32. Out of these 4, if more than 2 are equal to or more than 2 are present, it means your patient is in critical condition. This is called a systemic inflammatory response syndrome. What is the Q SOFA score? Here you have to see respiratory rate. Here respiratory rate you have to see. GCS score you have to see, and systolic blood pressure you have to see. Systolic blood pressure you have to see here. See, if respiratory rate, if there is a tachypnea more than 20 per minute, if GCS score, Glasgow Coma Scale, less than 14, dangerous condition. Systolic blood pressure is less than 100, it is dangerous condition. But remember one catchy point here, in systemic inflammatory response syndrome, no, remember here, respiratory rate should be more than 22. More than 22. But in Q SOFA, respiratory rate is more than 20. So be careful about this only. Here only examiner is going to, confuse you. Remember here, out of these 3, if minimum 2 or more than 2 are there, then high mortality rate will be there. So remember SIRS, SIRS, and you have to remember Q SOFA. You have to remember Q SOFA. All these points are clear to everyone? Yes. Now, remember here, whenever you are getting a patient of the septic shock, whenever you are getting a patient where you can easily understand if patient is going into sepsis, whenever there will be infection, high temperature will be there. Mostly there will be fever. So there is a new update. They have added, either it is called as sepsis bundle, or you can say sepsis 6. What is sepsis 6? This is, you know, like if you are getting a patient of the septic shock here, remember here, basically you are going to resuscitate the patient and you have to perform, and this should be completed within 6 hours. This should be completed within 6 hours. You have to see the level of the lactate. Very, very important. So very easy to memorize. You have to give 3 things to your patient, like IV fluid, high dose IV antibiotics, and you have to give oxygen, and you have to monitor urine output. You have to take away 3 things from the patient. You have to take blood culture. You have to take blood, see here, you have to take blood sample so that you can do CBC, full blood count. And you have to take the sample for lactate also. Remember here, lactate less than 2 mm, it is good, it is healthy. But when lactate is more than 4, more than 5, it is danger. It means your patient is in sepsis. Your patient is having hypoperfusion. So remember here, you can say either a sepsis bundle or you can say sepsis 6. Sepsis 6, you have to give 3 things to your patient. You have to take away 3 things from your patient. Okay, now few pharma question. If patient is having, like if patient is in septic shock, no, broad spectrum antibiotics, yes, obviously yes. But what is the vasopressor of choice here in a case of, remember here, if there will be like different shock now, different shock, like distributic shock, like septic shock, you can use noradrenaline. For the cardiogenic shock, noradrenaline or dopamine. For anaphylactic shock, adrenaline is best. Shock with oliguria, dopamine is best. If there is hypoadrenal shock, okay, see, steroid is best. All these are one-liner question related to your pharmacology part. Now, surgical hemorrhage, even after surgery, like if there is rebleeding, even after surgery, if there is a rebleeding, remember here, one is called the primary bleeding, another is called as secondary bleeding. What is the meaning of the word? What is the meaning of the primary bleeding and secondary bleeding? What is the meaning of this? See, the primary bleeding means what? When you are operating, during surgery, if there is bleeding here, due to bleeder, due to, you know, like suppose if there was incision of any blood vessel. So during surgery, if there is bleeding, it is called the primary. It is called the primary hemorrhage. Which during surgery, if you see, okay, during surgery only you can use monopolar cautery, bipolar cautery. That was basically you can do the cauterization. If there will be major bloods, like suppose if there will be major blood vessels which have got incised, then you have to do ligation, ligate. For a small bleeder, you can use the cautery, monopolar, bipautery. Can you answer me? I have shown you that in monopolar cautery, there will be there will be two buttons, yellow and blue. Yellow is to cut and blue is to clot. Blue is to coagulate. Easy? Yes? Very good. Now, what about the secondary? What about the secondary? I have operated the patient. I have operated the patient, and after 24 hours, after 1 day, after 2 days, after a few days, I would say after a few days of surgery, even see, because of the infection, because of the surgical site infection, and where actually suture, where actually ligature was there, no, like from there if there'll be bleeding, no, so then it will be called as secondary. During surgery it is primary. After the surgery, after a few days, after 24 hours, it is called as secondary. So minimum bleeding will be there. Minimum bleeding will be there where you have to admit the patient and you have to start high dose antibiotics. Now, but after surgery, you have shifted the patient to recovery room, or patient was shifted to ward. Now, within 4 to 24 hours, no, if there will be, within 4 to 24 hours, if there will be like leakage, if there will be bleeding, it will be called as a reactionary hemorrhage. It will be called as a reactionary hemorrhage, and this can be dangerous. There can be massive bleeding, and a root cause, most common cause is what? Slippage of ligature material. Slippage of ligature. This can be very, very dangerous. Or if there will be sudden increase in the blood pressure, so that can cause reactionary hemorrhage. Or if there was the clot, if there was a dislodgement of the clot, yes, there can be massive bleeding. After that, you have to re-explore and ligate. So how many types of surgical hemorrhage I have taught you? One is called the primary and secondary. During surgery, primary. After surgery, after 1 day, after 2 days, after a few days, secondary. Okay, within 4 to 24 hours just after this surgery, that is called as reactionary, which will be having massive bleeding. Massive bleeding. Fine. Now, read this question and you try to answer. Read this question and you try to answer, please. Read this question and try to answer. All of you. On post-operative day 7 of cholecystectomy, patient is presented with bleeding from the surgical side. Amount of bleeding is minimal. Now, I think you can easily understand here, no? From surgical side, if there is bleeding, so this is a case of what? Secondary hemorrhage, right? So mostly due to sepsis, mostly due to surgical site infection here. So remember here, like at that time, please admit the patient, because we have to give high dose antibiotics. We have to give high dose antibiotics. So whenever we have to give high dose antibiotics, no, please admit the patient. Don't ask the patient, okay, take the drug and go. Okay, and go back. No, admit the patient, high dose antibiotics. Now, blood transfusion here. This is blood transfusion set. You can see here, blood transfusion set. Right now, which most commonly we are using in India. Right now, this is the blood packet which you can see here. Blood packet which you can see here. Now, remember here. Now, there is a special cell. See, there is a special set. This special set is called as, remember here, very frequently we do not get this BT set in India. Very frequently we do not get, but this photo, this BT set, they have mentioned in most of the standard surgical books, like including Italian law. Right now, so this is called, here there is something special, something extra you can see here. Something extra. My question is that whenever you are going to perform blood transfusion, most of the time, see, most of the time patient will be complaining of rigors and chills, right? Or rigors and chills. This is due to what? This is due to what? WBC of donor. Suppose I have taken one blood sample. I have taken, like one packet of blood, like another patient, like from a donor. Same blood I'm going to transfuse in the patient. So now see here, the leukocyte of the donor that is going inside the recipient now. So that will be causing rigors and the chills here. So this is called as leukocyte reduction. This is called as leukocyte reduction BT set. Leukocyte reduction BT set. Leukocyte reduction BT set, where this is going to filter the WBC of donor, and this can also, remember here, this can also filter CGD virus. Okay, fine. Remember here, this is what leukocyte reduction set. Okay, yeah, fine. Now see this question now. Whenever we are going to take blood sample, okay, after blood collection from a donor, we have to do screening. No, we have to do screening before we have to perform blood transfusion. So which screening is not needed? I'm sure you know all these points because you have seen all these in hospitals. Can you answer me here? Hepatitis B, hepatitis C, remember here? Yes, we have to do a screening of, remember, we have to do a screening of all these, which I have mentioned here. Remember, we have to do a screening for hepatitis B virus, HIV, malaria also, and syphilis also. All these screenings we have to do. So remember, out of these four, easily you can rule out hepatitis A is not needed. We have to do this. No, we have to do this, right? We have to do this. See, now before, before blood transfusion, we have to do viral screening. We have to do screening for all these. Yes. Chalo. Now the question is, how much amount? First of all, can you answer me here? When a person is going to donate the blood, how much blood you are going to harvest? Okay, so how much blood can be taken out? 450 ml. You can take 450 ml of blood. You can take 450. Can you answer me? In a 1 year, maximum for how many times a person can donate his blood? In a 1 year, maximum for how many times a person can donate his blood? You can donate blood only for 3 times. You can donate the blood only for 3 times. Okay, only for 3 times. Healthy. Now, how much is this? See here, so from the same blood I can take out. See, one is called as whole blood. One is called as whole blood. From the same blood, no, I can take out only RBCs, which is called a PRBC. Means what? See here, PRBC mother. Yeah, this is called this is known as the packed red blood cells. From the same blood, I can take out only platelet. I can take out fresh frozen plasma. I can take out cryoprecipitate. I'm sure you would have seen the platelet and a fresh frozen plasma packet. I'm sure you would have seen this, no? Like if you see the bag of the platelet, or if you can see the fresh frozen plasma, actually this is blood product, but this will be yellowish color, no? Yellowish color. So there was a case in our hospital. There was a new JR. Female JR was there. She was 100% new, junior resident. And she started working in burns department, burns and plastic surgery, burns. Okay, she had 0 clinical experience. So like on day 1 of his duty only, no, his senior asked him, beta, we have a patient admitted here, like 80 to 90% burns is there, and you have to do blood transfusion. Okay, so nurse will get you the blood packets, and after that you have to do blood transfusion. Okay, I'm going to see other patient, please take care of this. After that she said, yes sir, fine sir. Okay, so when nurse brought actually, fresh frozen plasma, actually, that was actually what? Yellowish color. No, yellowish color. So after taking that, no, she started thinking, sir asked me that there will be, I had to do blood transfusion, but this is not a red color, this is yellow. First of all, this is not blood. But she was not able to ask the nurse, what is this, because of, ego issue upon doctor, like that. Okay, fine. She was not able to understand which product was that. So, but she asked one question from the nurse, like a diplomatic question. Sister ji, where to fix it? Like in which line I have to fix it? because the patient was bedridden. Patient had 80 to 90% so total body surface area of burns, right? Okay, fine. So sister said, "Arey, so many lines are there. You go, you can fix it anywhere." So blood transfusion, fresh frozen plasma, you have to infuse only in a vein only, no? Vein only, no? Blood vessel only, no? Right? Blood vessel only. When she went to see the patient, she could see central line was also there. See, the peripheral line was also there. Riles tube was also there. Foley's catheter was also there. So again, she was confused what to do. First of all, see, after that, no, she got confused. First of all, this is not the blood product. Arey, ye to liquid fecal matter, nana. I think this is urine. But sir has asked me where to fix it. Might be a special urine. She fixed in Foley's catheter. Fresh frozen plasma. See, the amount will be 200 to 250 ml, no? Eh? And the bladder capacity is approximately 450, 450. After 150 ml of urine, you feel the sensation of passing the urine, no? So she fixed in Foley's catheter. After 1 unit of, the complete infusion, no? Patient started complaining of severe abdominal pain. So patient complained of severe abdominal pain. So nurse was confused. Arey, abhi just now I've given Buscopan. Why she is complaining of, why he's complaining of like abdominal pain, right? Abdominal pain. So she is starting searching from here to there, After that, she looked at Foley's. First of all, she stopped, and with the syringe, she extracted it out. She took out all fresh frozen plasma from the bladder, but she made a phone call to senior. Sir, come. See, when you will be intern, no, your biggest enemies will be senior nurses, no, because they can have ego clashes, no. So most of the time they will be complaining, even a small mistakes of yours, she will be complaining to the senior doctor, and you will be scolded like that. Okay, fine. After that, senior came. Senior understood that point. After that, he called her. Beta, come. First of all, you tell me, one more packet was there. Which product is this? Vomiting, fecal matter, or urine? Answer. She said, sir, urine. Oh, very good. Sat topo ki islami lo tum. So this kind of mistake can also be there. Okay, old scenario, right? I will not take the name of hospital. I will not take the name of anyone, but this was the case. All right. This was the case. Okay, fine. All these points are clear to everyone. Remember here. So how much amount of whole blood? 450 ml. PRBC 250 ml to 300. See, platelet will be 50 to 70 ml, and fresh frozen plasma up to 200. See, what about the cryoprecipitate? Remember here, 10 to 15 ml only. At how much temperature we are going to preserve them? Whole blood and RBCs 1 to 6 degree. You can say what? Or 1 to 6 degree. But what about fresh frozen plasma? -40 to -50 degree. What about the cryoprecipitate? -30 degree. Okay, see, what are the needs of all these? Remember here, after massive bleeding, after massive fluid loss from the body, remember here, अच्छा 7 तोपे नहीं, लाइक अच्छा पूरे 21 तोपों की ले लो यार, ठीक है after massive bleeding, whole blood can be given, but when hemoglobin is less than 7, severe anemia is there, we can give packed RBCs. Question they have asked, after how much level of the hemoglobin, blood transfusion is must. Remember here, when hemoglobin level will be less than 6, no, remember less than 7 you can say, and so less than 6, like blood transfusion is must. The question what they have asked, after the transfusion of 1 packet of blood, 1 packet of RBC, how much hemoglobin will increase? Remember here, after 1 unit of blood transfusion, hemoglobin level will be increasing by 1 only, by 1. Okay, but how much hematocrit? Hematocrit means what? RBC concentration. This will be increasing by 3%. Okay, fine. Remember here, these are old, repeatedly asked question. After 1 unit of blood transfusion, how much hemoglobin will increase? 1 unit. But how much hematocrit will increase? Up to 3%. Remember here how they have framed the question earlier, like in some old exams. After road traffic accident where there was massive blood loss to a patient, When patient got admitted in hospital, at that time, his hemoglobin level was only 7. Only 7. After that, up to 2 units of blood got fully, after that, so 2 units of blood transfusions was done. Okay, up to 2 units. What will be the new hemoglobin? What will be the new hemoglobin? Can you answer me? New hemoglobin level will be 9. Simple. In this manner only questions are being framed. Platelets, how much is the normal platelet count? Can you answer me? How much is the normal platelet count? Normal platelet count is 1.5 to 4.5 lakhs per millimeter cube. Okay, 1.5 to 4.5. Okay, fine. Even in a case of that dengue, right now dengue, there can be platelet destruction here, right now. So there we can the infusion of the platelet. Remember here, see, platelet is the only blood product which we can keep at room temperature, only. Remember here, so like whenever we are going to give the transfusion of 1 packet of the platelet, this will be increasing platelet by 5,000 to 10,000. Okay, 10,000. Now, where will be the need of fresh frozen plasma? Where will be the need of the cryoprecipitate? Remember here, these are having, actually these are very, very rich in the coagulation factor. So fresh frozen plasma, which, see, this is rich in factor 2719. So especially in a case of the coagulopathy, right? Okay, fine. And what about the cryoprecipitate? Especially in a case of hemophilia, we can use like rich in fibrinogen and factor 8 and 30. Remember, this table is important. All these points are clear to everyone? Okay, fine. So it is a dengue or dengue. Please remember here, actual pronunciation is a dengue. Okay, by Aedes aegypti. है ना? Normally हम लोग बोलते हिंदी में डेंगू. Okay, चलो fine. Whatever, you should be able to solve the question and you have to take care of the patient also. Okay, dengue case. चलो. All right, now you can easily understand, you know, from whole blood only we can take out plasma, we can take out platelets and RBCs. After looking at this photo, you can easily understand here how we are going to extract, right? Remember here, what is the name of the anticoagulant agent which we are using in the blood bag? Remember here, we are using citrate, phosphate, dextrose. See, remember here, so shelf life will be 21 days. Okay, but we can add, you know, acetate also. Now shelf life will be 28 to 35 days. Remember here, after blood transfusion, remember here, how much is the normal half-life here? 120 days normal. Actually, the normal life of the RBC 120 days. After blood transfusion, 50 to 60 days. Okay, after blood transfusion, remember here, we have to, right, very easy to understand, and we have to, remember here, we have to store at 1 to 6 degree. All these points are clear to everyone? Remember here. Now, remember here, what are the transfusion protocol? Remember, from the refrigerator, if you have taken out the blood bag, you have to use within 30 minutes. Within 30 minutes. So like suppose if it is very, very cold, so very cold blood you cannot transfuse. So you can wrap with, you know, with a towel. Okay, now so that you can maintain some temperature. But within half an hour, you have to do the transfusion. Whole blood and PRBC, you have to complete within 4 hours. Okay, and remember here, when I talk about platelet and fresh frozen plasma, no, you have to complete within 20 minutes. Now, there can be blood transfusion. There can be the complications also. Now, remember here, there can be complications also. Remember here, what kind of complication? Overall, most common complication will be rigor and chills, which is actually what non-hemolytic transfusion reaction. Most common. But remember here, see, sometimes there can be what mismatch blood transfusion also. ABO incompatibility, you know, wrong transfusion. So most commonly, actually, see what the most common cause here? What most common will be clerical error only. Right now, ideally, whenever you are going to transfuse the blood, again you have to recheck. Blood grouping, patient name, patient bed number, patient age, each and everything. From donor side also you have to see everything. You have to cross check, right? Now, most common cause of death. Can you answer me? Most common cause of death. most common cause of death after blood transfusion is, most common cause of death after blood transfusion, very famous, this is called the TRALI, which is called the transfusion related acute lung injury, where there can be a respiratory distress, and it is maximum seen with packed RBC and fresh frozen plasma, So whenever you are getting this kind of situation, how to manage? Yes, you have to give low volume ventilation. Remember, your most common cause of death after blood transfusion is actually the TRALI. But if examiner is mentioning most common cause of death after massive blood transfusion, massive, if they are mentioning, no, massive, then you have to write, okay, then you have to mark coagulopathy, right? See here, then you have to mark the coagulopathy. This much point is clear to everyone. Now, some other we are going to learn here now. Wrong, if there will be mismatched blood transfusion. Mismatched blood transfusion. Mismatch over the most common symptom, pain and heat along the vein. First sign, when patient is fully conscious, it will be itching. But if patient is fully anesthetized, first sign will be low BP, and there'll be, and after that there can be bleeding from the operative site. Late sign will be, like there will be a low urine output, oliguria and all. So remember how to manage. Yes, we have to give the injection of steroid, and after that we have to give the injection of what? Antihistaminic and all. And after that, if situation will be like that, no, yes, we have to give diuretics also. After that, you have to repeat the matching, blood grouping and blood matching. Now, remember here, see here, now what is the meaning of the word massive blood transfusion? Can you answer me? What is the meaning of the word massive blood transfusion now? Massive blood transfusion. Massive blood transfusion, when patient had severe or massive blood loss, when patient had massive blood loss, like after that trauma, after maximum bleeding. Okay, then if you are giving 6 units of PRBC, 6 units of fresh frozen plasma, and 6 units of the platelets, right now platelets, okay, yes. Yes, so it is called as massive, actually massive, and a massive. Remember here, why we are not giving only PRBC? Because it can lead to coagulopathy, it can lead to DIC. So that's why we have to give what? Balanced resuscitation. When it will be called as massive, when it will be dangerous, when more than that, see, when after how many units within a day? More than the 10 units or 4 units within 1 hour, within 1 hour. So remember here, so do you think there can be, so because of the massive blood transfusion, there can be lysis, right? No, there can be lysis and all. Yes, there can be lysis of RBCs also. Remember here, what are the symptoms you are going to see here? Yes, metabolic alkalosis will be more. Okay, so when there will be lysis of RBC, it will be releasing more and more potassium. It will be causing hyperkalemia more. Hypo will be less. There will be hypocalcemia, hypomagnesemia. And remember here, like due to overload, no, it can lead to congestive heart failure, and that can be very, very dangerous for the patient. Remember here, massive blood transfusion can be lethal for the patient. If you have understood this much, now see this question first of all, then you try to answer. After this, I will give a break. Don't worry. I will give a small break now. Okay, don't worry. But you read this question first of all, and then you answer me. After massive blood transfusion, patient is having respiratory distress, increased JVP, increased blood pressure, central and pedal edema. Central and pedal edema. Now, you might be thinking either this can be TRALI or this can be the TACO. Okay, this can be a TACO. Either this can be the TRALI or this can be, this is actually what? TACO. Very, very important. Please remember here, TACA. TACO, please remember here. This is called the TACO. Right? This is called the TACO. This is called the transfusion associated circulatory overload. When there will be circulatory overload, I can say here that there will be the cardiogenic problem. No, it can lead to increased blood pressure, increased JVP, central edema. So this is a case of the TACO. This is a case of the TACO because of the cardiac overload. Remember here, when I talk about the TRALI, no, that is actually what? Like inflammatory reaction actually. So Remember here, that is actually what inflammatory reaction here. So when I talk about the tacho, remember here, this is actually what here this will be the cardiogenic. But remember here, acute lung injury, non-cardiogenic, this is called the TRALI. Remember here, when I talk about BP, JVP, all these are elevated in tacho, but it will not be elevated in the TRALI. All these points are clear to everyone. Remember here, this is more than enough. Second important point, you should be looking at BNP also. BNP will be elevated only in the tacho, not in the TRALI. So how to differentiate these two? This is an important topic for your exam. This is an important topic for your exam. Remember here, all these points are clear to everyone. Now, after the see the next topic which I will be teaching you, that will be trauma. Yeah, but before I start the new topic, let's have a small break. Like we can have a small break only for 10 minutes. We can have a small break only for 10 minutes. Okay, fine. We can have a small break for 10 minutes. All right. Okay, everyone. Yeah, chalo. So we are going to start with a new topic. This is the trauma now. Okay, like very important topic we are going to learn. This is the trauma. Okay, very important topic. So first of all, read this question and try to read this question and try to answer. This looks very big question, but I'm telling you, most anticipated question, and this is the favorite topic for FMGE exam also, INI-CT also, NEET PG also. Read this question, all of you. A 25-year-old young male met with high-speed RTA and came to trauma center. On examination, BP was low, pulse rate was very high, saturation, GCS score only 8, right? BP, right? GCS score only 8. On further examination, the patient had multiple injuries and fast reveals hemorrhage in all quadrants. Minimal surgery was done to stop bleeding, and closure of abdomen using mesh plasty only was done to prevent abdominal compartment syndrome. And then he was shifted to ICU with the planning of re-exploration and definitive repair of injuries. Can you answer me now? Bolo, can you answer me this question? So here, after reading this question, you can easily understand here. So I will give you one example. So what happened in our hospital, no? Like one day there was actually a patient who got admitted in the midnight. Like he got admitted in emergency. So like actually there was a person who was in Audi car, and there was a huge collision between Audi and the truck. Audi and the truck. Okay, fine. No. So there was severe injury. Severe injuries happened to the person who was sitting in Audi car. He was brought to emergency department. At that time, when he got shifted to emergency, no, so like at the same time, he was shifted to ICU. Right? No, so he was having multiple facial bone fracture, severe, like severe laceration over the abdominal part, over the thoracic part. Okay, multiple bone fractures. Right? No, so like his BP was going down. So basically, he was in severe position. He was in the critically ill position. After a few hours only, there was severe edema. Severe edema was this much that he was not able to open his eyes also. Severe swelling across his body within a few hours only. That was severe swelling around the body. So in the beginning, situation was like that, no, that he will not survive. Situation was like that, he will not be surviving. But what happened? What doctors did know? First of all, he was taken to the, like even in the ICU only, like remember, yes, so what happened? No, like first of all, like the doctors over there, they did minimal surgery. They did minimal surgery to control the damage. Wherever there was the bleeding, they closed actually that. So like actually they stopped bleeding. They stopped bleeding. Minimal surgery they performed. So basically main surgeries they did not do, because see that time no patient was not in the situation to handle any kind of major surgeries. So like doctors did only minimal surgery just to stop bleeding and all. Okay, fine. So after that he was shifted to ICU for resuscitation. After after one day, what happened? No, after one day, inside his body, no, like, see, his body started responding. So he started having, somewhat stable vitals, and also within 1 or 2 days only, no, he started responding well. His body is started responding well. So first of all, doctors did minimal surgeries just to control the damage. After that, patient got shifted to ICU for resuscitation. When he started responding well, after that, on day 2 or day 3, he was shifted to main operation theater for main surgery. So first of all, minimal surgery, then ICU, then major surgery. This kind of surgeries will be called as damage control surgery. Very important surgery. Please highlight this. This is called as damage control surgery. Repeatedly asked question. You may anticipate this kind of question in upcoming exam also, right? So damage control surgery means what? First of all, phase 1, phase 2, phase 3. First of all, minimal, minimal, you have to control the damage. Like initial exploration. After that, shift the patient to what? So first of all, what? Initial exploration, then secondary resuscitation in ICU, then definitive operation. This much point is clear. Phase 1, 2, 3. First of all, minimal surgery, then ICU, then major surgeries. This is called as a damage control surgery. Damage control surgeries, please remember it. Please highlight this. This is most anticipated topic in upcoming exam, damage control surgery. Okay, damage control surgery. Yes, Dr. Panic, you are saying sometimes fat embolism might also occur. So can you answer me when there will be the risk of fat embolism? Okay, all of you, can you answer me when there will be risk of fat embolism? When there will be fracture of long bones, when there will be fracture of long bones, like in an adult, fracture of long bones like femur fracture, humerus fracture, long bones fracture, basically long bones fracture. So if there will be fracture of long bones like a femur, shaft of the long bone fracture, so I'm sure you are able to recall. Can you answer me here? See, can you answer me here? What is the hematopoietic organ in adults? Okay, see, with this topic only, since one of you have asked me this question, can you answer me? With this topic only, can you answer me what is the hematopoietic organ like in an adult? Okay, yes, bone marrow to hai. Bone marrow of long bone or short bone? Bone marrow of long bone or short bone? Can you answer me? Remember here. Some of you might be writing कि bone marrow of long bones, because adult है वो long है इसलिए long bones. Please understand this very easy concept. Hematopoietic organ in intrauterine life, less than 5 months में yolk sac. Yolk sac is the hematopoietic organ. After 5 months to delivery, okay, now then there will be liver and spleen. After delivery to puberty, remember here, bone marrow of long bones in a child, bone marrow of long bones in a child, less than puberty, before puberty, up to puberty, bone marrow of long bones. Because like in a child, like in the bone marrow of a child, there will be red cells, mostly red cells will be there. After puberty, remember here, in an adult, remember here, in an adult, in the long bones, no, red cells will be replaced by fat cells. Okay, so in an adult, bone marrow of short and flat bones. Bone marrow of short and flat bones. Very easy to understand. So remember here, in an adult, in the long bones, mostly there will be yellow cells, there will be fat cells will be there, yellow cells will be there. So remember, whenever there will be fracture of long bones in an adult, yes, okay, there will be higher risk of fat embolism. There will be higher risk of fat embolism, but fat embolism, this can occur after 48 hours. After 48 hours of accident. This one point is clear to everyone. So remember here, fat embolism we see in adults only, because of long bone fracture. So always keep in mind, whenever there will be fracture of long bones in emergence, like in adults, so long bone fracture in adults will always be the surgery of emergency. You will have to operate as soon as possible. Within 2 days, you have to operate. But in a child, 8-year-old boy, femur fracture, no problem. Even after 5 days also, and even after 5 days also, you can operate. Like even after 6-7 days also, you can operate. But in a case of adults, within 2 days, you have to operate. Within 48 hours, you have to operate as soon as possible. All these points are clear to everyone. So this depends upon, right? So this depends upon, remember here, so this depends upon severity of fat embolism. You can save the patient also. Okay, fine, no? All these points are clear to everyone. That's why if I ask you, can you answer me, what is the best bone for bone marrow aspiration in adults? What is the best bone for bone marrow aspiration in adults? Bolo. What is the best bone for bone marrow aspiration in a case of blood cancer patient? Best bone, bolo. Best bone will be actually what? Hip bone. Ischium bone will be, no? Ischium is best for bone marrow aspiration, followed by sternum. But when I talk about what is the best bone for bone marrow aspiration in a child, tibial bone, long bone. This much point is clear to everyone. I hope this is clear to everyone. So we have learned about damage control surgery. First of all, basic management, shift the patient to ICU. Then you have to do what? Definitive surgery. All these points are clear to everyone. Right. Now, what is the criteria for damage control surgery, which is also called as abbreviated laparotomy. Abbreviated laparotomy means what? Remember here, basically, remember if there'll be severe injury, patient is in critical condition here now. Yes, I can do minimal invasive, I can do minimum surgery, but I cannot close the abdomen. After 1 or 2 days, when patient will be responding well, then we can do complete closure at last. Remember here, what are the criteria? If there will be lethal triad of trauma. The lethal triad of trauma, if patient is having hypothermia, if patient is having coagulopathy, if there is acidosis, this is lethal. This is very dangerous. If systolic BP is less than 70, lactate is more than 5 millimole, and if you are in the need of doing the transfusion of more than 15, like injury severity score more than 36, okay, remember here. Fine. So you have to do damage control surgery. You cannot complete the surgery as soon as possible. Wait. First of all, minimal surgery, shift the patient to ICU for resuscitation. After that, main surgery. But what are the indications of early surgery where you can? If patient looks stable or lactate is less than 2, okay, you can operate. Now, remember here, what are the stages of damage control surgery? I think this was the question in last time FMG or last time INICT. Stage number 1, first of all, patient selection. After that, stage 2, minimal surgery, like you have to control hemorrhage, you have to control contamination. Right now, you can do only packing, wound. See, wound will not be finally closed here. Ostomy you can make. Okay, fine. After that, stage number 3, ICU resuscitation, minimum for 1 to 2 days. After 2 days, definitive surgery, and finally, abdominal closure. Remember here, 5 stages of damage control surgery. 5 stages, and there will be 3 phases: initial exploration, ICU resuscitation, definitive treatment. Okay, fine. But here 5 stages. Please, please, please highlight this topic. Make a circle on this topic. This is repeatedly asked question. Damage control surgery. Next question is also very, very important. Read the question carefully and try to answer, all of you. After a 40-story building collapsed, 150 people were injured, 75 people had multiple bruises, but they can walk. After that, I can say that 25 seem to have rib fracture and facing difficulty in breathing. And next 25 had severe head injuries and they appeared to be unconscious and immobile. And 25 people had fracture over forearms and legs with the crush injury. Which of the following cases you will give least priority? Read the question carefully and yes, please answer. Least priority. I'm sure you would have learned about disaster management. Disaster management you would have learned, where you would have learned how to categorize the patient on the basis of severity, because whenever there will be a disaster, maybe after earthquake, after building collapse, when so many people got injured, no, like at that time, less number of doctors will be there, less number of paramedical staffs will be there, but more number of patients. No, at that time you have to sort out the patient. At that time you have to sort out the patient on the basis of severity. Sorting out is given by, yes, sorting out is given by, yes, this is given by a protocol which is called as, which is known as the triage. Okay, fine. Easy to understand. To sort out the patient on the basis of severity. On the basis of severity. Most of you are marking answer B here. Okay, remember here, out of these 4, first priority should be given. Suppose if I have to intervene within half an hour, because if I will be late, patient can die, because if there'll be tension, pneumothorax, if there'll be respiratory difficulty, you know, like if there'll be difficulty in breathing and all, within half an hour, okay, fine, this will be having highest priority. So this will be coming in a red zone. I'm sure you are able to recall about red, yellow, green and black. rig B. Red zone, you have to categorize the patient on the basis of severity. So option number B, red zone. After that, the patients whom we have to intervene within 1 to 2 hours, because if we will be late, then there can be the need of amputation. There can be the need of amputation. So option number C, I can say I can categorize in yellow. And like even after 1 day, if I'm going to see the patient, no problem. Or if I can shift the patient to other hospital, okay, उसको हम लोग कहेंगे green color. But patient, remember here, when the patient is appearing to be dead or morbid patient, at that time you don't have to be emotional there, because even if you are going to spend your time there, mostly you will not be able to save the patient here. So least priority should be given to black zone. Black zone means almost dead or moribund patient. Okay, remember here, this protocol, this is called as the triage protocol, right? See, this means sort out, right, on the basis of severity. Remember here, these 4 zones are important: red, yellow, green, and black. Red, yellow, green, and black. So before black they add blue color also, but almost same thing. Remember here, these 4 for mass casualties. Remember here, mass casualties, you have to categorize the patient on the basis of severity, likelihood of survival, and urgency of care. Please remember, this is also an important topic for your exam. This is related to disaster management. Now, what are the primary survey? See, remember here, one is called the primary survey, another is called as secondary survey. Secondary survey here, see, the primary survey of after any trauma, A, B, C, D, E, airway, breathing, circulation, disability, exposure, exposure, right? And like in the beginning, you have to control bleeding. All these are the primary survey. When I talk about a log rolling, remember here, log rolling means what? When a patient is in supine position, when a patient is in the emergency condition, if I have to shift the patient from one hospital to another hospital, or if I have to do a spinal examination, we need at least 4 people. Like in this manner, see, the 3 people are going to hold the patient like this, and 1 person. Basically, you have to turn the patient like this with, at the same time, you have to take extra precaution. Basically, you are rolling like a log. This method is called as log rolling. Log rolling is also the part of the primary survey. So when I have to do a spinal examination, when I have to transfer the patient, but if patient had pelvic fracture, please don't do this. You can damage more. But remember here, now as per the recent update, like if there will be, suppose if you have to perform log rolling, now this is replaced by whole body CT scan. Whole body CT scan now. Whole body CT scan should be performed, like instead of doing log rolling, because here now you are going to take the time of 4 people, actually 4 people here. But log rolling, still you should know, this can be your image based question also, like for a spinal examination. And even if I have to transfer the patient from one hospital to another or one place to another place, log rolling. But remember, if there was a suspected case of the pelvic fracture, please don't do this. Remember, see, the primary survey means what? Like I have to do the X-ray of neck and the pelvic part, but AP view X-ray, AP view, anterior posterior view. My question to you is that next question related to radiology. Can you answer me? What is the most common view of X-ray for the chest? Can you answer me, all of you? Please write down here. What is the most common view of taking X-ray of chest? Most common view? Remember here, always keep in mind, for chest, most common view for X-ray. Most common view for X-ray of chest. Most common view is PA view. And a posterior anterior view. I'm sure you also, like you all would have gone through, X-ray of chest, even for the medical examination. So the X-ray technician will be asking you to stand like this, no, like over. So there will be something. There will be a board like that. And after that, radiation will be coming from the back side. So the posterior anterior view. This is the most common. For that, you have to stand. But my question is that, in which condition you can do AP view? In which condition you can do AP view, like anterior-posterior view? Remember here, in any condition where patient is not able to stand, like suppose a patient is in coma, a patient is in ICU, if there is a flyal chest also, flyal chest, yes, after the trauma, AP view only, AP view, where patient cannot stand, This much point is clear to everyone. Very easy to understand. Now, can you answer me here? What is the view for if there will be a fracture of radial bone or ulnar bone? Which view you are going to use? Can you answer me? All of you, please write down. Yes, remember here, I'm sure you would have visited, X-ray room. So if there will be a fracture of this bone here, radial bone here, no, like one view will be like, like X-ray technician will be asking the patient to keep his forearm like over the table like this. One view will be AP view. But if there will be a fracture over the lower part, no, you might not be able to appreciate here, no. So for any long, remember here, for any long structure or a long bone, we have to take two views. One view should be AP, another should be lateral. So one AP, second will be lateral. AP and then lateral. Okay, two views should be there for long. Femur bone fracture, tibial bone fracture. But if there will be fracture of bone around the joints, can you answer me? If there will be fracture of bone around the joints, like wrist joint, elbow joint, at the wrist joint, 8 bones are there, no, carpal 8. So can you answer me here? Like if there will be wrist bone fracture, which view? Answer. See, if we are going to do AP lateral, no, 8 bones are there, no, superimposition of bones can be there, no, superimposition where you might not appreciate all fractures. So around the joints, no, you have to do one AP view, second will be oblique view, AP and oblique both. Suppose if there is a mother who is coming with her baby and she's complaining that my baby has swallowed a coin. So for the neck, which view you are going to use? See, the neck is also actually long structure only, no? So for here also AP and lateral. This much point is clear to everyone, right? Remember it. I hope all these points are clear to everyone. So can you write down in chat box if I ask you if there will be fracture of, like suppose if there will be a fracture of tibial bone, can you answer me which view of X-ray you will take? All of you, please write down in chat box. Tibial bone fracture, bolo. AP lateral. If there will be fracture over ankle joint, can you answer me which view? Ankle joint, bolo. AP oblique, no? AP oblique, right? So remember here, when patient is in supine position only, and you will be having ambulatory X-ray machine, right? So there only AP view of X-ray of neck, chest and pelvic. These are belonging to the primary survey of the trauma. But if you have to do PA view X-ray, no, then it will be secondary survey. So when I talk about NCCT, like NCCT head, whole body CT scan, EFAST, secondary survey, CT abdomen and X-ray PA view, secondary survey. Please remember here, all these are important related to your exam. Now we are going to learn about the thoracic injury, like injury over the thoracic cavity. Remember here, ICD tube, like intercostal drainage, we have to insert into a 5th intercostal space, mid-axillary line, right? No, but this can be inserted anywhere in between. See here, so basically this can be inserted anywhere like in safety triangle. This is a safety triangle. Axillary for like in between latissimus dorsi. Remember here, so this is actually what? This is a safety triangle. This can be inserted anywhere here, anywhere, safety triangle, but the most common is what? Fifth intercostal space, mid axillary line. Okay, fine. So where like safety triangle kya hai? Like anteriorly, you can see the pectoralis major, posterior latissimus dorsi, inferior nipple level. Nipple level. Now the question is that when you have to insert the needle, can you answer me? You are going to insert the needle over the just above the rib or below the rib? Answer me. At the upper border of rib or a lower border of rib? Can you answer me? So Dr. Mandir Kumar Gupta, heartiest congratulations. Safdar Jung is one of the best and one of the biggest. So I'm sure you must be getting so much of experiences over there. I wish you all the best for your future endeavors. Thank you for inspiring so many young and the budding doctors. Okay, now all of you, can you answer me here? All of you? Yes. So my question is that if you have to insert the needle, you have to insert just at the upper border of rib or the lower border of rib. Please understand here that neurovascular bundle, when I talk about, suppose if these are the two ribs, no, suppose if these are the two ribs, suppose if these are the two ribs like this, if these are the two ribs, when I talk about neurovascular bundle, blood vessels and nerves, these are lying at the lower border. These are lying at the lower border of the rib, no? So you have to insert the needle for thoracocentesis at upper border of rib, This is important question. This is important, okay? Important question at upper border. Now the question is that, yes, like intercostal drainage tube, this tube will be, remember, this tube will be connected with a like underwater drain here, underwater drain. Remember here, how will you understand that you are in the exact location and actually it is working? Remember here, so there will be water seal here, remember here, air water column, what you see here now, like there will be what, like in a bottle there will be, you know, like water will be there. So if you can see, if the air water column shall go up and down, it means you are in the right position. Here. But for the confirmation, X-ray of chest will be enough. Remember, I have shown you in the beginning itself, when you, after the insertion of intercostal drainage tube, if lungs will appear to be 100% normal, if you can see all the demarcation separately, if you can see the lungs part, and if you can see all, you know, like all the bronchi separate, each and everything, all demarcation you can appreciate normal hai. But like if you can see, like if the X-ray is like this, dark lung is there, and even after intercostal, you know, like even after intercostal drainage, no, what happened, no, patient started having increased JVP, low BP, and absent breath on right side. What does it mean? Now when you have taken the X-ray, easily you can understand here, that right side there is actually what? Tension, pneumothorax. You can see here dark color lung here. Even if you look at here, no, there is actually what? Tracheal shift. So tracheal shift is there, no, it means what? There is what? Tension, pneumothorax here. What is the next line of management? Wide bore needle. You are going to a fifth intercostal space in mid-axillary line for adults, but like in a case of the child, second intercostal space in mid-clavicular line. So for babies, for the pediatric age group, second intercostal. For adults, fifth mid-axillary. But overall, what will be the treatment of choice? Final will be what? Intercostal drainage tube you have to fix in a fifth intercostal space, mid-axillary line. Intercostal drainage. Remember here, even after that, if you are not sure about hemothorax or pneumothorax, and suppose if the facilities are not available, where you are not 100% sure, then in this kind of emergency, what can you do here? Basically, if there will be situation, suppose if the situation is getting worse here, situation will be worse actually, and now if you have to save the patient in emergency, so how to do here? You have to give incision over here, and you can insert finger inside. This is called a finger thoracostomy. This is called a finger thoracostomy. Basically, decompression is must. See, although this looks bad, actually this looks very rough, but you can save some people. This is called as finger thoracostomy. Finger thoracostomy. Remember it. Very, very important. Okay, very, very important. Chalo. Next. See, after looking at this X-ray, you can easily understand here that on the right side you can see normal lung. On the right side you can see normal lung, but the left side you can see there is a complete white here, complete white. Easy to understand. So remember here, this can be a case of what? Remember here, low BP, absent sound over the left side, and you can see white color here. This is a case of what? You can easily understand that there is severe accumulation of blood, hemothorax. Remember a low BP, absent breath sound here. Most common, like injured blood vessel will be intercostal artery. If there is a massive bleeding more than 500 ml, then you should understand here most common blood vessel to get damaged will be here, like internal mammary artery here, right? No, internal mammary, right? No, so all these pulmonary artery, aorta and all. Remember here, okay? So remember here, whenever there will be massive bleeding, you can suspect that major blood vessels got ruptured. Next line of management is what? Same, intercostal drainage in 5th intercostal space. The question is that what are the indications of doing open thoracotomy as soon as possible? What are the indications that you have to shift the patient to operation theater and you have to do thoracotomy right now? Remember here, if there will be blood loss, if blood is coming out 1 liter in the penetrating trauma, 1.5 liter in the blunt trauma, and more than 200 ml in last 3 hours, shift the patient to OT and you have to perform urgent thoracotomy. Next, now, like see, we have learned all these, right? We have learned all these. Now this is not, see here, this is a case of flyal chest. Now, next topic, what I'm showing you here, this is a case of flyal chest. After looking at this X-ray, you can easily understand multiple rib fractures are there, multiple rib fracture. Remember here, whenever there will be fracture of minimum 2 ribs at equal to more than 2 points, this will be called as a flyal chest. Although Belly and Love has mentioned more than a fracture of more than 3 ribs, but most of the books are still writing actually more than 2 ribs, minimum or more than 2 ribs. Remember here, flyal chest, this is an emergency condition. Obviously there will be paradoxical respiration, there will be opposite respiration. So what is the meaning of the word paradoxical respiration? When patient will be breathing in, there will be indrawing of chest. When he will be breathing out, there will be expansion of chest. Opposite. Okay. So now remember here. So what is the investigation of choice? Remember, since flyal chest hai, multiple segments, multiple rib fractures are there, investigation of choice will be 3D CT scan, right, to rule out underlying injuries over lungs. Management, first of all, intercostal drainage. You have to give oxygen, nasal oxygen. And remember here, see the painkiller. See here, painkiller you can inject through intercostal drainage also. And suppose if the saturation of oxygen is less than 60%, then you have to shift the patient to ventilator. Now remember IPPV, okay? Now, so this will be needed for the patient. Earlier, we were not operating for this case, but now even for the flyal chest. And see here, basically, if saturation is less than 60%, we have to shift the patient to ventilator. So remember here, now we can perform ORIF. Like, see here, open reduction, internal fixation. Earlier this was not in the protocol to operate. Now we can open and we can operate rib fractures. Open reduction, internal fixation for flyal chest is an important topic. But remember here, if suppose if there was a penetrating trauma, knife trauma, stab injury here in the chest here, after that patient is having, when you see the condition of the patient, patient is having high JVP, low BP, hypotension, and you are not able to hear heart sound. There will be muffled heart sound. This is called as Beck's triad. Beck's triad, this is the classical triad of pericardial tamponade. Remember here, repeatedly asked question. This is a case of the tamponade here, pericardial tamponade here. Remember here, you can easily understand if there will be accumulation of blood in the pericardium or in the pericardium, the cavity part. Okay, fine. Yes, heart auscultation will be difficult. Earlier, we used to insert a needle. We used to do the pericardiocentesis earlier. But remember, no more needle pericardiocentesis. Okay, see here. Earlier, we used to do what? Needle. We used to do pericardiocentesis. Right now. I know, but now, see, new update is there. Why to waste your time there? Please shift the patient to operation theater as soon as possible. Now, remember here, what is the treatment? What is the main line of treatment for the pericardial tamponade is what? Shift the patient to OT and do what? You have to operate. You have to do thoracotomy as soon as possible. Now, if there will be head injury, the second most important topic which we are going to learn, this is called as Glasgow Coma Scale. Glasgow Coma Scale. Now, see, in Glasgow Coma Scale, please remember here, Glasgow Coma Scale we are using especially to see the consciousness level of the patient. I have to see the consciousness level of the patient. First of all, I have to see eye movement, then verbal response, then motor response. Okay. So remember here how we are going to score it. This is very, very important topic we are learning now. Remember, after accident, if patient is brought to emergency department, patient is on a stretcher, patient can open his eyes spontaneously. Aram se, he is open here, like he is able to open his eyes spontaneously. I will give him maximum score of 4. But his eyes were closed. I asked him, hey, open your eyes. After my instruction, after my speech, he is opening, I will give him only 3 marks. But even when I asked him, hey, open your eyes, he's not opening. So I can use my pen and over the nail bed, I can apply a pressure over here. So I'm giving him pain, right? I'm giving him pain. See, after who is here, man? Like that. After pain, if he is opening the eyes, 2 score only. But remember here, even after pain, no response, then I will give him 1 mark. So for eye response, can you answer me? Maximum score I have given 4. Minimum score I have given 1. Now, response here. I want to check how much he is oriented now. If he looks 100% oriented, he knows where he is standing, with whom he is talking right now. 100% oriented hai, I will give him 5 marks. I will ask him some question. Hey, who are you? Who am I? Who is she? Who is he? Where are you now? Like in which city you are now? He looks 100% oriented. Sab pata hai usko kahan pe khada hai wo. He looks 100% oriented. But when he appears to be mentally confused, after head trauma, if a patient came to your hospital, you are wearing white coat, he is asking, hey, are you a chef? Oh my God, what kind of shopping mall is this? No lighting, no music. Basically, disoriented to time, place, and person. Mentally confused, I will give him 4 marks. But if you ask him any question, what is your name? He's saying what? I live in Andhra Pradesh, Mark Zuckerberg, Facebook, Instagram. Inappropriate words. Basically, not normal as per the situation. Or if patient is abusing the doctor, gali de raha hai, right? You will give him only 3 marks. But whatever patient is saying, you are not able to understand incomprehensible sound, you can give only 2 marks. You ask him, what is your name? He will say what? My name is... Incomprehensible sound which you cannot understand, only 2 marks. No sound at all, 1 mark. Here maximum score you have given 5, minimum score you have given 1. Now motor response I want to see. Whatever I'm asking my patient to do, he is obeying my command. If he can obey my command 100% normally, whatever I'm asking him to do, okay, he is doing it. I will give him 6 marks. Okay. After that, suppose if I'm going to apply a pressure over here, over the nail bed, I can ask him, where do you feel the pain? Where do you feel the pain? If he can localize the pain exactly this side, or if I can, you know, if I can bite like this, ऐसे करके pinch किया यहाँ पे, back पे, anywhere. If he can localize the pain, 5 marks. Okay, fine. Suppose if I'm going to apply, suppose if I'm going to give him pain like this, after that, if he is like, suppose if he is going to withdraw from the pain, normal withdrawal, normal withdrawal, flex to withdraw from the pain, I will give him 4 marks. But suppose the patient is in this position now, exactly, like he is not able to move, right? No, he's not able to move like this. When I'm giving him, like suppose if I'm going to apply pressure over nail bed, no, when I'm giving him pain, after that he is doing what, like this, somewhat like this, right? So this is called as what? So this is called as abnormal flexion, But when I'm giving him pain, then he's like he's keeping his hand like this, This is called a what? Abnormal extension. This is called a what? Abnormal flexion. Like here at the back side, this is called a what? Abnormal extension. So that's why, remember here, this is called as decorticate rigidity, and this is called as decerebrate injury. Right? One is called a decorticate, another is called a decerebrate. So remember here, like up to here, this is also okay. But if there'll be a decerebrate, actually, no, that will be very, very dangerous. Okay, fine. Suppose if there is no movement at all, so I will give him, like, see, abnormal flexion, only 3. Abnormal extension, like only 2 marks. Right? No response, no movement in the body, 1. So maximum here I have given 6, minimum 1. EVM machine, remember, E4 maximum, V5, M6, 4, 5, 6. So can you answer me in total how much is the Glasgow score? In total it will be 15. Minimum, how much is the minimum? Minimum score will be only 3. Remember, GCS score will never be 0. GCS score will never be 0. So minimum it is only 3. When will you declare a patient in coma? Can you answer me? When will you declare a patient in coma? When GCS score will be equal to or less than 8. When will you intubate the patient? When would you like to intubate the patient? When GCS score is equal to or less than 8. All these points are clear to everyone? Yeah, GCS score is very, very important. Remember, one more thing is added. Suppose the patient is intubated. So you cannot, so their verbal response you cannot, so verbal response you cannot test. So remember here, if patient is already intubated, ventilated patient is there, no. So you have to write down V may NT. NT means, like NT means actually non-testable. Cannot test here. So this will be actually 0. So over or for GCS score, best is motor response. If remember here, if GCS score is 14 or 15 with the loss of consciousness, it is mild. Okay. With or without, you can say with or without. Like suppose, see here, okay, with or without. Okay, so it is mild. But like a score will be a 9 to 13, moderate. Less than 8, it is severe. Whenever there will be head injury, can you answer me? If there will be head injury, yes, like investigation of choice is called as, see, investigation of choice will be what? NCCT. My question to you is that, like if there will be acute head, suppose if there will be acute head injury, do you think you can do MRI? Answer me yes or no. Do you think you can do MRI? MRI can be performed, yes or no? MRI should not be done. See, because see, like one MRI will take half an hour to 1 hour actually, no? So this is actually time consuming. In the same manner, when I talk about CECT, no? Even in a case of the CECT, if there will be acute head injury, fresh bleed will be there. One is the fresh bleed. After that, Before you inject any contrast, you have to repeat a renal function test. You have to see the level of the creatinine. If level of the creatinine is more than 1.5, injection of any contrast will be contraindicated. So this will also be time taking here. That's why in a case of acute head injury, remember a same like X-ray, NCCT. NCCT is the investigation of choice. This is the investigation of choice. Okay, one question to you. Suppose if there will be history of fall. Suppose if there will be history of fall. History of fall from 5th floor. But it was a rainy season. A young boy who was standing on the 5th floor, after that he fell down. Because of rainy season, he did not get any injuries over the body. He did not get any injury over the body. But after history of fall, no, he's only smiling. He's only laughing. So his father has brought to you, okay, Dr. C, after history of fall, he is only laughing. My question to you is that, what is the next line of management? Option number 1, admit him and keep under observation. Option number 2, you will also smile and discharge the patient. Option number 3, you will ask some questions and you will take a decision to perform CT scan. Bolo. Answer. You will ask some questions, right? You will ask some questions for sure. And you will ask some question. Can you answer me? What are the relevant questions you are going to ask so that you can take a decision to perform CT scan or not? What are the indications of CT scan of head? Number 1, you have to ask him, did you had loss of consciousness? Did you had a loss of consciousness? First of all, did you had, like even for a few seconds, did you had a loss of consciousness? Loss of consciousness. Okay, fine. Okay, fine. So after that, you ask the patient here, did you had a seizure or convulsion? Did you had a seizure or a convulsion after history of fall? Okay, did you had a seizure or convulsion after history of fall? Did you had a nausea or vomiting for more than one time? Did you had nausea or vomiting for more than one time? Okay. Number 4, if there will be open skull fracture, if there will be bleeding from the nose or ear, open skull fracture, yes, you have to do. And if there will be a Glasgow coma scale less than 40, no. Remember here, as per a nice guidelines, if any of this is present, no, CT scan is must. CT scan is must. Now, see, intracranial hemorrhage, I am sure you know about intracranial hemorrhage. That, remember here, how you are going to understand like intracranial hemorrhage here, right? Okay, suppose if this is a skull, this is a skull, and this is the pia mater, arachnoid mater, dura mater, PAD. After blunt trauma, after any trauma, if there will be rupture of any blood vessel over here, this will be causing what? EDH, extradural hemorrhage, epidural. So there will be damage of middle meningeal artery most commonly. If there will be bleeding over here, rupture of blood vessel under the dura, it will be called as subdural hemorrhage. So there can be rupture of bridging veins. If there will be bleeding under subarachnoid, okay, this will be called as what? Subarachnoid hemorrhage. Subarachnoid hemorrhage here. Okay, so like mostly this will be due to rupture of AV malformation, aneurysm, right? So remember here, so after subarachnoid hemorrhage, yes, there will be a worst headache of the life. See the thunderclap headache. I'm sure all these you would have learned in anatomy also, neurosurgery also, forensic also. And a forensic also, where we have learned lucid interval can be there. Can you answer me? Lucid interval. What is a lucid interval? This will be considered as a period of consciousness in between two periods of unconsciousness. It is called as a lucid interval. Lucid interval will be seen in EDH. Lucid interval will be seen in EDH, right? EDH, it will be seen here. This one point is also clear to everyone. Now, the question is that how we are going to manage these patients. Okay, how we are going to manage this patient. Extradural hemorrhage, yes. Remember here, what will be the CT markings you are going to see here? If you can see, shape of hematoma is like idli shape or biconvex shape in EDH, biconvex shape. Biconvex. Middle meningeal artery, lucid interval. So this will be having actually very good prognosis. Remember here, mortality rate is less than 1% here. So there'll be good prognosis. You can do burr hole. You can evacuate the hematoma. But subdural hemorrhage, no. Shape of hematoma is like this, like a banana, you can say, or you can say what? Concavo-convex. So this can be seen due to high velocity trauma, rupture of bridging veins. There can be loss of consciousness just after the trauma. Okay, here urgent craniotomy is needed right now. You have to operate as soon as possible, and the prognosis will be poor here. Mortality rate will be 40%. Okay, like even see what will be the shape of hematoma in a case of subarachnoid hemorrhage. Subarachnoid hemorrhage. Please remember here, subarachnoid hemorrhage. Subarachnoid hemorrhage. Shape of, remember here, shape of hematoma will be like a star shaped, right now, like a star shaped or a stellate shaped. This much point is clear to everyone. Very easy to understand. All these points are clear. Remember here, for a burr hole, this is the instrument. You should be able to recall here. Yes, you should be able to recall. All these points are clear to everyone. But after head trauma, we have to decrease like ICP, intracranial pressure, as soon as possible. So how to decrease intracranial pressure? First of all, you can keep the head up to 15 to 30 degree. Mannitol is the drug of choice. Okay, when BP is normal, yes, furosemide can be given. Remember here, for seizure prophylaxis, no, you can use phenytoin. And to sedate the patient, this will be the question where examiner would like to trap you. Are you going to use benzodiazepine? No. Remember here, benzodiazepine will be causing what? Respiratory depression. So to sedate the patient, we are using barbiturate here. If you can see suspected, open skull fracture, where you suspect there can be severe infection, antibiotics, please add. Okay, which we should not be using. Steroid we should avoid. Lumbar puncture we should avoid. Herniation can be there. Remember here, like even if there'll be like need of CSF, no, you can do what? External ventricular drainage. This much point is clear to everyone. One important point which I have taught you that, like one important sign, photo I have not added here, but you should know. If there will be fracture of anterior cranial fossa here, accumulation of blood will be under the eye here. This is called as which type of black eyes? Can you answer me? This is called as raccoon sign. Raccoon eye sign. Very easy to understand. This is called as raccoon eye sign, black specks, or this is also called the panda's eyes, black eyes. If there will be fracture of middle cranial fossa or basal fracture, there will be accumulation of blood just behind the ear, here over the mastoid. You can see bruises around the mastoid. That is called as which sign? Raccoon sign we have seen, but here it will be called as what? It will be called as, remember here, this will be called as battle sign. Remember all these points we already have learned in forensic also, but important. We have learned about head injury. Now abdominal trauma. Remember here, these days we are using EFAST. EFAST means what? Extended fast. Earlier we were using only FAST. FAST means focused assessment sonography for trauma. So 4 places we used to see here: right side liver, left side spleen, and the upper epigastric, and lower actually the pelvic part. Fast. But now we are using extended fast, like extended fast. We can, so here remember here, we can see here, we can diagnose if there will be any pathology, like we can check lungs also, right and left lungs also. Okay, even the pneumothorax can also be diagnosed. Okay, now remember here with EFAST. Remember here, why EFAST? Always keep in mind, whenever there will be blunt trauma, can you answer me? Whenever there will be blunt trauma over the abdomen, okay, can you answer me? Most common organ to be damaged in a case of blunt trauma, that is a spleen. Most common organ to be damaged in a case of, like in a case of a stab injury penetrating, liver. Liver. Okay, fine. So even after blunt trauma, if patient looks full, like if patient looks stable, if patient looks stable, or even if patient looks unstable, if they are going to ask you, remember here, like if they are going to ask you, what is the investigation of choice? Investigation of choice will always be E-fast. Fast is always the first. Fast is always the first. But if patient looks stable, patient looks stable, and when you have performed a fast, you did not find any accumulation of blood, then what is the gold standard test? CE-CT abdomen. CE-CT abdomen, because there are some limitations of ultrasound. There are some limitations of E-fast. Remember here, E-fast will not be able to detect if bleeding is less than 100 ml. If there will be a stab injury, if there will be the penetrating trauma over the bowel injury shaft, ultrasound will not be able to detect. If there will be retroperitoneal injury, E-fast will not be able to detect. For that, CE-CT will be the gold standard. CE-CT will be the gold standard. Easy to understand. All these points are clear to everyone? Right. Remember here, so how do you diagnose pneumothorax? Seashore sign, if you can see seashore sign, if you can see seashore sign, when like air is coming up and down, seashore sign means normal. This is a normal. But if you cannot see movement of there, no, same like the barcode sign or a stratosphere, then it, so basically if there will be a barcode sign, or a stratosphere sign, it means pneumothorax. Seashore sign means normal lungs. Remember here, all these are very, very important. One liner question, most common injury after the blunt trauma, spleen and then liver. See, after that, the penetrating trauma, liver first. After the gunshot over the abdomen, a small bowel. Seat belt injury, we have learned in forensic also, mesentery only. Now, suppose if there will be abdominal trauma, when remember here, if a blunt trauma is there, ABCD is first. You have to do E-fast. If patient looks CCT, like if patient looks stable, then CCT. And suppose if patient is unstable, no, shift the patient to OT as soon as possible. Laparotomy. But if there is a case of the penetrating trauma, now remember here, there is no role of E-fast in the penetrating trauma. So don't waste your time there. ABCD is must. But after, if patient looks stable, you have to do local wound exploration. But remember, if patient looks unstable, like if bowel is out, right? Now, suppose if the bowel out, or even if there will be the peritonitis, even the omentum, like see, suppose if there will be evisceration, anything is coming out, no, shift the patient to OT as soon as possible. Shift the patient to operation theater as soon as possible. Laparotomy as soon as possible. Okay, all these points are clear to everyone? Yes. Liver injury, we should understand here that liver injury, right? Liver injury may, now see, remember, we have the grading of the liver injury. See here, first, second, third, fourth and fifth grade. Remember here, like when the laceration will be less than 1 centimeter, or if there will be hematoma collection here, right? See, like hematoma collection under the capsule less than 10%, grade 1. Laceration size is 1 to 3 centimeter, hematoma collection 10 to 15%, grade 2. Laceration more than 3, hematoma more than 50%, vascular injury with bleeding into the liver parenchyma, inside the liver bed only. Okay, grade 3. When there will be parenchymal disruption. Now, when liver is becoming black due to lack of blood, vascular injury. Now, see, remember, when the bleeding is going inside the peritoneal cavity also, grade 4. Right? Suppose if there will be disruption more than 75% of the liver parenchyma, and near, like suppose if there will be juxtahepatic, like inferior vena cava injury, grade 5. Remember here, management of liver injury. If patient looks stable, no, 90% patient will become normal even after the conservative management only. 90% patient will improve. But if patient looks unstable, 4 P's. One is called the Pringle maneuver. I'm sure you would have learned. One is called the Pringle maneuver. Where, so the question they are asking, this kind of question they're asking, in a case of the Pringle maneuver, where we are going to ligate actually, which we are going to block. Can you answer me here? We are going to ligate what? Remember here? So this is what? We are going to ligate epiploic foramen, or you can say what? Hepatoduodenal ligament. We are going to we are going to block. One is called the Pringle maneuver. Second, you are going to plug the liver. You are going to plug the liver with omentum. Omentum, nearby omentum you get, you are going to plug it. You are going to push. You are going to push the liver. You are going to push the liver here posteriorly, and after that you are going to pack around the liver with any pad. So what are the 4 P's? One is called the Pringle. One is called the Pringle. After that, plug, push, and pack. Pringle. Remember what are the 4 P's? One is called the Pringle maneuver, plug, push, and pack. Remember here. Now they are asking the question, whenever you are going to use the Pringle maneuver, this will be blocking. So this will be blocking the bleeding from only of hepatic artery and portal vein. So suppose if you are getting a patient of the liver laceration, blunt trauma or sharp trauma, like liver laceration cases there, if you are going to block, if you are going to occlude here, if you are going to perform the Pringle maneuver, like suppose if the bleeding will be stopped, it means there was actually rupture of, like, see, it means what? Bleeding was either from hepatic artery or portal vein. But even after Pringle maneuver, still bleeding is going on. Now the bleeding is from hepatic vein. Now the bleeding is from hepatic vein. All these points are clear to everyone? Right. So remember, see, for the liver, I'm telling you, see, the Pringle maneuver repeatedly asked question. Now, liver injury here. After the, see, actually, this is what? Like, this is not liver, this is actually spleen. Right now, this is actually what? Spleen. Spleen. Okay. Now, we are going to learn about spleen injury. See, always keep in mind, most common organ to be damaged in a case of the blunt trauma is a spleen. Laceration is less than 1 centimeter, grade 1. And hematoma collection less than 10%. Laceration 1 to 3, grade 2. Okay, fine. Grade number 3, laceration more than 3, hematoma more than 50%. Remember here, grade 4, see here, now there can be the parenchymal disruption for more than 75%, but bleeding will be inside the splenic capsule. But grade 5, remember, shattered spleen here, and bleeding will be there inside the peritoneal cavity. Remember here, stable patient, most of the patient will improve after conservative management only, no surgery needed here. Remember here, but suppose if there was a blunt trauma, if there was a case over the splenic injury, before I discharge the patient, I have kept the patient with the conservative management only, under observation only. But before I discharge the patient, CCT is must. CCT abdomen is must before discharging the patient. Because remember here, there can be development of false aneurysm, which will appear like which is called about splenotumor blush. So before we discharge the patient, if we can detect splenotumor blush, we have to do angioembolization. We have to do angioembolization. But suppose without CT scan, if you discharge the patient and patient had developed a splenotumor blush after reaching home, if there will be rupture of this, there can be severe bleeding that can be dangerous for the patient. If patient looks unstable, remember here, first, second, and third grade, only we can wrap the spleen with, with omentum. Okay, this is called splenography. But grade 4 and 5, we have to remove the spleen. We have to remove the spleen. This much point is clear to everyone. We have to remove the spleen, splenectomy. Stab injury, remember here, penetrating trauma means if there is only one entry wound, entry plus exit wound, both are there. This is called the perforating wound. Always keep in mind. If there will be penetrating trauma, simple thing is that unstable patient, we have learned it. I think we have learned whenever there will be anything is coming out, operate the patient as soon as possible. But a stable patient, first of all, local exploration. Rule out if there is any peritoneal breach. If there will be peritoneal breach, then CCT abdomen is must. CCT abdomen is must. right? Suppose even after that, if patient is developing, like suppose if the patient is developing peritonitis, operate the case. Suppose if there is no peritoneal breach, discharge the patient. These days, like these days for the stable patient, no, remember here we are doing diagnostic laparoscopy. We are going to insert a probe. After that, we are going to check if there is any, like some other kind of bleeding or not. So that is what diagnostic laparoscopy. Now, if there will be, remember here, retroperitoneal hematoma, grade 1, 2, 3, please remember this is an important image for your exam. Here I am showing you, like here I am showing grade 1, like here I am showing grade 1, grade 2, this is grade 3. This is grade 3. So like suppose here, see here, grade 1, 2 and 3. Grade 1, 2 and 3, what does it mean? Remember here, if there will be retroperitoneal hematoma, no, if there will be any rupture of aorta or inferior vena cava, this is zone 1, central mein zone 1. But if there will be damage of the right and left kidneys, renal injuries, zone 2. 90% patient will improve only with the conservative management, without any surgery. But if there will be any rupture of inferior vena cava or aorta, shift the patient to OT as soon as possible. And see here at the lower part, grade number 3, see there can be the rupture inside the pelvic hematoma. Remember here, so mostly we are using a pelvic binder, and mostly we avoid surgery here, because see here, if you are going to operate that time, no, that can lead to more bleeding. So remember here, if there'll be bleeding in the central part, mostly what, inferior vena cava here or aorta, zone 1, you can zone 1 central, zone 2 right and left kidney, zone 3 below, like in the pelvic region. Zone 4 is also added. This is juxtahepatic, like inferior vena cava injury. And what I am showing you here, no, this is called as the pelvic binder here. This is called as the pelvic binder. This can be your image-based question. Now, suppose zone 1, if there will be damage in the inferior vena cava, if there will be damage, no, how to operate for that? There are two maneuvers here. One is called the Mattox maneuver for aorta, and one is called the Cattle maneuver for inferior vena cava. What does it mean? What does it mean? When I talk about Mattox, see here, left side, say left visceral medial rotation if I'm going to do, so that I can expose the aorta and I can operate peacefully. But what about the Cattle maneuver here? Right side, say right side visceral medial rotation, so that I can see inferior vena cava very clearly and I can operate. So remember here, Mattox and the Cattle maneuver. Mattox and the Cattle maneuver. All these points are clear. Now, if there will be abdominal compartment syndrome, when it can be there, whenever there will be abdominal compartment pressure, when it is more than 20, mmHg, remember here, we have to do laparoscopy. Or either like we can do what? We can give incision from here. We can give incision from the sternum to the pubic part here, right? After that, we are going to keep a bag. This bag is called as a Bagota bag. Or we can use a vac therapy. Okay, fine. After a few days, like when patient will be stable, and after that we can reseal it. So remember here, abdominal compartment syndrome, that is also an emergency. Now, after the trauma, like especially in a case of road traffic accident, suppose if the patient was sitting on the front passenger seat or over the driving seat, okay, seat belt injury. When after the trauma, if severe pain will be there, pain is radiating towards the scapula. Remember here, fluctuating BP is there, right? No, and on X-ray wide mediastinum, right? So remember here, like if patient looks stable, no, CCT, where you can see the tennis ball sign. Remember here, this is a case of what? Aortic dissection aneurysm. This is a case of aortic dissection aneurysm. If patient is actually unstable, which test you have to do here? You have to do the transesophageal echocardiography. But if high BP is there, first of all, short-acting beta blocker, you are going to use ismolol and shift the patient to operation theater, and you have to do what? Dacron grafting. I hope all these points are clear to everyone. Now, read this question and can you answer me? Can you answer me here? Read this question and can you answer me here? Which anatomical structure is to be repaired first in a case of the crush injury? First structure to be repaired. Can you answer me? First structure to be repaired. Yeah, most of you might be marking. Most of you might be saying what? Most of you might be saying artery because you want to stop bleeding. No, if you see this kind of, if you see this kind of the crush injury, no, if you can see this kind of the crush injury, no, remember here, where you can see rupture blood vessels, vein, arteries, nerves, skin, and even, you know, like if you can see, like suppose if there will be what fractured bones also. Overall, suppose if there will be fractured bones, no, fractured bones will be having spikes like this. Even if you are going to repair the artery, no, that can damage your artery again. Okay, so you want to stop the bleeding, no, you can use artery forceps to stop the bleeding. You can use artery forceps like mosquito, right? Okay, fine. Remember here, you have to repair hardest structure first. Bone is first. Bone is for fix the alignment first. After that, you have to repair the tendon, then artery and all. So remember here, sequence of anastomosis, number 1 is bone. Number 1 is bone. After that, extensor tendon, flexor tendon, then you have to repair artery, vein, nerve, at last skin. So sequence of anastomosis is important. Bone is first. Bone is first. Bone is first. Remember here, like suppose if early arrival of the patient is there, then you have to repair vein first, but late arrival mein hai, okay, then you have to repair artery first. All these points are clear to everyone. Now, before this surgery NPO order, please remember here, there is an update. There is an update here for adult patient for nil per oral. For nil per oral. For adult patient, stop solid 6 hours before this surgery and stop clear liquid 2 hours before this surgery. But for the pediatric age group, see the clear fluid 1 hour before the surgery, mother's milk 4 hours before the surgery, and solid food 6 hours before the surgery. Shaving before the surgery should be done or not? This is old question, FMG question only. Remember, ideally, shaving should not be done. Shaving should not be done. Okay, fine. Suppose if shaving is needed, then please remember here. Remember, ideally we can do in advance, but mostly remember here, we should not be using razor. We should not be using razor. Please remember here, not the razor, not the razor. Remember here, shaving before the surgery, not the razor. You have to use only surgical clipper. Same like a, see here, same like a clipper only. Please remember here, only surgical clipper. This is more than enough to, like see here, this is more than enough before the surgery. All these points are clear to everyone. Now next topic we are going to complete, like aaj ke liye we can do only burns. After that I will leave you people. Remaining topic like hernia, breast and thyroid, GI surgery, urosurgery, all these we are going to do on 28th of December. 28th, after 2 days. How much we have learned today? Please have revision at least for one time. Now burns, remember here, first of all, degree of burns. Degree of burns, like if there will be involvement of only epidermis, if there will be involvement of only epidermis, superficial first degree burn. If there will be involvement of dermis, second degree burn. If there will be involvement of burns up to subcutaneous layer, third degree. And when there will be involvement of muscles, bones and the tendons, right, muscles, bones and all, then you can say fourth degree burn. Second degree burn is further divided into superficial burn and deep burn. Superficial and deep. When there will be involvement of epidermis and the upper layer of dermis, it is second degree superficial. When there will be involvement of lower layer of the dermis, no, it is called a second degree deep. Remember here, all superficial burns are painful. All deep burns are painless. Remember like this. Very easy to understand. All deep burns are painless. All deep burns. But as per the new update in belly, actually what they have mentioned here, remember here what they have mentioned. Suppose if we are getting a patient of the burns, how to understand superficial and deep. So first degree, second degree, third degree, fourth degree. So mostly they are not following it. So they said after wearing gloves, if you are going to touch the wound, if there will be slippery, is there superficial. If it is not slippery, it is deep. Simple. Okay. Now remember, redness, pain, blister formation will be there. Now All superficial burns are painless, all superficial burns are painful, deep are painless. Remember like this. Now, first degree burn like sunburn is there, hot iron. So here you can see only superficial. This can heal without any scar formation. Without any scar formation within 7 to 10 days only. But second degree burn, which is also called a partial thickness burn, remember here you can see the formation of blister. In the second degree burn, you can see formation of blister. Okay. Now, when there will be involvement of subcutaneous tissue also, yes, it is called a third degree burn. This will be healing by forming, like scars. Like you can say there can be a neck contracture, axillary contracture. Now, fourth degree burn, when there will be burns up to the muscles and all, fourth degree burn. All these points are clear to everyone? Fourth degree burn. Now, see what are the causes of death in burns patient. On the spot, if patient is going to die, see the cause of death will be asphyxia. Cause of death will be asphyxia. Right? Asphyxial death, there will be inhalational burns. Early period, within 1 or 2 days, you can say hypovolemic shock. Late stage sepsis. Overall, most common cause of death is sepsis only. Now, how we are going to manage the case of burns? First of all, can you answer me which patients are supposed to be admitted? When a patient is having total body surface area, of more than 15% in adults, more than 10% in a child, please admit. Like even if these are actually superficial, but all deep burns, please admit. If there will be burns over face, please admit. Burns over face, because there can be inhalational burn, patient can die on the spot. If there will be burns over any joints, major joints, please admit. Okay, burns over joints. If there will be electric burn, acid alkali burn, please admit. If there will be burns over genitals, please admit. If there is a psychiatric patient with burns, please admit. Psychiatric. If there will be a destitute patient means what? Who does not have any family member, who does not have any attendant. Destitute patient, right? From the roadside, if the police has brought him, please admit. Now, one question to you is that, suppose if you are working in hospital, you have only one bed left. But at the same time you got actually 3 patients. Patient A, patient B, and patient C. Patient A was having 30% burns over upper limbs, lower limbs, over the trunk. Patient B was having 35% burns over upper limbs, lower limbs, anterior part, and the posterior part of chest. Patient C was having only 5% burn, but burns was there over the face. Can you answer me, if you have only one bed available in hospital, only one bed, can you answer me which patient will you admit? A, B, C? Bolo, which patient will you admit? Now? Remember here, you have to admit the patient. Yes, you have to admit him. Face burn, right? Because see here, this can lead to what? Inhalational injury. Patient can die on the spot here. All these points are clear to everyone? Very easy to understand? Yes. Now, how to calculate the percentage of burns? Wallace rule of 9, most rapid technique, but it is not so much accurate. Most accurate technique is Lund and Crowder's chart. If there will be patchy burn, we can use rule of palm. We can use the rule of palm. See, patchy burn is here, backside like that. So what we do, we take a white paper, we keep the hand of the patient over there, and after that we are going to tear the paper exactly at the size of the palm of the patient. One palm is equal to 1%. One palm is equal to 1%. One palm is equal to 1%, right? So Wallace rule of 9, what is Wallace rule of 9 here? This is very easy to understand. Suppose if I'm making head and neck, and this is anterior part of chest, this, okay, and this is a leg, this is hand. Okay, fine. So remember here, rule of 9 is what? For adults, head and neck is equal to 9%. Right upper limb is equal to 9%. Left upper limb 9%. Now, only the anterior part of chest 9% and the posterior part of chest 9%. At the same time, see anterior part of abdomen 9%, and see the posterior part of abdomen, the back side, that is also 9%. Right thigh is a 9%, right leg 9%. Here also 9%, 9%. So this is actually 99. 1% is genital. 1% is genital for adults. For adults, it is like this. It is called as a rule of 9. It is called as a rule of 9. But this is somewhat different in. This is somewhat different in the. See, this is somewhat different in the pediatric age group, because of, see, different sizes of, different ratio of the size of head and neck in a child, and see there will be a smaller size of the lower limbs, at a smaller size of the lower limbs. So remember here I have viscosity. See, for the adults, head and neck 9%, but a baby will be having ratio head and neck will be bigger here. So this is 18% in a child. 18%. Here same, here same, here same. But lower limbs also here, see here, as per the ratio, lower limbs will be smaller here. So like in total, in adult, it will be 9 plus 9, 18% here, 9 plus 9, 18% here. But in a child, 14%. Remember like this only. Head and neck total 18%, lower legs 14%. This much point is clear to everyone. Very easy to understand. All these points are clear to everyone, right? Chalo, fine. This much point is clear to everyone. Now, how to calculate that I will teach you. Lund and Browder chart. See, this is actually, we have a big chart, most accurate. Big chart is there. But remember here, like if you have to calculate a Wallace rule of 9, like almost level of the question, you can solve with Wallace rule of 9 only. Wallace rule of 9 only. This much point is clear to everyone. Now, can you answer me here? What is the fluid of choice in a case of burns? First 24 hours, RL, Ringer's lactate. But if there will be a pediatric age group with burns, no, we have to give maintenance also, no? So we have to give DNS there. The colloids can be given. Remember here, we can use albumin. We can use albumin. Remember here, we can use albumin. We can use the colloids after 12 hours. After 12 hours. Remember why RL is the fluid of choice? Can you answer me? Why RL is the fluid of choice for the burns, like in the beginning phase? Because after burns, no. After burns, remember here, after burns, what can happen there? No, after burns, there will be severe release of the inflammatory markers. And even for the blood vessels, there will be leakage, severe leakage will be there. So in the beginning itself, if you want to give colloid to increase, to increase the volume, expand, if you want to expand the volume, right? No, see here, RL is light molecular weight and cheap. But see, when I talk about colloid albumin, that is actually expensive also, high molecular weight. So in the beginning, if you want to give albumin, no, there will be leakage. Leakage will be there, you can waste the albumin. So that's why, first of all, always we start RL only, and only after 12 hours, okay, we can start colloidal solution. Now, how to calculate how much fluids to be given? First of all, see this question, and after that you try to answer. See this question and you try to answer. First of all, you see this one. After that, you try to answer. 70 kg, 70 kg, brought to the hospital with burns over his chest, abdomen, right upper limb, right lower limb. How much fluid should be given to the patient in first 8 hours? Okay, so can you answer me? First of all, can you answer me? How much is the total body surface area? How much is the total body surface area? All of you, can you answer me? How much is the total body surface area? See, burns over his, यहाँ पे क्या है कि burns over his chest and abdomen. So this will be 9 plus 9. Right upper limb. Right upper limb 9%. Right lower limb, whole lower limb, right lower limb 18%. 18. Okay. So कितना हो जाएगा total? It will be 45% only. Total, this will be 45%. No. See, over the chest 9%, over the abdomen 9%, 9, 9, 18%. Right upper limb 9%. So ये कितना हो गया? Right, this will be 9% here. Right lower limb means whole with thigh and leg 18%. No, so this will be equal to 45% only. No, right, this will be equal to, yes, no, 45%. No, all of you are writing only 36%. How come? See, देखो, first of all, please understand, over his chest 9%, abdomen 9%. Right upper limb 9%. Right lower limb means what? Thigh and leg together. So 9 plus 9, 18 will be there. No, right? 18 will be there. No. So this will be 45% only. No. Is it a 45% only? No. Now, how to calculate fluid to be given? How to calculate fluid to be given here? First of all, we have to learn. See, this is actually, see, remember here, there is a confusion in this. There is a confusion in this here. There is a confusion. This is called as, see, when I talk about the Parkland's formula, no, when I talk about the Parkland's formula, 4 into percentage of burns into weight of the patient, into weight of the patient. Okay, but as per ATLS, remember here, burns is also an example of the trauma only. Burns will be the example of the trauma only. So what is the new update here? So remember, as per ATLS, now instead of 4, you have to multiply with 2. You have to multiply with 2 with the total body surface area and weight. Age of the patient is less than 14 years, multiply by 3. If there will be electric burn, multiply by 4. So if examiner has to ask as per the Parkland formula, modified Parkland formula, you have to multiply by 4. But if examiner is mentioning as per ATLS, then you have to replace 4 by 2. There should be no confusion. There should be confusion now. Very easy to understand. So suppose if I'm using modified Parkland formula in this case here, like, so I can calculate like this. No, I can calculate like this. 4 into 45 into 70. Right now 70 kg is the weight. Can you answer me here in total? एक बार बताओ, how much will be the total calculation over here? Yeah, so this will be equal to 12.6 liter. See, this will be coming into the milliliter. No. So like, see here, how much fluid to be given to a burns patient in first 24 hours. Remember here, how much fluid to be given? In first 24 hours, that we can use. Right now, that we can use with the help of modified Parkland's formula or ATLS. Examiner has to mention that. Easy to understand. All these points are clear to everyone. So like see, remember here, within 24 hours, you have to transfuse. You have to give 12.6 liter of Ringer's lactate. But in first 8 hours, half of the calculated fluid. Next 16 hours, half of the calculated fluid. So in the first 8 hours, I have to give 6.3 liter. Next 16 hours, I have to give 6.3 liter. 6.3 liter. This much point is clear to everyone. Remember here both are different formula. One is called a Parkland's, another is as per ATLS. Examiner will mention, mostly examiner will mention, okay? Or suppose if examiner is mentioning as per updated, so you have to multiply by 2 only. This much point is clear. So how much fluid to be given? Remember here, first 8 hours, half of the calculated fluid. Next 16 hours, half of the calculated fluid. On day 2 also for next 24 hours, half of the calculated fluid. All these points are clear to everyone? समझ में आ गई बात? Very easy to understand. Right. Now, what can be the complication after burns? Yes, there can be the contracture here. So if you see this kind of the contracture because of what abnormal collagen here, no, then you have to do what? Excision, releasing, and then you have to do skin grafting. Axillary contracture, you can see here. Yes, no, axillary contracture, same, you know, like release and grafting. Marjolin ulcer can be there, non-healing ulcer. Okay, I hope all these points are clear to everyone. But my question is that, suppose if you are getting a patient after Diwali pataka, you know, after Diwali firecracker, like fresh burn is there, right? First of all, with normal room temperature water, you have to do the cooling, right? No, and please remember here, you have to keep the wound fully dry. You have to keep the wound fully dry. If there will be the primary burn, superficial burn, so remember here, no need to apply a dressing. There are 2 types of the dressing here. One is called as open dressing. Another is called as closed dressing. Open dressing means what? Like same like face, you have to keep open. And after when you are going to apply a bandage, that is called the closed dressing. Okay, that is called as what? So what is the ointment of choice? We are using what? Silver sulfadizine only. Silver sulfadizine. So first degree burn, no need of using any bandage. You keep it open. But second degree, blisters will be there. Remember here, you have to change daily dressing. And you have to apply a topical antibiotics. Remember, these days we have started using for the superficial, we have started using a collagen sheet also, collagen sheet, but for deep, we have to do skin grafting. Okay, see, in case of the third degree burn, no, so there can be a formation of hard leather-like structure that is called as eschar formation. That can lead to compartment syndrome. So we have to remove that, we have to cut that out as soon as possible. That is called as what? Escherectomy. Sclerotomy, after that skin grafting. Okay, skin grafting. All these points are clear to everyone, right? So we have completed up to burns. We have completed up to burns. We are going to stop here. We are going to meet at the same time. We are going to start at 5 p.m. on 28th December. After that, we are going to complete hernia, breast, thyroid, GIT, uro, and all the topics. Okay, so I think so. So today we have learned for 7 hours. 7 hours we have done today. Out of these, I'm sure 8 to 10 questions. 8 to 10 questions you can get from here. 8 to 10 question. Remaining 8 to 10 question or more than the 10 question, we are going to learn from the next day topic. So we are going to stop here. Thank you so much, all of you, for your patience. Thank you so much. And I wish you all the best. Okay, chalo then. Bye bye. Good night.